A working laryngoscope and EG tube size is divided by 4 plus 4. So 4.5 and 5.5 millimeter EG tube size, right? So that's for airway and breathing, and get the pulse oximeter ready as well and the other monitors. So for circulation, some few large bore IV cannulas and an interosseous needle as well. And we need IV adrenaline, 1 in 10,000, 0.01 ml per kg, so 0.15 ml. IV normal saline fluid bolus, 20 ml per kg, which is 300 ml, and IV 10% dextrose, 3 ml per kg, so roughly about 50 ml. And we need some IV antibiotics ready as well. Cefotaxime, 50 milligrams per kg, that comes to 750 ml of IV cefotaxime. And Sanjiva, we also should be ready with the defibrillator in case, and 4 joules per kilogram, so 60 joules. So I think we are ready with the basic equipment.
Okay, so just as you finish, the ambulance comes in and they bring Nimal here.
Okay.
Hey doc, we got Nimal here. He's quite drowsy. Will you please take over the child first?
Nimal, is he responding?
He doesn't respond to, he doesn't open his eyes spontaneously, but
right.
to voice, yes.
Right. And is he, airway, is he breathing?
He's breathing and
Okay.
it's quite rapid. It's
Right.
about 40 per minute.
Right. So connect to the pulse oximeter while I do the rest of the airway. So respiratory rate is about 40 per minute. Right? Get ready with the oxygen. What is the air entry like?
Air entry is equal and
both sides?
there's no added sounds.
No added sounds. So what's the pulse oximeter reading?
So pulse oximeter
Okay.
says, as you can see, 89.
9%. So shall we put him some 10 to 15 liters of oxygen? Right. Yeah. Is the mask foggy?
Yeah, mask is foggy.
Right. Okay. So until we get the air, right. So after the oxygen, are we getting a pulse oximeter reading now?
Yeah, so with the oxygen, we can see it's still around, it has picked up to about
Right,
92.
92. Okay.
Yeah.
Right. So we'll go to the circulation. What about his peripheries?
Yeah, the peripheries are cold and there's a line of coldness as well
Right.
towards like the ankle.
Okay. Line of coldness is there. Yes. And Sefali, get ready with the IV cannula and stuff. What's the pulse? Can I feel a pulse?
Yeah, the peripheral pulse is very thready
Ready.
and
Rate is about
Yeah,
170 per minute.
yeah.
Capillary refilling 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000.
7 seconds.
7 seconds.
The cannula is in and there's some blood coming now.
Right. I will put the blood pressure pump also. So, Sefali, shall we take blood for full blood count, CRP, blood culture, electrolytes, blood sugar, and a blood gas? Right. So, have we sent the blood off now?
Yeah.
Yeah. Okay.
On its
So shall we give a fluid bolus since the circulation is poor? So 300 ml of normal saline fluid bolus, and I will also try another cannula.
Yeah, so that cannula is not in because its
Okay.
peripheries are very cold.
Right, but this is functioning at the
Yeah,
moment.
maybe you could try a central
Yeah.
one. Then.
Yes. Okay. Right. So
Yeah, that's it.
okay.
Yeah.
Right. So while Sefali is giving the fluid bolus, I will go back to the airway. Is he crying? Is he responding now?
He's kind of very quiet now
Quiet
and
now.
he doesn't respond to your voice now.
Okay. Mask is fogging as before.
Not very good really.
Right.
Respiration is kind of irregular as well. Yeah.
Okay. And the pulse oximeter reading?
It has dropped back
Dropped
to
back.
89.
Okay. So Sanjiva, while I assess the rest of the airway, can you get ready with the intubation equipment? Right. So air entry?
Air entry is good.
Okay.
I'm going at with 10 liters of oxygen.
Right. Okay. And with the pre-oxygenated nation, the saturation is coming up, I think. Yes, right.
Yeah.
Okay. So,
Bolus is
fluid
over.
bolus is gone. Shall we get ready with our induction agents, Stefani, for the intubation? Right. Yeah. So, Sanjeev, are you happy to do the intubation? Right. Okay. Okay. So, Stefani had given the induction agents, right? Okay. Right. So, you can get ready with the so size 5 millimeter in the tracheal tube. Right. Okay. Right. So easy. Okay. Right. So is the tube foggy?
Tube is foggy.
Right. And what about the air entry?
Air entry is equal both sides, and the chest expansion also
Better
symmetrical.
now, and the saturation is coming up.
Yeah. So you see over there
Okay,
it's
98%.
98. Yeah.
Right. So we are okay with the airway and breathing at the moment. I will go and reassess the circulation. Is the pole line better now?
Not really.
Not really.
Yeah.
Okay.
Still is cold
Right.
and
And the pulse
is still very
ready and 153.
Yeah.
1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000.
It's about 5 seconds.
Right. What about the blood pressure?
Blood pressure is at 80 by 35.
Okay. So still the circulation is poor. Shall we go ahead with the second fluid bolus? Right. So another 300 ml of fluid bolus is going on. Have you got the blood sugar?
Yeah, blood sugar is 4 millimoles.
Right. So blood sugar is normal. And what about the blood gas and the electrolytes and with the lactic levels?
Yeah, so it says blood gas pH 7.12
Okay.
and of PO2 36, PCO2 42 and lactate of 5.4.
Right. So there's a significant metabolic acidosis. I think we should carry on with our fluid resuscitation. In the meantime, I will check his D. So he's obviously drowsy with our. And what about the pupils?
Yeah, so the pupils are small and
Okay.
equally reacting though.
Right.
Yeah.
Okay. And so exposure-wise, is there any rash seen?
You can see a petechial rash that's
Okay.
appearing on
Right.
the lower limbs and
Okay,
the
so I
front
think we
limbs.
are dealing with probably a meningococcal sepsis sort of a condition. So I will reassess, right? So are you happy with the bag and mask? Okay, and the tube is foggy. Yeah,
Air entry is equal both sides and
Okay.
the chest expansion is good.
okay. The color has improved.
Yeah, color has improved.
Okay. So going back to the circulation,
Second bolus is over.
second bolus is over. What about the peripheries now?
Only slight improvement,
Slight
but still
improvement.
cold.
Okay. The pulse, do I feel it a little better now?
Yeah, slightly better.
Slightly better, and the rate has come down to about 138. So circulation is improving, but let me check the capillary filling. 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000.
Yeah, so it's about 3 seconds.
3 seconds, okay. And the blood pressure has come up to 95 by 45.
Correct.
Sepani, shall we have to get ready with another fluid bolus as well as inotropes, adrenaline. And shall we give a dose of IV cefotaxime as well? Since probably we are dealing with a meningococcal sepsis. So cefotaxime, first dose going in. Right, so Sepal is giving the third fluid bolus, and did you get the adrenaline infusion ready? Yeah, okay, right. Okay, so once more I will go for reassessment. Are you okay with the bag and mask? The tube is fogging and
And is good. Yeah.
okay.
So
No added sound.
no added sound. And chest
Right.
expansion
It's
symmetrical.
good, right? And the peripheries?
There is an improvement,
Improvement,
but
okay.
it's not
Right.
normal.
Okay, right. Pulse rate is 138.
Yeah,
And pulse volume is a little better now?
yeah, very much better.
Okay, right. And the blood pressure had come up to 95 by 45. 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000.
Yeah, it's 2 seconds.
Right, okay. So, Sanjeeva Simpal, so I think third bolus is over and you have started the infusion. Okay. So I think the child is stable now. So, but we can't keep him here. We need to get him transferred to the intensive care unit. So I'll get a call to the intensive care unit.
Yeah, so we have the intensive consultant here, Dr. Srilal De Silva.
Hello, sir. Good morning. I'm Delusha, Pediatrics Senior Registrar speaking from the emergency department. We had a 4-year-old boy who presented with features of septic shock. Background-wise, he had been unwell for the past 3 days with high fever and drowsiness. So on admission, his mainly circulation was quite poor. So we had to give him 3 fluid boluses. And then finally he stabilized with the inotropes. He is currently on the adrenaline infusion. And midway through during our resuscitation, his GCS dropped, so we had to intubate him. Currently he is intubated with effective bag and mask ventilation. And we gave a dose of IV antibiotics as well. His investigation showed a normal blood sugar, but there was a significant metabolic acidosis with high lactate levels. So, and with the history and examination also there was a rash, so I'm suspecting a possibility of a meningococcal septicemia. Currently his ABC are stable, so I would like to hand him over to the intensive care unit for further management.
Right, thank you.
So, Dilusha, so we have now completed the scenario.
Yes.
And what do you think the patient was having according to the signs and
So
symptoms?
from the background and my examination, I think the child probably has a meningococcal septicemia with septic shock.
Okay. So,
So,
and you correctly put the child to the ICU. So, the important thing here is, as you could see Dilusha doing several times, she was basically reassessing the child on the ABCD approach, and once resuscitation is done, she would reassess from airway, breathing, circulation, and also not forgetting disability and exposure. Okay, so we conclude this teaching scenario, and you'll be going to the next station now.
thank you very much.
डॉक्टर भाई लाम्या ने जुड़ा बालन नको आणि कावरूच नेते भाई लाम्या पुते पुते आणि पुते ऑक्सीजन
Face mask is done.
He looks 8 years.
Saturation. You are not seeing any expansion in the chest. Saturation is not recorded. Your monitor is there. Monitor is there. Saturation not recording. You can see in the monitor.
Large size.
No expansion in the chest. And your monitor is there on the blue. Patient is blue, very cold.
IV drugs will exhibit
No heart rate. So you are nearing 2 minutes.
Second dose. Tube.
Okay, 2 minutes up. Okay. Yeah, sinus pulse is there and color is now becoming pink and bagging is good. Okay, we will stop it there.
බලන්නකො මේ ළමයානේ ඉන්නුනා. මේ ડોක්ටර් මේ ළමයානේ ඉන්නුනා බලන්නකො. අනේ කවුරුත් නැත්නම් මේ ළමයා පුතේ පුතේ. අනේ පුතේ. ඔක්සිජන්.
face mask is done.
Face mask.
Why is it keeping our body?
8, looks 8 years.
Saturation.
You are not seeing any expansion in the chest. Saturation is not recorded. Your monitor is there. Monitor is there. Saturation not recording.
Heart rate.
You can see in the monitor.
Large size.
No expansion in the chest. And your monitor is there on the blue. Patient is blue, very cold.
IV drugs will exhibit
No heart rate.
Right. Good morning, everyone. Welcome to second day of the pre-intern training. Today session is conducted by College of Pediatricians, day 2. So I would like to invite Dr. Srila De Silva, Senior Consultant Pediatrician and the National Coordinator for Training in College of Pediatricians to address the meeting. Over to you, sir.
Okay, thank you, Roshan. So today's program is the second day of the pediatrics topics today. So we have few lined up today. And on the 4th of October, we'll be going through some neonatal topics. And after that, we'll be sending your MCQ to your email. And it's on the Survey Monkey format. You can have to answer that. And also we will send you a feedback form at the end of all the sessions. So once you have completed, then we'll be sending you the certificate, online certificate to everybody. So today's topic, the first one will be done by Dr. Ridma Jayaratnam, pediatric pulmonologist at Colombo South Teaching Hospital. And she'll be talking to you on hypoxia in COVID infections. Okay, it's over to Ridma.
Thank you, sir. Shall I share my slides?
Yeah, I can.
Do you see my slides?
Yeah, we can see your slides, Ridma, yeah.
Right, sir. Thank you very much. Good morning, everyone. So I'm Dr. Ridma, as sir mentioned. Thank you very much for information, sir. And so today I will be talking a little bit about the hypoxia in COVID-19 infection. If you have any doubts, you can always ask, even in middle of the lecture, that will be fine. Okay, so let's move. So during this 20 to 30 minutes, I will be discussing a little bit about what is the pathophysiology behind the COVID-19 infection, and then what are the mechanisms of hypoxia, and then how do you monitor hypoxia as a newly appointed house officers to our wards, and then what are the basic managements that you can start for the hypoxia in COVID-19 infection. So if you think of the COVID-19 infection, so it is sort of a very evolving disease over the last 2 years, and which was started from China, and then now it was reaching the Europe, USA, and then the Asia. So it was nominated as a pandemic disease. So apart from the epidemiology, so if you look at the clinical features of COVID-19, also highly evolving over this time, and it is very depending on the patient's age and based on their underlying risk factors, and it could range from totally asymptomatic patients to severe form of respiratory failure, and also multi-organ failure associated. You might have heard of pediatric involvement. We always talk about the MIS-C or the PMSTS. So there are variation in the clinical presentation. So these presentation could affect on the outcome of the disease of the patients as well. So if you look at this picture, so if you think of pediatric population, so less than 10-year-olds, and so ideally it is less than 18-year-old, but commonly if the children are less than 10-year-old, then they are asymptomatic, and 81% of them would have mild disease, maybe involving upper respiratory system, where you get only cough, cold, and low-grade fever, maybe a dry cough, and then it could develop into a pneumonia, and then about 14 to 15% of patients could go into the severe disease where they need ICU care and ventilatory support, and less than 5% of the patients would go into the critical disease where we define as having associated acute respiratory distress syndrome, acute cardiac injury, multi-organ failure. So if you look at this severe and critical disease, that is more likely to be developed in older people as well as who are having underlying disease. But we should remember, though we say it is mostly asymptomatic or mild disease is seen among the children, we had experience of having severe and critical disease even among children as well. So that is why it is important as pediatric intern house officers for you to have an understanding why the COVID-19 should be detected early, and then why you would monitor the patients for the hypoxia. So if you think of the pathophysiology, as you all know now, so it is transmitted through the airborne droplets, and then that will those droplets containing viral particles would present into the nasal epithelium, and then it is presented to the antigen presenting cells through the AC2 receptors. And then this virus is replicate in the nasal epithelium, which will be identified during your rapid antigen testing or the PCR testing when you do the nasopharyngeal or nasal swabbing. And then these viruses will migrate into the local lymph nodes as well as to the pneumocytes in the lungs, and then that will give rise to two clinical presentations. One thing is the cytokine storm, where this viral particle inducing a huge cytokine release from your immune system, which leads to destruction of the host cells. On the other hand, the virus will directly affect your cells and destroy your cells. Thereby, it can lead to diffuse alveolar damage. So ultimately, by both contributing the cytokine storm as well as direct viral destruction of cells can lead to the severe respiratory distress syndrome in adults as well as in children. So if you look at the time course of the disease, so initially the patient will inhale the viral particles and there will be a pre-symptomatic phase. And then once the virus starts replicating, so in the very initial phase, you will see the features of mild disease where you get only the upper respiratory symptoms or just low-grade fever. And then you can see towards the end of the first week, the children or the adults who are leading to moderate to severe illness. So, and yeah. And then if you, as house officers, if you think of this pathophysiology, so you can work out which investigation that you could do to detect the COVID-19 infection. So initially, even before the symptoms occur during the pre-symptomatic period, so you can get your rapid antigen test as well as the PCR test being positive. And then after about 1 week, your IgM antibody would be positive. And you should remember now when you interpret the PCR testing, now we go by the CT values. So when it is less than 30, so we thought it is highly infective, the virus being present in the in high titers. So it is important to have an idea about which test that you would need to request depending on patient's clinical presentation. So if you think of the clinical classification, so we have mild disease, moderate, severe, and critical disease. So in the mild disease, so these are the definitions. So they just have fever, sore throat, or upper respiratory symptoms, maybe vomiting, diarrhea, and then always their saturation remain within the normal range. So it is more than 94. And then when it becomes a moderate disease, so they have the features of mild disease and having a age-based, if you classify the respiratory rate, so they are tachypneic for their age. And then the same time, if you take a chest x-ray, there will be some evidence of COVID-19 infection. And there the saturation is based lying between 90 to 94% on room air. But there's no evidence of severe pneumonia, like where the baby being cyanosed, having severe respiratory distress with chest retraction, subcostal, intercostal recessions, and seizures. Also the radiographic infiltration, which I show you in a next couple of slides. But child does not have any other evidence of critical disease. So we have identified, the WHO has identified 4 major critical diseases where they can go into acute respiratory distress syndrome, or the multi-organ dysfunction syndrome, or they can develop acute thrombosis, and especially in children, this multi-inflammatory syndrome, so which we call as MIS-C. So it is important when you assess a patient to look at their symptoms and then the examination findings about their respiratory distress and the other general features like cyanosis, lethargy, having seizures, and cardiovascular status. And then you come in to do the saturation monitoring by SpO2, and then looking at the evidence of radiological imaging. So always it is important to go in methodically to see which grade the severity is. So if you think of the mechanism of hypoxia, so there are 5 main mechanisms that we can think in the physiology where you can have low oxygen in your blood. So it could be due to one thing. So you are inspiring oxygen, which is partial pressure of oxygen is less. And then, so there may be limbi to the blood. And so it would be, patient may be hypoventilating. So they are not adequately breathing enough to get enough oxygen, or there may be a mismatch in the ventilation with the perfusion at the alveolar level, and there may be shunting. So if you think of the reduced partial pressure of oxygen, so when the altitude is higher, your partial pressure of oxygen goes low. So if it is in a high altitude area, so you're breathing less oxygen. So your body oxygen will be, blood oxygen will be less. So, and if you think of the diffusion, so you know from the alveoli, the oxygen to be diffused into the blood vessel, so you have to go through the alveolar capillary membrane. So if there's anything wrong in this alveolar capillary membrane, so it could be thickened. So the thickness could be due to any fluid containing in this compartment, or maybe bleeding into this compartment, or maybe chronic disease like fibrosis of the lung, and due to the thickening of the interstitium. So if there's anything wrong here, so in pneumonia, you have atelectasis and the collection of secretions in the alveolar side. And then if there's pulmonary edema. So you have increased fluid in this maybe if you think of chronic diseases in adults, you may know this alveolar fibrosis. So there you can have thickened this membrane, so that blood, so that can directly affect your oxygen level, leading to hypoxia. And then if you think of the breathing of the patient, so your breathing has two components. So you have the central component and the peripheral component. So when you have central component, so where your brainstem, spinal cord, all these respiratory centers dictating your lungs to breathe and your intercostal muscles and then your diaphragm to move and to do the regular breathing. So if there's anything wrong in this system, in the central monitor, so you get hypoventilation. So especially when you have raised ICP and then any tumors, any underlying diseases, especially in children. So you have to remember the structural brain malformations. Those can lead to hypoventilation. So we have the airway and then the lungs and the neuromuscular system that is helping for your mechanical part of the respiration. So if there's anything wrong in either of these components, so you can again develop hypoventilation. So if the airways is obstructed, when they are obese, when they have a high fat pad around the neck, when they have adenotonsillar hypertrophy, maybe if you think of small children who are having facial abnormalities, and then abnormalities in their airways like Pierre-Robin syndrome, maybe Down syndrome. So your airway can get hypotonic, and then that can lead to hypoventilation. And then at the same time, if they are having neuromuscular problems and then any restrictive lung diseases, then of course they can have restrictive hypoventilation where your peripheral ventilation was affected. So that again can lead to hypoxia. And then the VQ mismatch, so where your good oxygenated blood is coming, but it is not, the alveoli are not ventilated, so you are not getting enough oxygenated blood. On the other hand, so you are ventilating very well, but you are not getting enough blood. So there will be again a mismatch between your perfusion and ventilation. So generally we call the shunting and the physiological dead space. So if there's any mismatch between your ventilation and bleed perfusion, again, that will lead to the hypoxia. So, and then last, so if you think of the COVID-19 infection, so mainly these three causes leading to the hypoxia in COVID-19 infection. The first one is the diffusion limitation, where because of the added secretions and the edema, and then the alveolitis, the inflammation going on around the alveoli, so that can lead to impairment of the alveolar capillary membrane function. So that will reduce the diffusion capacity. And at the same time, there will be thrombus formation with the hypercoagulability in the COVID-19 infection. And then, so that can lead to the endothelial inflammation. And then, so the perfusion would be affected. And at the same time, so when there is hypoxia is going on, so that can lead to vasoconstriction. And then again, this atelectasis, and then because of the hypoxia, there will be new vessel formation, we call angiogenesis, all this causing increased shunting. So we have, these are just theory components that you need to remember. So all these components could affect, will contribute in the COVID-19 infection leading to hypoxia. So it is important that we monitor patients mainly for hypoxia. So this is one of, these are one of a couple of radiological imaging. If you look at the chest X-ray, you can see like all these opacities are mainly concentrating in the peripheral areas, and even in this chest CT you would see that those are mainly seen at the peripheries. So that is sort of a classical imaging of the COVID-19 patients. So how do you monitor this patient for hypoxia? So the most non-invasive option we have in the ward is a pulse oximetry. So you have to be very careful when you interpret the pulse oximetry. You have to make sure that the patient is having good peripheral perfusion because it directly affects the pulse oximetry reading. And then before you do the reading, you have to make sure that the patient is getting a good plethysmography. I will show you a picture. So if you, sorry, you need to have nice sine waves on the monitor that will give you a correct saturation value. And then the invasive modes of monitoring hypoxia that we have is the arterial blood gas analysis. That is the most common thing that we use. So there you can look at, get an idea about the partial pressure of oxygen in the blood, and then the alveolar arterial gradient of oxygen, and then again the ratio between the partial pressure of oxygen and the inspired oxygen level. So those are the common components in the blood gas that you can get an idea about the oxygenation level of the patient. So this is the pulse oximeter. So you have to always, so it has two components. So always it has to be placed in the top manner, and then make sure that the contact is right, as well as you are getting a good plethysmographic wave before interpreting the saturation number. And then here you have to remember, so when you look at the saturation, so you must remember in the physiology, you might have learned about the oxygen dissociation curve. So if you look at these numbers, so when it comes to the saturation of 90, the arterial tension becomes 60. And when it is 95, it is 80. So it is at this level. And then, so you can see, once this level is reached, it is steeply coming down. When there is arterial tension is low, your saturation will quickly come down. So it is important, and when the saturation is 90, you have to be vigilant and act quickly. So these are the indicators of hypoxia from the arterial blood gas components. So these are the usually normal values. So always remember PaO2. If it is less than 80, then you have to be careful. So there will be a mild hypoxia is going on. And then saturation, always we would like to keep it more than 95. And then if it is around 90, then you have to be so vigilant, and that there is a imminent threat that child can go into severe hypoxia. And then, so the pH again is important because it is indirectly measures the anaerobic metabolism and lactic acidosis, making acidosis. So it is important to look at the pH as well, but you have to be very careful. So when there is even hypoxia, they can keep the pH within normal range by the compensation with the respiration. So the child will be tachypnic, and to keep the pH normal and the oxygenation well. So even the saturation is within normal range. If the baby is tachypnic, so you have to be vigilant about those patients. And then about the CO2. So often you get the high CO2 when they are leading to the respiratory failure. So have to be careful about interpreting the CO2, because you can just wait without saying that the CO2 is normal, but it doesn't say, because a child is tachypnic, and most often you will see a washed out CO2. The less CO2 level would be less than 35 when the baby is tachypnic. But if in a tachypnic baby, if you are getting a high CO2, then you have to be careful, because that shows that baby is getting exhausted and then going to the failure. So it is important to look at the CO2 as well. So this is sort of a quick algorithm that we can get an idea about the oxygenation. So often when you have the alveolar artery gradient, so you have to look at it whether it is normal or the wide gap is there. So often we take the gradient is normal between 5 to 25, and then if it is increasing, so then we have to think it could be either VQ mismatch or the diffusion limitation or shunt, because your partial pressure of oxygen in the lungs is high compared to the arterial level. So there should be a reason why that in between there should be a reason that oxygenation is interrupted. So there you have to you can give oxygen and assess where there will be an response to the oxygen. So if it is poor, so that means there is some shunting is going on. So that is a rough idea you can get from this. And then in the wards, so we have simple measures that you can take when the patient is detected having hypoxia. So we have different types of oxygen delivery systems. So the basic ones are the nasal cannula, and where you can give flow FiO2 of 25 to 40% maximum. And most often we would go for in an acute situation, so it has to be given through the face mask rather than nasal cannula, where you can deliver more FiO2 compared to nasal cannula. Ideally, so with the non-rebreathable bag, rebreather, so where you can give higher concentration of oxygen. And then the Venturi mask, it is being used mainly in the adults, even in pediatrics. Now, of course, because we got this high flow nasal cannula, now it is being used less often, but it is still usable. And then in the Venturi mask, there is a nice color code which give you the exact number of flow of oxygen, how much you can give. So based on the flow that you are selecting, you have to use the different color mask for that. And then especially about the high flow nasal cannula, so now it is being very commonly used in pediatric setup, even in adults. So because it is very convenient and it has an additional advantage that you can give heated, humidified flow of oxygen, and in a calculated flow, as well as even you can give 100% oxygen. So this is very important to know. And then once you come to the wards, you can learn how to be used that. And often, other than the COVID-19, especially in the bronchiolitis babies and maybe pneumonia babies, we use to deliver higher concentration of oxygen. And then maybe in the adult wards, you might have seen this, we can give the next step as the respiratory support with CPAP or BiPAP. So in the BiPAP, what is happening there is usually now when we breathe in and out, so that is a negative ventilation, isn't it? So we reduce the intrathoracic pressure by expanding the thoracic volume, and then it allows the air to suck in. So it is a negative ventilation. So what happens here is we are giving sort of a positive ventilation, where you give forcefully giving a blow of air with a positive pressure, and then it has to be mimic the normal respiration, where you have inspiration as well as expiration. So when you use this machine, so it simulates the breathing, but there you have to mention about the how much inspiratory pressures you have to give, and the how much expiratory pressures you have to expect, and then which increase with which that we will increase the oxygenation of the patient, as well as so you can improve their carbon dioxide washout as well. So this is not being used very often, very commonly in the pediatric ward setup, unless in the ICU. But you have to know the use of high flow nasal cannula. It is being very commonly used. So, and then in COVID-19 infection, again, that we use the proning of the patients to improve their VQ mismatch. And so I think there's nothing much on it. And then, so this is sort of an interesting area, the silent hypoxia that is being discussed in the past, and where different mechanisms are, of course, thought that is causing as an hypoxia. So it is mainly due to the desensitization of the peripheral chemoreceptors and central chemoreceptors for the rise of the CO2, which stimulate your breathing. So if you check the patient's saturation, so that is low, but there is no evidence of dyspnea or anxiety or confusion seen in the patient at rest. So in that case, we try to induce this hypoxia by doing the 6-minute walk test. So we will ask the patient to walk in a 30-meter corridor for a 6 minutes time and see the pre and the post test saturations, heart rate, and the respiratory rate and blood pressure. So if there is a fall off saturation below 90 after this test, or falling by more than 4% of their saturation. So if you say when they start the test, the saturation was 95 and it dropped to 90. So it is more than 4% falling the saturation. So that will indicate there is an evidence of hypoxia. So there you need to go into the further evaluation with the echocardiogram and then rest of the other special investigation. So that is one of the key component that we need to keep in mind when you detect low saturations in a clinically well child who had the evidence of saturation, then COVID-19, then of course we have to be a bit worried. So that is to be remembered. So I think that's all for today. Yes.
Thank you very much, madam.
Okay.
Media berapa kan Miss?
I will give you all the parameters that among the parameters are saturation is 90. Saturation is 93 with any other parameters I can give you, right? Any other parameters I will give you. Blood pressure is 90/70.
ID salbutamol का टेस्ट करेगा
Infusion.
what again
Nebulization. The first nebulization पालवी nebulization एक काम है
accident क्या कर लेने वाले मम्मा full blood count दिखाई CRP left right initiation जानो कैनल डाल का मम्मा
Can we start the lecture?
yes sir we can't see your screen sir now we can see sir
Hello. පටන් ගන්නද? ඔව් එහෙනම් බලන්න එනවා කියලා. Right, okay, thank you. And good morning. I'm Dr. Deshan Adihetti. I'm a pediatric intensivist at Ledridge Hospital Medical Intensive Care Unit. In the next 30 minutes, we will be discussing on high flow nasal oxygen therapy. Some of you may be aware of this modality of oxygen therapy already. So the objectives are to understand what is a high flow nasal cannula system and to understand the mechanisms under high flow nasal cannula oxygen therapy. Also to know about the indications and contraindications and to learn how to select the nasal cannula and the flow rates, and also what to monitor and when to escalate therapy. So in high flow nasal oxygen therapy, the flow rates are always at 2 liters per kg per minute. You calculate the flow rate based on the patient's weight. 2 liters per kg per minute. The device can deliver flow rates from 2 liters to 60 liters per minute. So the features of a high flow nasal oxygen system are it has a nasal cannula, which is an open delivery system, which means that the cannula does not cover the entire diameter of the nares. Only 50% of the nasal diameter should be covered so that you maintain an open delivery system. And it provides humidified air with optimal temperature. And also it provides gases under high flow rates. This is a high flow nasal system, cannula system. You can see that there is a water reservoir, which the water is used, sent to a humidifier chamber where it's heated and it generates water droplets. Then the air is drawn out from the nasal, from the wall oxygen, as well as from outside. And it mixes with this water vapor in the humidification chamber, and then it is sent through this tubing system where it reaches the patient's nares and into the airway. So this is the heated circuit. So the open delivery system means that it makes sure that you select a nasal cannula that so that it does not cover the entire diameter of the nares, right? Then optimal humidity is important for our mucociliary action and removal of secretions in the airways. Usually medical gases are dry air and it does not contain any water vapor. So by adding water vapor, we have humidified it so that it prevents drying out of the mucus. If the mucosa is dried, the mucociliary mechanisms are not functioning well, so that you don't get rid of the secretions. But due to optimal humidity, it helps to keep the mucociliary mechanisms intact. The high flow nasal cannula system was produced with the experience given by a patient who had had a heart attack with acute pulmonary edema. She was rushed to the emergency department in the car. So while she was seated in the car and the shutters open, she noticed that whenever there was acceleration and she was facing the wind, it was easy for this person to breathe. And whenever there was deceleration and the wind speed reduced, there was difficulty in breathing. So when she recovered, this was divulged, and later on, many research were done, and thereafter they developed this high flow nasal oxygen system. So that is where this brilliant piece of equipment was born. So now this is how it works: high flow therapy and airway pressure. So as you can see on the x-axis, this is the gas flow rate in liters per kg per minute. And the y-axis shows the pharyngeal pressures in water centimeters. So you can see that whenever we are increasing our gas flow rates, the pharyngeal pressures increase. But this does not happen forever as a linear pattern. So further analysis revealed that though you increase this flow rate, the majority of the end expected pressure generated by this gas flow will be scattered around this area. So from that they have derived this 2 liters per kg per minute prescription of flow rates, because the majority of peak and expected pressures are scattering at this area. So you can see here in inspiration and expiration, the blue part is the inspiration, the pink part is the expiration, and this is normal. The black line is normal, and this is when you apply high flow nasal therapy. You can see when a normal patient is breathing, the inspiration generates a negative pressure and expiration a positive pressure in the airways. Whereas when you apply high flow nasal oxygen therapy, you keep a positive pressure during the inspiratory process as well. And this is beneficial in reduction of the work of breathing. So there are many research publications on the physiology of high flow nasal therapy. This is one of them. So how it helps to reduce the work of breathing. Now you can see in this graph, this is the PP is the pharyngeal pressure on the y-axis, and the time which it is applied on the x-axis, right here. The second graph shows the esophageal pressure versus the time. Now see, we have, this is normal inspiration and expiration, right? In inspiration, the esophageal pressure is because you contract your diaphragm, increase the intrathoracic volume, you generate a negative pressure. So in this is during normal breathing. You generate a negative pressure of around minus 40 centimeters water. And this pressure, into the time this pressure is applied, is called the pressure time product. So this area is the pressure time product, which is somewhat equivalent to the amount of work that should be done. So this is without high flow therapy. This is with high flow therapy. See that the pressure time product has reduced with high flow nasal therapy. The amount of negative pressure needed to be generated has reduced here due to the effect of the high flow nasal cannula system. So this is how it brings your work of breathing down. So gas dynamics in high flow nasal oxygen therapy. So gas flows at high velocities, right, into your upper airway, and part of it comes out of your mouth. So there is high velocity of gas flowing, right? So the open system means the nares are also partially open and the mouth can be open, right? Without this open mechanism, it does not function. So gas is flowing at high velocities here at this pharyngeal level, right? So then if the flow is high here, the pressure should be less, and it will drag your whatever your expired air here and help it to be removed. At the same time, your anatomical dead space, which is usually filled with carbon dioxide rich gas at the end of expiration in a normal person. So when you apply this high flow, what happens is this anatomical dead space is going to be washed out with oxygen rich humidified gas. So then with the next inspiration, instead of a gas mixture which has part of your dead space rich in carbon dioxide, here you get the dead space that is rich in oxygen. So in other words, you have increased your amount of oxygen that is being delivered. So this expiration, I said the dead space is entirely filled with carbon dioxide rich gas. Inspiration, this dead space is part of it is inspirated, then that you get the oxygen mixture. But here in high flow, your dead space is replaced with oxygen rich gases. So it helps to bring up your inspired oxygen concentration. So what are the impacts? It conditions gas flow for delivery of high flow rates. It decreases the work of breathing. Flushes your anatomical dead space with carbon dioxide rich gas. Provides low levels of airway pressure. Reduced energy expenditure by reducing the work of breathing. It improves the mucociliary function due to humidification, and it reduces the need for mechanical ventilation because you have reduced the work of breathing of the patient, and increase the carbon dioxide washout, as well as you are delivering a higher oxygen concentration so that your hypoxia is also being settled. Because intubation rates have been reduced, exposure to sedatives and other analgesics also has been reduced drastically in ICUs which practice high flow nasal oxygen therapy. Indications are bronchiolitis, so any respiratory infection from bronchiolitis, pneumonia, asthma to heart failure, for post-extubation care and for post-cardiac surgery, as well as for peri-oxygenation during intubation and extubation. Right? Contraindications are obviously your nasal passage should be intact. So in coronal atresia, you can't use it. Injections and toxins which impair your level of consciousness, diminishing your protective airway reflexes, then of course you can't use this. Then life-threatening, impending respiratory failure, you cannot use this. Child needs intubation. Trauma to the adjacent structures, maxilla, basal skull fractures, chest is a contraindication. And pulmonary air leak syndromes, which are the pneumothorax, pneumomediastinum, and subcutaneous emphysema, as well as foreign body aspiration. So what needs to be prescribed? The FiO2, which is dependent on the disease. The flow rate, which is always 2 liters per kg per minute. Temperature, 37 degrees Celsius. Mode, whether it's a pediatric mode or adult mode, this should be selected. Cannula size selection. So there are cannulas varying from extra small, the dark, the blue one, small, medium, large to extra large. And you have to compare this cannula with the nasal diameter, right? And each of these cannulas have a minimum flow rate that can be delivered to a maximum flow rate, right? So first you get the patient's weight, apply 2 liters per kg so that you know the flow rate. So patient is 5 kilos, 2 liters per kg is 10 liters per minute. So then you have to see which cannula can deliver 10 liters per minute, right? And also compare whether it covers 50% of the nasal diameter, and then you select nasal cannula. Remember, flow rate 2 liters per kg. So these are the various cannulas and the flow rates. What are the observations you should do once you put the patient on high nasal oxygen therapy? So basic monitoring, the FiO2 requirement, the saturation, heart rate, and the respiratory rate, and also the work of breathing. So these are from studies. They say that once you apply high flow nasal oxygen therapy, if you're on the correct path, the heart rate should show a reduction by 10 minutes, respiratory rate by 5 to 15 minutes, oxygenation will improve by 10 to 15 minutes, and so on. Now, no need to memorize these. These are patient dependent. So this is just for your knowledge to show you that once you have applied high flow nasal therapy, you should look for the trend of reduction in heart rate, trend of reduction in the respiratory rate, improving saturations, and reducing oxygen requirements. And the patient's general condition should improve if you are on the correct path. So if it is not happening, then you should consider escalation. So if the patient is not stabilizing by 2 to 4 hours of application, then you have to think of escalation. If the respiratory stress is worsening, if the hypoxemia is persisting, and your requirement is rising, oxygen requirement is rising. If so, then you have to do a blood gas, do a chest X-ray to exclude any pneumothorax, and escalate to the next step. So this is the respiratory pattern. You can see that At this point, we have applied high flow nasal therapy for this patient, and the rate has reduced nicely. Same thing in the heart rate. Okay? So always learn to observe the patterns of your, not the numbers, it's a pattern that you see. Whether it's the trend of the number. Then when to start weaning, you have to give adequate time for your disease process to settle. Maybe a pneumonia, maybe a heart failure, and treat the underlying cause properly. And after that, you can see that your FiO2 is, you can start weaning your FiO2. And once the FiO2 is at 0.3 or 30%, you can come off the high flow nasal oxygen therapy. Remember that we don't wean the flow, right? Nursing care is very important. Nasal pump should be prong position, should be kept properly to prevent pressure damage. And also there should be proper nasal hygiene, suctioning, so that these prongs are not obstructed. This happens very commonly with patients with bronchiolitis, who have a lot of secretions. So sometimes you put on high flow, but with time the patient improves, but again gets bad because your nasal prongs are obstructed with secretion. So remember to do regular suctioning of the nasal prongs. And also remember, when you're starting high flow, you have to put a nasogastric tube and decompress the stomach, because some amount of gas can be swallowed and there can be gastric distension, which further impairs your the dynamics of the diaphragm. And to change the saturation probe site 2 to 4 hourly to prevent burn. And be fed once the patient is stable through nasogastric tube or sometimes even through breastfeed. But remember that your disease process should have settled, right? Those who cannot take could be given intravenous fluid. So can I nebulize with high flow nasal oxygen therapy? Yes, then you should, instead of this normal humidifier chamber, you have to add this humidification chamber that has the nebulization port. Right? So nebulization chamber is this. Right? Same thing. This is the nebulization chamber. You have to add your nebulization solutions here and connect to this gadget here, and then fix it to the humidifier. Then you can nebulize. So nebulization device, power device. With COVID-19, there was research done on patients with high flow nasal oxygen therapy. You know that it generates lots of aerosol. So there was a concern whether using high flow nasal oxygen therapy in the ICU would predispose healthcare workers to COVID-19. So what they did is they just put a simple face mask on top of the device, as you can see here, right? So this is without a device, a simple face mask. You can see the amount of droplets that is generated. Here it's with the face mask. See, so whenever you are using high flow nasal oxygen therapy in COVID-19 patients or in influenza patients, remember to apply a simple surgical mask. So it reduces the problem. This is how it looks like when you apply. That's a new thing about high flow nasal. Episode coming to the end. Take home messages. So high flow nasal oxygen therapy is a rescue therapy. It's a bridging therapy, and it's a mode of weaning. Right? Rescue therapy, severe illness, you can start high flow instead of going for intubation and see whether it is improving. If not improving, you can escalate to mechanical ventilation. Right? So during escalation, it's a bridge. Again, during weaning also you can use the high flow nasal oxygen therapy. So remember to apply the simple surgical mask when you are using high flow nasal oxygen therapy in infectious patients, especially the COVID-19 or the influenza patients. So that brings to the end of the lecture. Remember, the flow rate is at 2 liters per kg per minute. You have to prescribe the FiO2, the flow rates, choose the correct nasal cannulae, and while weaning, you don't wean the flow, you wean only the FiO2. And once the FiO2 is at 0.3 or 30%, you can come off the high flow onto room air or nasal cannulas or the face mask. Okay, thank you.
Thank you very much, sir. If there are any inquiries, you can put them into the chat box.
Okay, are there any questions? Okay, then let's find. Okay, thank you.
Thank you very much, sir.
Oxygen
I will give you all the parameters that among the parameters saturation is 90. Saturation is 93 with any other parameters I can give you, right? Any other parameters I will give you. Blood pressure is 90/70.
Full dot counting I, CRT, left light, initiating channel down come C-base से किए थे?
Can see lot of chest injury, tracheal tap, lot of subpustal, interpustal recessions. He is trying to speak, but he is unable to speak even a few words. Right, your first nebulization is over. Following nebulization, saturation is 91, 92 is around. Following nebulization is right there. Saturation is 91%. Respiration is 35. That's gone up to 37. Huh? He is conscious, but very breathless, lot of effort. කතා කරන්න හදනවා. මාස්ක් හොඳට මේ fogging mist. Tinggal Hanu. I know I think Hanu. Anything you want to check is a respiratory system. Breathing. Yeah, it is slightly reduced, quite resonant, and there are a lot of ground pattern. Secretions, there are not secretions. The extremity is coming. This X-ray, this X-ray machine is a portable X-ray. අන්න X-ray එක digital X-ray එකක් කියලා දැන්.
I'm the emergency medicine. So obvious right side is right. Please, I do back and.
No bubbling. Nothing. No is no bubbling. No air coming to the water level. Nothing coming out from the tube. It's not bubbling. There's no water level is not shrinking.
There's anything for prepare for needle therapy.
Right. So there's no heating in the needle. No water bubbles coming to the chest compression or the needle. Up. Can you stop?
Next lecture will be delivered by Dr. Inota Pereira, pediatric nephrologist, regarding oliguria and acute kidney injury.
Hello, can you all hear me? I hope you can hear me. I'm Dr. Inoka Pereira. I've been asked to talk to you all on acute kidney injury among children regarding prevention and management. So I'm hoping to talk to you all, just touch on normal functions of the kidney, then talk about definitions, risk factors for development of acute kidney injury, diagnosis, prevention, and management. And if there is time, I'll discuss one or two cases. So what are the normal kidney functions? To recapitulate what we have learned all these years. The main function is to maintain intravascular volume by glomerular filtration and reabsorption of water from tubules. Other important functions include maintaining acid base and electrolyte balance, maintain blood pressure, production of erythropoietin, which is essential for erythropoiesis. Also maintaining calcium phosphate metabolism is important for bone health. So all these functions can get affected when the kidney function deteriorates. So if you look at the structure of the kidney, you know the nephron is the functional unit of the kidney. There are millions of nephrons in each kidney. If you consider the renal corpuscle, it consists of the Bowman capsule and the glomerulus. The glomerulus is supplied by the afferent arteriole, and then the blood that enters the glomerulus leaves via the efferent arteriole. If you look at this diagram, you probably remember that the afferent arteriole and efferent arteriole have different dimensions. The efferent has a smaller caliber than the afferent arteriole. the importance of that is, so what maintains production of urine is by glomerular filtration, which in turn is maintained by the high pressure inside the glomerular capillary tuft. How does that take place? When blood enters the glomerulus and leaves via arteriole, which has a smaller caliber than the afferent arteriole, then you probably understand the pressure inside the tuft rises, which facilitates filtration and your production of urine. So any reduction in blood volume can affect this mechanism. Because when the kidney, unlike other organs, is a very wonderful organ. It will suddenly sort of don't go into strike and say, I'm not going to work from now on. It will try bring about various compensatory mechanisms to maintain the functions that I mentioned earlier as much as possible. So it does so by synthesizing various chemicals to maintain renal blood flow. So how does it maintain renal blood flow? By increasing, when there is hypovolemia, there is increased prostaglandin synthesis, which dilates the afferent arteriole so that the renal glomerulus is properly perfused. At the same time, in order to maintain the high pressure inside the glomerulus, the efferent arteriole undergoes constriction because of increased production of renin in hypovolemia. So if we interfere with these two protective mechanisms, the glomerular filtration, the high pressure will not be maintained. That will in turn lead to reduction in glomerular filtrate and reduction in urine output as a result. So what are certain medications, especially non-steroidal anti-inflammatory drugs which are prostaglandin synthase inhibitors, can inhibit the dilatation of the afferent arteriole in case of hypovolemia. Likewise, ACE inhibitors like captopril can interfere with the protective vasoconstriction in hypovolemia, resulting again drop in intracapillary glomerular pressure, which can lead to reduction in urine output. So your kidney has just briefly, you have the glomerulus and proximal tubule, which has done a lot of work, and then you have your loop of Henle, ascending loop, and thick ascending loop, and the distal convoluted tubule, which in turn drains into your collecting tubule. So what are the normal functions of the tubule? So once the glomerular filtration occurs, 98% of the fluid is reabsorbed, right, from the proximal tubule, and the obligatory fluid absorption takes place from the proximal tubule, and throughout the kidney at various sites, water will get reabsorbed. In addition to water absorption, the proximal tubule will also absorb sodium, glucose, bicarbonate, your calcium, phosphate, or most of the electrolytes are reabsorbed from the proximal tubule. Then in the descending limb, further absorption of water via countercurrent mechanism takes place. And again, in the distal tubule also water gets absorbed, which is again under control of ADH hormone. So any interference to this mechanism, protective mechanism, can lead to reduced urine output, especially because with proximal tubular electrolyte absorption is a lot of transport need are energy dependent. So for if there is, in a case of hypoxia, energy supply to these tubules will be reduced, leading to these essential absorptive functions of the proximal tubule will not take place. Right? So there are changes in the kidney function with age. The glomerular filtration rate and the other functions of the kidney are not the same in a child when it compares to an adult. So usually the kidney development starts at 5 weeks of gestation, and by 35 4 weeks of gestation, the nephrogenesis is complete, and the baby, a trained baby will have about 1 million glomeruli in each kidney. So what does that tell us? If a preterm baby, in a preterm baby, all this normal nephrogenesis will not complete. So a preterm baby will not have the normal number of glomeruli in that kidney, which in turn can push them into, if an injury occurs, that will make them at risk of developing kidney injury. And at birth, the plasma creatinine, you have to remember, reflects the mother's creatinine level. Because in utero, the creatinine, all your excreted products are removed from the placenta. And when suddenly the baby's blood supply is cut off from the placenta, it's unable to excrete all the excreted products efficiently. Because a newborn baby's glomerular filtration rate is lower than that of an adult, right? In a preterm baby, it's about 10 to 15, whereas a term baby, it's about 15 to 20. So the removal of excreted product is inefficient. Because of that, the baby's creatinine tends to be high, that it is almost equal to the mother's creatinine, because mother has been excreting the creatinine up to birth. Thereafter, after about 72 hours only, the baby's proper creatinine value will be reflected. So if you need to check a creatinine renal functions of a newborn baby, it's important if you do it in the first 24 hours of life. If you see it as sort of elevated, you repeat it in 72 hours. And the adult level usually is reached by about 5 years of age. And also remember, the plasma bicarb may be lower due to lower tubular threshold of absorption. So that also is important for you to remember when you are interpreting your blood gas. Yeah, you have to know how to calculate the glomerular filtration rate. That is, it is important when it comes to adjusting your drug doses. I will talk a little on that later on. So the easiest formula is the short formula, which is the K constant multiplied by height in centimeter divided by micromoles, creatinine in micromoles per liter. In most centers, they use a K as a constant. 40 if the creatinine is in micromoles, 0.45 it is in milligrams per deciliter. Ideally, this K is given for various age groups. It's not. It's the same as the 40 if you really properly calculate. So for practical purposes, you can use this formula. So what about how common is pediatric incidence of acute injury? Now, during my time when I was a medical student and an intern, we used the terminology acute renal failure. Now we have moved away from that because we use acute kidney injury. Because you can't wait until the kidney fails, but act before that to prevent the kidney from failing. Right? So acute kidney injury is the terminology. So I think you all must have been taught this term. So incidence of AKI in hospitalized children is clearly increasing at an alarming rate. The main causes used to be in the past intrinsic renal diseases like hemolytic uremic syndrome, glomerulonephritis, things like that. But now it has shifted more towards these acute illnesses like sepsis, hypoxia, things like the toxin. Those are the those have now come into the picture more than the intrinsic renal disease. And 1 in 5 adults and 1 in 3 children worldwide experience AKI during a hospital admission. And it can vary from 5% of hospital admissions to 30 to 50% among children in PICU. So you can see that children who go into PICU are critically ill, they are very, very ill. So they are at very high risk of developing. Okay. So why are we fussing about AKI? Is because the mortality rate in a child with AKI is very high, 30% against the child who is not having AKI, which is about 2.6. So that is why it's very, very important to, whenever possible, prevent a child from developing kidney injury. Not only is the mortality rate high, the cost of care is also high. Those who develop injury, kidney failure, they need very specialized treatment, which are very, very expensive. So it's a burden to countries like ours. So how do you diagnose it? Yeah, it's very difficult because there have been many definitions, more than 30 definitions in the past. Most of them were in considering serum creatinine, which is a poor biomarker because it varies with age, it increases with age and race, gender, a lot of factors affect the serum creatinine level. And in order to observe a rise in creatinine, the kidney function has to deteriorate for about 50%. So you cannot identify a child at the initial stage of developing injury. And it does not tell us about the etiology, duration, or severity. So commonly nowadays there are two widely used criteria: the pediatric rifle criteria and the KDIGO criteria. These are basically developed considering current evidence. So KDIGO criteria explains defines kidney injury in 3 stages. Then it considers the rising serum creatinine from the baseline and also considers the urine output. Now, when you are dealing with a child, when you see a patient coming into your ward, you don't know what their previous creatinine has been. Normal children don't have their creatinine measured, isn't it? So that also has limitations. Then you have your P-rifle criteria, which is which describes the progression of kidney injury from a risk of injury to development of injury, then resulting in failure, loss of kidney function, and development and stage renal failure. So high mortality and decreased likelihood of renal recovery is displayed when we go down this chart. Again, they consider the estimated creatinine clearance and urine output as their parameters. So this again, for the same reason, is very difficult for us to use in a ward setting. So I advise you to go by the urine output. That is the easiest method. Now you would appreciate at all these stages they talk about the duration. See, both P-rifle and KDIGO criteria talk about this number of hours. So that is the period, the critical period for less than 0.5 ml per kg per hour. Critical period where there is a risk of where the injury to kidney patient are having a risk of kidney injury. This is the time for us to act and do something and prevent an injury. Right? So it's very, very important to identify our patient by monitoring their urine output and do something you can't about it. You can't see a patient in the morning, ward round, and then come back in the night, and then suddenly realize I've got the urine output stop and push the panic button. Have a sleepless night. The patient might have progressed to injury and failure by then. So, very, very important. Any child who is at risk of renal injury, you have to keep an eye on their urine output. So there is no traditional etiological classification. You probably remember from medical school, there is pre-renal, intrinsic, and post-renal. So pre-renal involves decreasing fluid intravascular volume due to volume loss, blood loss, fluid loss, diarrhea, vomiting, and it can be, although there is no external fluid loss, it could be because of reduction in effective intravascular volume. Such as in a patient with nephrotic syndrome, we remember the imbalance of Starling process due to hypoalbuminemia causes extravasation of fluid from the intravascular to extravascular compartment, isn't it? So such patients, burn patients, so they are the ones who have a reduction in the effective intravascular volume, although there is no external fluid loss. And then you have your ischemic injury, hypertoxic vascular and glomerular injuries. There is vasculitis can cause injury, glomerulonephritis, post-obstructive, especially congenital abnormalities of the kidney, vascular urethral valve, bilateral VUJ obstruction, PUJ obstruction. Usually, if in a bilateral child who have two kidneys. If one kidney is normal, although there is some problem in the other kidney, it is not going to push them into renal failure because the other normal kidney will compensate. Problem happens when there is only a single kidney, congenital absence of one kidney. So if there is obstruction to that kidney, there can be those children are at risk. So how does the kidney progress from pre-renal to intrinsic failure? Usually hypovolemia will lead to reduction in renal blood flow. That will result in all these compensatory mechanisms I told you about maintain the renal perfusion. So these compensatory mechanisms involve the introduction of glandine or angiotensin 2. So if we intervene with respect to blood flow, we can prevent a pre-renal injury because pre-renal injury, the kidney structure is normal. So if we do something, if we do a management properly and restore the blood flow, it will come back to normal. Patient will start producing urine. But if we don't do anything about it, or if we don't facilitate the normal protective mechanism of the kidney by doing our fluid management properly, it can lead to intrinsic renal failure, where the renal function, the kidney architecture is injured, renal bed is injured. For that to recover, it has to do repair and remodeling. So that takes time. It can take from days to weeks to months. Sometimes may not recover even. So it can lead to an irreversible stage, and it will be too late. So we might have to start renal replacement. So this is the time for us to act, right? So prevention of developing acute injury is important. You have to identify children at risk. You have to manage and ensure their renal blood flow is maintained with normal blood pressure. How do you know whether there is good renal blood flow? Is the patient's blood pressure will be normal? You feel the good femoral pulses. You will be able to feel the femoral pulses. Then you can say, okay, there is some blood going into the kidney. At the same time, it is very important to avoid nephrotoxic medication. The common nephrotoxic medications include
We can't hear.
Yeah, she's sharing the slides again.
Okay, sir.
So, was mentioning, so prevention of developing AKI is very, very important. How we do that is by identifying children who are at risk of developing AKI and ensuring their renal blood flow, ensuring that their blood pressure is normal and their femoral pulses are well felt. At the same time, avoid all these nephrotoxic medications like non-steroidal anti-inflammatory drugs, aminoglycoside, which is notorious to cause renal injury, and again also IV contrast. So how you so if you have to if you have to use aminoglycoside, there are ways to reduce injury. I will talk about that later in my slide. And also, it is important to adjust the dose according to glomerular filtration, Usually the BNF gives you instructions as to how to do it. So you calculate your GFR with the available creatinine from the formula I gave you and follow the instructions given in BNF. So who are the children who are at risk of developing injury? Neonates. They are very vulnerable, especially the preterm infant, because they have reduced number of glomeruli. Even term babies are at risk. Those who are having congenital heart disease, and because most of them have heart failure, so their cardiac output is low, so their renal blood flow is also not optimum. At the same time, they are on diuretics and they are ACE inhibitors. So ACE inhibitors interfere with the efferent arterial protective mechanism, so they are at risk. Then those who have pre-existing renal diseases like congenital abnormalities of the kidneys, like dysplastic kidneys, various obstructive diseases, they can have acute or chronic deterioration of their kidney function. So febrile children, they are at risk because fever causes increased insensible, right? So unless you pay attention to their fluid intake, they are at the end. And then sepsis causes interferes with hemodynamic stability. Sepsis is involved with the various bacterial toxins are released. So those can cause intrinsic injury to the kidney. So any septic child is at risk of developing kidney injury. So how do you avoid nephrotoxic injury? Aminoglycoside. If you have to use antibiotic, you have to use. There are many alternative antibiotics to cover gram-negative, good gram-negative cover. So in the Western countries, developed centers, we monitor drug levels, and with monitoring of drug levels, you can give aminoglycoside. And instead of BD or TDS dosing, you can give daily dosing. And also, instead of giving intravenous preparation, you can use topical preparation like inhalers for pneumonia. So IV contrast, very, very important when you prescribe, before you subject the child for IV contrast. You have to avoid it in high-risk patients I mentioned above. Discuss with the radiologist and see whether half the dose can be used. If it has to be done, you have to hydrate before with IV fluids and then continue IV fluids after the procedure. At the same time, monitor your creatinine before going for the procedure, then 6 hours, 12 hours, 24 hours, and 48 hours later to make sure that renal functions are not affected. And if they are, sometimes we may use mannitol to promote diuresis. Then ACE inhibitors, captopril, enalapril, and olosartan, avoid in dehydrated patients, especially these congenital babies with congenital heart disease. And also, if you are to use an antihypertensive in managing glomerulonephritis, it is advisable not to use the inhibitors, use calcium channel blockers or any other antihypertensive. So toxins, bacterial toxins are very important. So if you suspect any child to have bacterial infection, it's important to start IV antibiotics early. So myoglobin, hemoglobin, urea, again, are other toxins. So how do clinically, what is the clinical approach to acute kidney injury? So you have to take a very good history. You have to assess the volume status of the patient. This is not only just on admission, but every day, maybe twice a day, 3 times a day, you have to assess the volume status in a high-risk patient. You do your investigation. Urine analysis, if it is normal, it usually indicates a prerenal cause. I'll talk a little bit more on that. Abnormal urine analysis usually is associated with either tubulointerstitial disorders or glomerular injury. Then if ultrasound can show hydronephrosis, it usually tells you that you are dealing with a post-renal cause. So they're talking about the management. There is no specific treatment as such. So today, up to date, the management of KI is involved with managing complications with conservative management and renal replacement therapy. So what does conservative management involve? It involves the maintenance of fluid and electrolyte balance, preventing life-threatening complications. What are the life-threatening complications? That is pulmonary edema, hyperkalemia, and acidosis. So you have to watch out for those things and treat them if you see them develop. So avoid further third kidney injury by not giving you any nephrotoxic medications or providing appropriate nutrition. So renal replacement therapy, if we cannot go on with conservative management, we can start renal replacement therapy. So peritoneal dialysis, hemodialysis, PRRT, one of those methods. So how do we, if you talk a little bit on evaluation of the patient, history, so you have to do a good history and find out if there is any form of fluid or blood loss, find out if there is ischemic features, take the drug history, find out if there is anything in the past medical history like congenital heart disease, examination. You have to do a daily body weight check. So that is only objective way of assessing your whether the patient is euvolemic, hypovolemic, or hypervolemic. So you might have to check the weight either on a daily basis or sometimes on a twice daily basis. So assess the volume status, examine the peripheries and their whole peripheries, look at the capillary refilling. You would have this topic would have been covered earlier. In a neonate or small baby, feel the fontanelle and see if it is depressed. Look at the mucous membrane, are they dry? Then look for any systemic features suggestive of a glomerulonephritis or vasculitis. Edema might be due to nephrotic syndrome. So you do your system examination. Usually tachypnea include suggests can be heart failure, bronchial asthma, acidosis, pneumonia, tachycardia. Can't see the bottom of the slide. Can't remember it. Right. So tachycardia can be due to hypovolemia. And then, so these look for risk factors I mentioned earlier, right? So what are the basic investigations you want to do? You obviously look at the urine. This is like liquid gold urine. Even the little bit of drop, you have to tell, you should not discard. As soon as you see the patient, you have to take some urine and send it for investigation for full report, culture where necessary. And if you have the facility, so you can check the urine sodium level, creatinine level, osmolality. UFR usually gives specific gravity also. I will tell you the importance of these in a bit. So you send off your blood, Q and creatinine, you can do a gas, either capillary or venous gas, liver function, your calcium phosphate. If you suspect nephrotic syndrome, do albumin and cholesterol. So full blood count, look for any evidence of infection on your blood and other cultures. Then ultrasound scan, kidney, you look at the kidney sizes. If it is, are the sizes normal for the age? If they are small for the age, then that means that there is a pre-existing renal problem. Child has renal dysplasia, echogenicity. Then any obstructive features like hydronephrosis, hydroureter, which can be due to posterior urethral valve, tabulated bladder. So those are the information you can get by doing your basic investigation. So there are certain clues in your investigation which will help you to differentiate where the etiology is. So pre-renal is usually associated with a raised hematocrit, right? So if you compare the blood urea and creatinine, both will be raised. Sometimes the creatinine may not be raised. Or whatever it is, the rise in blood urea is much higher than the rise in creatinine. that will usually tell you there's a pre-renal element, right? So in UFR, the osmolality, because the urine is concentrated, osmolality or specific gravity will be high. Urine sodium excretion, you remember the tubular reabsorption, because by how the kidney maintains intravascular volume is by water absorption by way of sodium absorption. So excretion of sodium will be minimum, right? So your urine sodium excretion will be less than 10. And if you calculate the fractional excretion, it will be 1%, less than 1%, but this will be only helpful before you give any diuretics. Because you give diuretics, sodium will, if the patient responds, there will be sodium excretion, and these values may not be reliable. So in intrinsic renal failure, the rise in creatinine is more than the rise in blood urea level, right? Urine osmolality will be less than 300. Sodium, there will be increased sodium excretion because the normal compensatory mechanisms of sodium absorption cannot take place because of the intrinsic injury. So your patient will lose sodium, right? Post-renal, not very helpful. Again, low osmolality, lot of dilute urine is passed in post-renal renal injury. Sodium excretion is also low. So what is the fluid management in a child with acute kidney injury, right? So first thing you have to ask is, what is the volume status of the patient? Is the child hypovolemic, euvolemic, or volume overload after your assessment? So it is, if it is hypovolemia, you have to do your volume expansion. I'm sure you must have had a lecture on fluid electrolyte management, isn't it? I'm not going to elaborate on that. So expand the volume. So usually when the intravascular volume is restored, patient is expected to pass urine in 1 or 2 hours. So you come and reassess after ensuring that you have done your fluid management properly. So if there is no improvement in urine output, you can try a furosemide challenge by giving a 1 to 2 milligram per kilogram of furosemide IV. Sometimes in a severe case, you use furosemide as an infusion. What is important in prescribing furosemide is you cannot give it, if you're giving a bolus, you can't just push and give, because what is the problem with furosemide? It is ototoxic. So, at the same time, you have to prevent side effects of this medication. So it has to be given very slowly over about 10-15 minutes. Very important to give that instruction to nurses. So if there is no response to volume expansion and furosemide challenge, then we need to restrict giving further fluid. So degree of restriction again depends on whether the patient has euvolemia or hypervolemia. Euvolemic patient, you can give previous output and insensible loss if you know the output, or you can try say 2/3 maintenance, 50% maintenance, like that. Severe restriction is required if there is volume overload. So if the child is euvolemic after your assessment, again you restrict fluid to insensible loss and previous. It may not be previous 24 hours urine output. You can do last 6 hours urine output over the next 6 hours. It's insensible, like that. Because if you see the patient, when you see the patient on the first time, you may not have the previous 24-hour urine output value. So we work out a practical duration. Again, you can try furosemide. So patient who has volume overload with evidence of hypertension, pulmonary edema, severe restriction of fluid, furosemide, failing that we have to start renal replacement therapy. So hyperkalemia. So remember the 3 things which can be lethal: the pulmonary edema, hyperkalemia, and acidosis. So hyperkalemia can lead to cardiac arrest or arrhythmia. So any child who has a serum potassium of more than 6 should have ECG monitoring. What are the ECG changes of hyperkalemia? Can have tall peak T waves, prolonged QRS complexes, and long PR interval. The treatment involves severe restriction of potassium intake. That includes you don't give any potassium in your IV fluid. If you have been giving adding a potassium into your fluid, IV fluid, you have to stop that. Advise the child on not to take any potassium containing fruits, especially fruits and fruit juices. Certain drugs contain, so you look at the literature and see if they contain potassium. The definite treatment is removal of potassium from the body, which is by dialysis. Until the setting up dialysis take time, until that time, you have to stabilize the myocardium to prevent arrhythmias and shift your intravascular potassium into the intracellular compartment. So how do you do that? Right. So 10% calcium gluconate is the agent we use for stabilizing myocardium. It has to be given at this dose very, very slowly because IV calcium itself can cause arrhythmias. So you have to give it slowly over 10-15 minutes. The onset of action is immediate, and there should be ECG monitoring to pick up any bradycardia or arrhythmia. So what commonly you have salbutamol nebulizer in most wards. Nebulizing with salbutamol shifts the potassium inside the cell. Then if there is acidosis also, you can give some bicarbonate. That again will push your potassium into the cells. Then you can start an introducing glucose drip. They also take a reasonable, very quite rapid action. But calcium resonium, it takes time, usually about 48 hours, and it's not that helpful in acute setting, right? So I'm not going to talk a lot on this hyponatremia. There's not enough time. I'm sure it would have been covered earlier. So you have to treat hyponatremia because it's often due to fluid accumulation. So usually restriction of fluid or removal of fluid will improve the sodium level. Metabolic acidosis, again, rapid corrections can lead to hypocalcemic tetany and seizures. So you have to make sure that the ionized calcium level is normal. So indication for treatment includes hyperkalemia and acidosis, severe acidosis. Then you can give some bicarbonate. Hypertension, again caused by fluid overload and intrinsic vasoconstriction due to hypovolemia. So choice depends on your severity and cause. Commonly, we use nifedipine, prazosin, furosemide. Furosemide is the only diuretic which can be used when the GFR is below 10, like spironolactone, HTT. Those are not helpful. So avoid giving ACE inhibitors and angiotensin receptor blockers due to the reasons I mentioned earlier. So other aspects of management of AKI include management of hypokalcemia, hypophosphatemia, leukemia, nutrition, very important. I don't have time to go through them in detail. So monitoring, extremely important. You have to check your patient's daily weight, check your vital signs, strict fluid and input-output chart. You cannot monitor the urine output properly, catheterize. So you do your daily investigation, right? So we have time for about 2 cases. Case 1, 6-month-old baby, trisomy 21, having complete congenital heart disease, admitted for surgery. Baby is failing to thrive and having signs of cardiac failure on furosemide, spironolactone, and captopril. Baby has developed diarrhea and vomiting in the past 48 hours. ORS has been given. Is this child at risk of developing kidney injury? Can you all talk?
You can put in chat box.
Yes, this child is having is at risk of developing injury because he has a congenital heart disease on furosemide, diuretics, and on captopril. On top of that, she's having diarrhea and vomiting, having heart failure. Also, the cardiac output is low. So the child is at risk of developing it. So you can't keep such a child in a chronic side. The child has to be brought into the acute side or the high dependency area. So this he has heart tachycardia, tachypnea, blood pressure is on the low side, fever, very irritable, dry mucous membrane, sunken fontanel, decreased skin turgor, capillary refilling time prolonged. Mother says try not pass urine for 12 hours. So what is the working diagnosis? So there's evidence of moderate to severe dehydration with hypovolemia because the blood pressure is on the low side, isn't it? And then there is reduced urine now. So there's is the child having already having injury to the kidney. So you look at the urine, it's very concentrated, dark in color, osmolality is high, specific gravity is high, sodium is low. If you look at the sediment, there can be carb. Look at the urea and creatinine, they are elevated, right? So the degree of elevation, I told you about now, the upper limit is 30, here the creatinine is only 32. Whereas in urea, it's almost double, isn't it? The urea elevation in urea. So there's hypernatremia, potassium is on the high side, there's acidosis, bicarb is low. All this tell you there is moderate to severe hypovolemia with metabolic acidosis and hypernatremia and hyperkalemia. So what will you do? What are the immediate steps you can take in managing this child? So if you have to discontinue all the diuretics and captopril. At the same time, discuss with the cardiology team and inform them that you are going to stop them because you have to protect the heart also, because if the heart stops suddenly, everything is over. So you have to your fluid management here, ensure that volume is restored in order to manage this patient. Second case, 4-year-old boy, high fever, having pneumonia on treatment with antibiotics, has been feeding poorly. He's drowsy and pale, having cold periphery, passing dark urine, minimal amount, prolonged capillary time, tachycardia, blood pressure low. What is the working diagnosis here? So this looks like a septic child going into septic shock, isn't it? So what are the renoprotective measures that could have been done to prevent the child leading into acute kidney injury, you think? So frequent monitoring of the child is essential. Since you all are not talking, I'm going to keep it going ahead. So this child could have been again managed in the acute side when giving antibiotics. Ensure that safe antibiotics are prescribed. This child has been feeding poorly, so he should have started on IV fluids, maintenance IV fluids. Monitoring is important. So because the child has high fever, he will require more than maintenance fluid. Because high fever increases insensible loss, thereby requiring more fluid than the maintenance. Right? So those are the renoprotective measures which we can take. So if you look at the examination, there will be neutrophil leukocytosis, hemoglobin low, platelet high, high CRP. Here, look at the creatinine and urea values. The rise in creatinine is about 3 times. Urea is about 3 times from the upper limit, whereas in rise in creatinine is more than 5 times the upper limit. So that's like a intrinsic. Although there is a pre-renal element due to hypovolemic shock, there is an intrinsic cause element also. So this child is hyperkalemic, so you need to do your management of hyperkalemia, like that. So in summary, what you have to remember is acute kidney injury increases mortality. So we have to, it is extremely important that we prevent a child at risk from developing acute injury. So identifying the patient at risk of developing AKI is very important. How we do that is by closely monitoring the urine output of such patients. Early and adequate fluid management to maintain renal blood flow and prevent development of AKI. And always ensure protective measures in all children admitted to hospital. Avoid your hepatotoxic medication. Thank you. Hope all you good people will do your best and look after your patients to prevent them from developing kidney injury. And one little message, the management of UTI and nephrotic syndrome is in the college website. I think you should all read it. It's very practical, it's a guideline. And thank you and all the best to you.
Thank you very much, madam. Now there is a tea time until 10:40 a.m.
Can I start the meeting, sir?
Yes, sir. Now it is. Yes, sir. Now you can start, sir.
Okay, I am going to start.
This lecture will be delivered by Dr. Udaya Silva. It is about poisoning and snake envenomation. It is to you, sir.
I am sharing the screen. Has screen's been shared?
Yes, sir. We can see you.
Okay. So in I will be discussing two topics in this session. One is about acute management of acute poisoning in children, and the other one is on snake bites. When you acute poisoning in children, poisoning is a significant cause of childhood morbidity and mortality worldwide, and so it is one of the most commonest home accidents in childhood. So with the fast change in lifestyle, with increasing use of chemical substances, in the incidence of child poisoning is in the rise. So when we talk about poisoning, the concept of poison and poisoning should be understood. So poison is a substance and poisoning is a incident. So usually, commonly we label something as poison when it is been causing kind of symptoms, signs, or threatening to life, or affecting a function of a structure or a system, we consider it as a poison. When it happens, the concept is known as poisoning. So anything can be poisonous in high concentrations. But generally, we use the term poison for substances which can cause the clinical effect in small amounts. It's a kind of, I said, it is a kind of chemical contact. So the contact can be acute ingestion, surface contact, like skin or mucosal or eye contact, inhalation or aspiration, or injection. Injection means kind of an injection into subcutaneous tissues or deeper tissues, which happens in snake bites and arthropod bites. The poisoning can be acute or chronic. In this session, we are concentrating on acute poisoning. So at the end of this session, you are supposed to have some basic knowledge on acute poisoning, and you should be able to have a structured approach to a child with acute poisoning, and familiar with the protocols for treatment of child with poisoning, and some exposure to challenges and practical issues. chemicals from different origins and sources available around us. Some chemicals are synthetic, some are natural. Synthetic chemicals can be pharmaceutical chemicals like medicines, agricultural chemicals, industrial chemicals, household or domestic chemicals, and natural toxins like plant poisons and animal poisons. Management, we have to manifestations. The poisoning can be manifested locally, like GIT manifestations, skin or mucosal manifestations, or it can have distal manifestations. So the injection, the site of contact can be different to the site of manifestations. So the manifestations can occur in a specific organ or a system like heart, lung, or blood. Systemic manifestations can occur in multiple systems, then it is known as a systemic manifestation. Single organ is known as distal manifestations. The management has 4 steps. If the patient is having life-threatening airway breathing has been, circulation has compromised, like in any emergency, you have to do activate the resuscitation protocol. So that is resuscitation. But if it is not necessary, you have to go for the D. Under the D of ABCD, there are 3 steps, 4 steps in poisoning management. One is decontamination. The other one is elimination. The last one is detoxification of 3 poisoning management. Supportive care is extremely important in any acutely ill patients. So like in other emergencies, supportive care has a very big role in acute poisoning management as well. Airway breathing circulation, as I mentioned before, ABC is resuscitation. After that, decontamination, elimination, and detoxification, and supportive care. Decontamination is removal of poison from the contaminated surface before entering the circulation. So if you can wash with saline or wash with water, the surface where the surface of contact, which is known as surface irrigation, or earlier there was a method of removal by inducing emesis. So gastric lavage is washing the GI tract with saline to remove the poison. Endoscopic removal of poison from the endoscope by endoscopy. And giving single dose activated charcoal is also a method of decontamination. If you take one by one, we don't use this emesis anymore. So gastric lavage are used in some places, but in developed countries, even this gastric lavage is not happening. Elimination is removal of poison from the circulation. Decontamination is removal of poison from the entering surface. Elimination is removal of poison from the circulation. Giving multiple dose activated charcoal and hemodialysis are some 2 methods we use. There are many more methods I will discuss later. So the main methods are multiple dose activated charcoal and hemodialysis. Detoxification is inactivation of absorbed poison in the body. So detoxification. Decontamination is removal from the surface. Elimination is from the removal from the circulation. Detoxification is inactivation of the absorbed poison in the body. How to perform gastric lavage? So, it is one of the decontamination method. So how to perform gastric lavage, gastric decontamination? So it is been done by inserting a tube through mouth or nose into the stomach, followed by sequential removal of administration and removal of small volume of saline. It should be performed by a very experienced person, and the patient is being positioned in the left lateral position. usually head lower than the feet, which is the Trendelenburg position. And you have to use the largest possible tube. The tube size is the largest possible size, usually up to 24 French gauge in infants. And place the tube, and the placement should be confirmed. Stomach placement should be confirmed by pH testing of aspirated stomach content or X-ray. The usual air insufflation is not a reliable method, which is done in Sri Lanka. It should be discouraged. You can use it in conjunction with other more reliable methods. The best method is pH testing. The stomach content should be emptied. Then lavage should be performed with 10 ml per kg normal saline aliquots. Then usually it comes to 20 to 200 to 300 milliliters in children. And the number of fluid cycles until it depends on the position. It should be performed until the effluent is clear. So it should be done with normal saline. And we have to assure the proper placement of tube to prevent aspiration, because there is a risk of aspiration. So you have to keep suction device always ready. The patient is not conscious, better not perform this procedure. And if you are going to do it in unconscious conscious patient, then the cuffed endotracheal tube should be placed to prevent aspiration. There are so many complications. The one common one is aspiration pneumonia. Other complications include laryngospasm, hypoxia, bradycardia, epistaxis, hyponatremia, hypochloremia, various water and electrolyte abnormalities, or mechanical injury to esophagus and mediastinal organs. So it is effective within 1 to 2 hours with airway protection, left lateral position, wide bore tube. And you have to insert an oropharyngeal airway while the tube is in, because the patient can bite the tube. So oropharyngeal airway should be inserted. And normal saline 10 to 20 ml for 3 cycles and continue until effluent is clear. Though it is a very socially demanding procedure, it has got unproven efficacy and many complications. So if you have to do it in extremely indicated situation, and if the skilled people are available and skilled familiar people with the procedure should be available if you are going to perform it. So single dose activated charcoal. It is a method of decontamination, single dose one. It can be given orally or given via gastric tube. It is effective within 2 hours of poisoning. Sometimes it can be effective more than 2 hours if the substance of poisoning is gastric emptying delay in substance. The dosage is 1 to 2 milligram per kg drinking via orogastric or nasogastric tube. And it is not very much useful for iron, lithium, mercury, like heavy metals, and cyanide, acid, alkali, and alcohol. Now it is been given after dissolving with water, and you should not add any additives like sugar, sorbitol, and substance which promote bowel motion should not be added, because if you add any substance, it can go and bind to charcoal. So you have to keep charcoal surface clear. So you should not press the charcoal and to make tablets or pellets. You have to give it free powder dissolved in water. So it is not recommended if there is no bowel sounds. And even this also has a complication of risk of aspiration. It should not be given if the patient has CNS depression. Whole bowel irrigation is also a method of decontamination. The substance known as polyethylene glycol is being given as a liquid. It is a powder dissolved in liquid. For whole bowel irrigation, it acts as a purgative and dispatches poison from the bottom. It has been given as 9 to 6 years, 9 months to 6 years, 20 milligrams per kg per hour. 6 years to 12 years, 20 ml per kg per hour. More than 12, 1.5 to 2 liters per hour orally. Removal of poison from the circulation, which is known as elimination, done by a technique known as multiple dose activated charcoal. It is worked with the collaboration of this enterohepatic circulation. When the poison is being secreted into gut, the secreted poison is being removed by multiple dose activated charcoal. So it is method of elimination. It takes the poison from the circulation, take out from the circulation. So dialysis is another method, forced alkaline and enuresis, acid enuresis, saline diuresis, multiple dose charcoal, dialysis, extracorporeal removal by hemodialysis and hemoperfusion. So the dose of multiple dose activated charcoal, 1 to 2 grams per kg, drinking via NG or nasogastric tube, dose repeated every 4 hours. Detoxification is inactivation of absorbed poison in the body. So for this purpose, you need some antidotes of 4 drugs. So there is a list of antidotes. So if you are interested, you can copy this list. I give little time. Just take a photograph or copy it. So it will be useful. So these antidotes, some of the drugs are available in our units, some are not. So, however, there are so many poisons, but limited number of antidotes. If available, it can be used to neutralize the poison in the circulation, in the circulation and other tissues. How to assess and monitor poisoning? So, assessment and monitoring done clinically and with investigations. Like in any other condition, the monitoring done with history, examination, general and system examination, and investigations, you do blood counts because some poisons affect blood, and liver and renal functions because liver and hepatic toxicity common in acute poisoning. And to monitor cardiac complications, we do repeated ECG. This is the algorithm we use to manage poisoning. So when poison is being ingested, do not induce vomiting any time. It is no indication for inducing vomiting. If poison is a corrosive or hydrocarbon or volatile liquid, do not do any removal method. If the poison substance is a significant amount, ingestion has occurred within 1 hour. If airway is protected, you can go ahead with decontamination. If ingested occurred more than 1 hour, there is no point doing gastric lavage. Or if the patient is not unconscious and airway is not protected, no indication for gastric lavage. If the substance is which can cause delayed gastric emptying, you can consider gastric lavage even up to 2 hours. So like that, so you have to screen the patient for indications and contraindications and indicate the decontamination. At the end of the gastric lavage, you can put another substance into the same tube. That is charcoal. So this is the protocol for charcoal administration. If the patient present within 2 hours and airway is protected, we can give charcoal within 2 hours. So that is the management of acute poisoning. In summary, the management, you have to do symptomatic relief like pain and discomfort management, vomiting, nausea and vertigo management, wheezing and SOB management, itching and burning sensation management, symptomatic. And then you have to think of, after managing this poisoning, you have to think of any supportive care is needed for the patient. Like if there's a respiratory issue, respiratory support. If there's circulatory problems, circulatory support, hydration, nutrition, electrolyte management, acid-base management, liver function failure management, renal failure management to be indicated based on the patient situation. If there are any specific complications like convulsion, anaphylaxis or hypoglycemia, you have to manage then and there as a part of poisoning management. There are few practical issues, challenges I am going to talk about. One is insertion of tube. When you perform gastric lavage, insert the best possible largest tube and confirming the tube position by pH testing. To my knowledge, I don't see any pH testing kits in our wards. It is very cheap. So if you're interested, you can keep it at home, keep it at ward. And management of vomiting. So vomiting, if patient is already vomiting, do not try to stop it. If patient is not vomiting, do not induce it. When patient comes with suspected poisoning, then you have to go through this proper diagnostic path, check for the manifestations in various systems, local, distal and systemic manifestations to be looked for in all the systems. So that comes to the end of acute poisoning management. Any questions so far with regard to acute poisoning management? Any questions? I have one more part in the same presentation. So this is the summary. If there is acute poisoning, go to ABC steps and DE, decontamination, elimination, detoxification, and always apply supportive care for the management of poisoning. I am going to go through a few pictures of poisonous plants for your knowledge, for your reference. Not going to go through much details. Being Sri Lanka a country with large biodiversity, we have got so many plants. Unfortunately, some of them are poisonous. So various parts can be poisonous. It can be seeds, it can be leaves, it can be tubers or roots. So it can be enter the body, it can enter the body in all the methods that other poison enters: surface contact, GI injection, inhalation, aspiration, and injections. Identification is being considered by familiarizing the plants. So typical plant identification described in the books in botany cannot be applied in our medical profession, but familiarization with poisonous plants are important. So that is why I'm going to show you some pictures. So these are some of the chemicals. I'm not going to concentrate it. These are some of the names of plants which can be poisonous. Kaneru, Hondala, Niagala, Olida, Attana, Endaru, Aduru. So the poisonous substances are most of the time alkaloids, sometimes acidic substances. This is a plant known as Hondala, which has got poisonous substance as cyanide. So it is common in wet zone. This is Gloriosa superba or Niagala. The roots are poisonous. If somebody inserts roots, which can cause presentation like blood and mucus diarrhea and fatal poison. This is Abrus precatorius olida. It's poisonous to children, especially the young seeds. The red seeds difficult to break. So poisoning uncommon. But if child ingests white seed, it can be poisonous. This is Datura stramonium attana. It's a beautiful flower and spiky fruit of the plant, which contains seeds. Seeds are toxic. Fruit of the plant is spike. So other one is Canerunaria oleander. Caneru is another common toxin plant poison which can cause cardiotoxicity. These are the seeds. Behetenderu, Vatenderu, both are poisonous. Vatenderu is less poisonous to Behetenderu. For the Ricinus communis and Jatropha circus. You can see it. Another one is Kaduru, Goda Kaduru, Dvi Kaduru, Vel Kaduru. Those are Trichus taxonica is Goda Kaduru. It is contain the poison known as strychnine, highly toxic substance, which can cause neurological manifestations. Then B. Kaduru is Severa mangus, which cause cardiac manifestations. Sardica causes local manifestations. Calotropis vara causes local manifestations. These foliage plants like Croton, Anthurium, and other groups of various Diphyllobacia. These are some of the plants which can cause local toxicity. I just show those slides to familiar with to identify poisonous plant. Then the prevention. The best part in prevention is avoid their minimum usage. If you are going to use it, do it safely, store it safely, appropriate first aid knowledge, and knowledge on early hospitalization, education, and awareness. So that's going to be in the poisonous plant poisoning. So I am going to tell you a few words on snake bites in children. Snake bite in children. It is also another kind of natural toxin intoxication. The poison is being injected into the body with few venomous snakes. And you are supposed to understand the structured approach to the child with snake bite. To understand the protocol for the treatment of the child with snake bite, Sri Lanka has got, as being a country with large biodiversity, there are a large number of snake species. Most of them are non-venomous. Some of them are venomous. Venomous snakes are few. The cobra, rhesus viper, and crate are always highly venomous. But saw-scaled viper and hump-nosed viper making toxicity time to time.
Sir, Roshani, sir.
Yes, sir.
Slides are not moving. Inside slides there.
Not moving?
Are there slides?
Yeah. Wait. It is not being shared.
Yeah, it's been shared. We have last seen that plants.
Can you see the first slide?
No, you might have to close the current one and restart, sir.
Then restart the whole presentation.
No. I mean, yes.
Sharing.
Yeah, sharing. So it'll be stuck there after this.
I first time take it, stopping sharing, stop it, and again I start sharing.
Okay.
I am going to share the.
All right.
Can you see it now?
Now, yes, sir. We might have to make it full screen.
Right. Now, can you see the movie?
Yes.
Right. So this is the list of snakes I told you. The non-venomous snakes and venomous snakes. Cobra, rhesus viper, and crate are highly poisonous. Saw-scale viper and hump-nosed viper are time to time becoming highly poisonous. Generally, earlier saw-scale viper was considered as a highly venomous snake, but the saw-scale viper in Sri Lanka is a dwarf saw-scale viper. So hump-nosed viper was considered as a moderately venomous snake earlier, but it is increasingly causing renal failure in bitten patients. So now hump-nosed viper is considered as a highly venomous snake. Saw-scale viper is considered as a moderately venomous snake. So these are some of the pictures of snakes. So you can see these various pictures in your wards and various places. But we do not, in Sri Lanka, we have management, we have got only the polyvalent single antivenom. So we do not go by the identification of the snake. We go by the identification of envenoming signs. So as any other emergency, can you see this moving slides now, Prashant?
Yes, I can see.
Okay. So the management is by like in any other emergency, you have to go through ABCD steps. If patient is having cardiorespiratory failure, you have to resuscitate ABC steps. So under D, we apply the snake bite management. So snake bite identification, though it is very interesting in snake bite presentations, not that important because we go by the symptoms and signs of manifestations. Snake bites usually causes coagulopathy, neuropathy, and non-specific symptoms. So rhesus viper causing both coagulopathy and neuropathy. Crate causes neuropathy. Bleeding tendency. When there is bleeding, how do you assess bleeding? You have to assess bleeding clinically. Clinical bleeding, you have to look for bleeding, bleeding from the snake bite site. So venipuncture sites, mucosal bleedings like subconjunctival hemorrhage, gum bleeding, and other mucosal bleeding and hematuria. So we assess bleeding tendency clinically, and we assess bleeding tendency with laboratory testing by PTINR. In the ward, we assess the bleeding tendency with whole blood clotting time, which is a very non-specific test. Then you consider the neuropathy. In neuropathy, the patient can present with many ways. The one method is weakness of body. Other one is ophthalmoplegia, which is ptosis. Sometimes they feel difficult speech, dysarthria. So like that, so there can be several neuropathic manifestations. So there is no investigation to diagnose neuropathy like coagulopathy, but you have to look for these features clinically. So it is very important to study the non-specific manifestations of snake bites. What are the non-specific manifestations? Vomiting, abdominal pain, headache are some of the non-specific features. So when the neuropathy and coagulopathy signs are not dominant, these non-specific signs are important to make decisions in giving antivenom. So how do you manage snake bites? Snake bite management is very simple because in our country, we have got only single antivenom. So don't make snake bite management complicated, because you go by the envenomation signs, you look for coagulopathy, look for neuropathy. If any of these features are there, either systemic manifestations, you start giving antivenom without any delay. Sometimes going through snake identification can be misleading if they bring or if they provide the witness of a different snake. So you have to know how to give antivenom properly and supportive care. With antivenom, you should know the management of respiratory failure, circulatory failure, renal failure, like that, various supportive care, and symptomatic management. The main symptom in snake bite is pain. So when you do pain management in snake bites, due to the bleeding tendency, you should not use painkillers causing bleeding. So you can use paracetamol or opioid analgesics. Better to avoid NSAIDs. And the follow-up, you can do non-routine follow-up is no needing always. But if there is any problems for complications, you can do follow-up. It is very important to know this our antivenom has got very high complication rates. Sometimes the complications are more dangerous than the envenomation. Anaphylaxis is the commonest. So whoever giving antivenom should be very familiar with the use of antivenom, adrenaline in anaphylaxis. So whenever you get anaphylactic shock, you can give repeated adrenaline doses to prevent the deadly complications of anaphylaxis of antivenom. So envenomation can be, as I mentioned, it can be systemic, local, or non-specific. Systemic can be neuropathic or coagulopathic. Then how much antivenom and how to give antivenom. So antivenom usually comes as vials in a powder. So you have to dissolve the powder in water. So you may have seen when you study in the medical faculty, you may have seen these vials, and you have to dissolve it. The powder should be dissolved with sterile water, 10 ml. Every vial should be filled with 10 ml of sterile water and dissolve it. And you have to give 20 vials of antivenin as the first management in Russell's swiper management. In Russell's swiper, you have to give 20 vials. Other snakes, you have to give 10 vials, regardless of the age of the child. Any age, you have to give the same dose. And in children, you are not going to further dilute it. You can directly administer with the syringe pump the reconstituted antivenin. No need to put into another saline bottle like in adults. You can directly administer with the infusion pump, because if you add another saline lot, which can lead to fluid overload. So what are the challenges of managing antivenin? One challenge is managing very young patients. So if an infant or very young child comes with snake bite, the management is the same. The antivenin dose is the same as adult. But compared with the body size, you have to give large volume. 10 vials, 20 vials means 200 ml. So what you can do in that situation is you have to give it slowly. Otherwise, they can get fluid overload. So coagulopathy assessment, as I mentioned you can do the clinical assessment, but you do sometimes the inward whole blood clotting time assessment. When you do whole blood clotting time inward assessment, sometimes it can cause errors due to the wrong technique and wrong equipment. Ideally, standard method, this has to be done using 5 centimeter long, 1 centimeter diameter borosilicate tube. But I have seen most of the time it has been done in penicillin bottles in hospitals. So we have to avoid these practices. We have to get down the correct equipments to do the standard testing. Other one is the neuropathy assessment. Neuropathy assessment can be difficult in the night. In the night, the patient comes with neuropathic problem. They can be ptosis, body weakness, dysarthria. It's difficult to assess at 2 in the morning due to the sleepiness. So that is a challenge. Respiratory failure assessment is also difficult. So if it is difficult, you can use a saturation monitors to assess respiration and heart rate. Sometimes the prolonged antivenin, the prolonged coagulopathy is a problem sometimes, because when we repeated antivenom, still you can have prolonged whole blood clotting time. If the patient is having prolonged whole blood clotting time, then repeating the antivenin, you can manage the coagulopathy. If there is bleeding, you can give FFP instead of giving antivenin, because antivenin, initial 10 or 20 vial is most of the time adequate. If you want, you can go for another 10 vial, and that is all. No point repeated dose of large number of antivenin. Other one is prolonged ventilation in plate. You should remember, in plate bites, you may need to ventilate the patient 2-3 weeks. Then the management of unconscious patient should be applied when you manage plate bite long time. You have to stress the nursing staff regarding prolonged ventilation complications. Other one is use of oxygen in respiratory failure. It is dangerous to use oxygen unless patient is severely hypoxic and dyspneic. For the mild respiratory symptoms, don't use oxygen by mask, because it can mask the respiratory complications. So that is the summary of snake bites. So have you got any questions? Any questions? So I can't go detailed snake bite management due to time issues. So in the absence of questions, I am going to finish my presentation of snake bite and poisoning. If you want to get further details of snakes identification and further snake bite management, you can go to the snake bite SLMA website on the snake bite guidelines, snake bite subcommittee website. I have shown you the link, and there is a separate chapter on snake biting children. You can read it. Thank you.
Thank you very much, sir. Next lecture will be started from 5 minutes. The lecture will be done by Dr. Viraj Jaisinghe, consultant pediatrician at LRH.
Thanks, Nadijan. Give me a minute. Right. Okay. So, good morning, everyone. So, we'll be 1 minute. Right. So, now this lecture will be on approach to an acutely ill patient, the structured approach, right? So, we'll have half an hour to go through it. And if you have any questions while I'm discussing, please feel free to put up in the chat box. I'll be more than happy to answer, right? Right. So, first of all, now right. So the basic thing to understand here is, now see, like when you work as house officer, you will see patients. So these days, of course, there are ETUs in each and every hospital. Sometimes ETUs and the HOs also go to ETUs. Sometimes, of course, in the OPD, if they miss a bad patient, might end up in your ward, right? So we could get really bad patients. So in adults, so the preterm, actually what we are really worried about would be about a cardiac arrest, where, like, we might need to start our CPR and resuscitation, right? So there is a main basic difference between cardiac arrest in a child and in an adult. So in an adult is mainly because of a primary cardiac issue, like say, like a myocardial infarction, or maybe had an arrhythmia, right? heart failure, something like that. But in children, actually, mostly their hearts are very, strong and quite healthy, unless, of course, in children with congenital heart disease, right? But in a large majority, the hearts are fine. But the problem is there is either a respiratory issue, like a respiratory problem, maybe a pneumonia, asthma not treated properly, or a circulatory problem, like, say, a dengue shock or dehydration shock, right? Which is not addressed properly, and then will lead on to cardiac arrest, right? So that's the basic difference. So when you start your cardiac arrest, the resuscitation in adults, it's mainly the rhythm you will have to check, and most of the times it will be a ventricular fibrillation, whereas you will need to shock the patient, right? So that's the primary problem, the cardiac. So you need to quickly shock him, like defibrillate him, right? Whereas in children, it's probably the respiratory issue. So once you start bagging the patient properly and start giving CPR, and maybe if it's a systole or partial electrical activity, when you start, giving adrenaline and nicely ventilating the child, and probably if it's a shock, you give another bolus and see, then they respond because their hearts are healthy. So that's what you need to understand. So two things. One thing is, you have a child with cardiac arrest, please pay attention to the circulation and the respiration, because it's not a primary cardiac issue. That is one thing. And then the other thing is, if there's a patient in your ward who is being monitored first, we'll say dengue, please make sure that his circulation is being monitored properly so that he won't go into shock without you knowing, because that can ultimately lead into cardiac arrest, right? So those are the two important things that you need to think about. Right. So I was telling about the respiratory issues, then the circulatory issues, right? So there are a whole lot of, causes for that. I'm sure I don't need to go through it. So like one or two, if I take, okay. So respiratory depression, child has a ongoing convulsion or poisoning with OP, right? So he's having respiratory depression. That can lead to respiratory failure, which in turn will give rise to cardiac arrest, right? Or we say a child with diarrhea, dehydrated, in shock, not detected, goes on in continues to be in shock, and then results in cardiac arrest, right? So that's the common pathway. Whereas in adults, gets an MI, goes into cardiac arrest, right? Where he needs to be defibrillated properly, right? Okay, like he gets a myocardial infarction, which ends up in a cardiac arrest, right? So that's the basic difference, right? Now, okay, so now these are just like few examples. There are so many ways that acute ill patient could present to you. These are some of the most pre-terminal conditions, right, that could come to you as a house officer. Okay, a child coming with sudden obstruction to the airway. He was playing with some toy, car or something, then suddenly puts something in the mouth, gets obstructed in the airway, comes to you. That's a immediately, life-threatening condition. And also, there is a child who had been at home, had been sick, and then so parents were not too worried, but in the morning they noticed that his breathing rate is not good. So that's a patient with impending respiratory arrest. So that also happens, especially in the early morning hours, because child goes to sleep in the night, right? Probably having some sort of illness, but not so probably diarrhea, right? Dehydrated overnight, parents also sleep. In the morning they find out, okay, his respiratory effort is not good, and they bring in, and you need to straight away intervene. And likewise with intractable seizures, could come with, convulsions. Then, of course, with a slow pulse with poor signs of life, that is, of course, cardiac arrest, right? So these are some of the ways, right? Right. Now, one more thing that you need to be careful, right? There's a huge difference between adults and children, right? Because adults, they have good compensatory mechanism. So we say that an adult has pneumonia, his respiratory muscles are very strong. So he can go on for a long time with the distress, won't get exhausted. But whereas a child, his muscles are not that strong enough, right? So an adult who could, be dystic for about 1.5 days or 2 days without much of a problem, right? Whereas a small infant, if he's very badly distressed, within about 5 to 6 hours, he might get, respiratory arrest. So you have to be careful. Then likewise, so because of that, they can deteriorate very rapidly because their physiological reserves are not very good. Like they are the cardiac reserve, the respiratory reserve, everything's not like in adults. So you have to be very careful. They deteriorate very quickly, right? And they are difficult to assess as well. So you think that this child has a respiratory issue and you want to auscultate, see the respiratory rate, look at the saturation, but the child is crying like crazy, right? You can't go near him. He'll be crying, you won't let, you put the probe, right? And then the saturation probe, so you don't have any idea about the saturation, right? And you can't see whether he's dystic or not, he's howling, right? So that's a difficulty. So you need to really calm this child down before you see him. But at the same time, don't tell the mother, okay, take the child outside, give him some feeds and come, I'll see you slowly, because child could get arrested, right? So you have to keep that patient close to you and continue to somehow calm the child and try to assess him, right? And then, of course, the technical procedures are also difficult with children, because now you would know putting a cannula in a newborn is like 1,000 times difficult than putting the same cannula in an adult, right? So the procedures are technically very difficult. Intubating is difficult, right? Getting intraosseous access might be difficult, right? All these things are very difficult. So children are different that way compared to adults, right? Okay. Right. So this is what you are taught in medical schools, right? So you have a patient come into you, take a history, then examine, then come to a diagnosis, do the investigations, then give appropriate treatment. So this is all right for a stable patient, but not in a seriously ill patient. You won't have this time, right? You can't take history slowly, examine him, and then by the time you start your treatment, patient will be dead and gone, right? So that's where your structured approach comes in, right? So structured approaches, it's systematic. You don't you don't need to think. So airway, breathing, circulation in that order, right? So it's easily learned, can be drilled, you do it. That's why we have these courses, advanced pediatric life support, right? Neonatal life support program, so that, you are drilled. Like in schools, you do a drill. So you it's there in your blood, right? It's there at a spinal level. You don't need to think, right? So easily learned. It's not very complicated. You didn't need to read a lot of theory and stuff like that. Basic stuff, right? And then, so regardless of the diagnosis, so when a child comes shocked, you're not going to see, is it a appendicitis that has caused this and septic shock, or is it a dengue shock? So straight away you start your treatment, your airway, breathing, circulation, fluid resuscitation. Then halfway through, when you are stabilizing the patient only, you will slowly get to know the proper diagnosis, right? So another thing is, when you are under stress, when a patient's life is in your hands, you can't be thinking, should I put the cannula first or should I give him oxygen first? So you can't think. So ABCD is arranged in such a way that the priority is given to the most important areas. So obviously, if a child is in shock and you want to put a IV cannula or intraosseous line, but of course the patient is not breathing, right? Now, no point putting a cannula in a patient who is not breathing, because he's not being oxygenated. So by the time you put the cannula or the intraosseous line, patient would have been dead. So that's why breathing comes before the circulation. So, you don't need to think all this, it's nicely organized and arranged. So you don't, split your hairs thinking, should I do this first or should I do that? But there's a nice organized way, right? So no one finds fault with you and the patient is also safe, right? So that's where the structured approach comes in, right? This is called the blueprint. This is like your, the plan in your house, right? Something like the blueprint is that, the master plan, right? So first of all, whenever you approach to a patient, you should be doctors, DRS, is out of danger, right? You are safe, right? And so you are walking on the road and then you find that a child collapses in the middle of the road, you move the child to the side. Otherwise, you will be a second victim and the child will be further, further damaged by the ongoing vehicles, right? So dangers, outer danger, responsive. So that's the most important thing. You stabilize the head, tap on the shoulder and ask, are you all right? Are you okay? Or what's your name? So if he speaks and all that, he's all right. Other, if he doesn't speak, he might be dead. He might be in cardiac arrest. So you need to really, start your management. So if he's unresponsive, your next thing is S, shout for help. So you have to get this patient to hospital. You need additional help. You need someone to put a cannula. You need someone to intubate. You need someone to get the defibrillator. So with all that, dangerous, responsive, shout for help. So, right, that's what you generally do, right? Okay. So, and the other thing is now just to get an, so this triaging is very important. That is like, identify patients who are really bad and who could wait, right? So in every hospital these days, there is a triaging nurse, right? When you come to LRH, when you come to the OPD, there is a triaging nurse who will triage patients according to the category. So we'll go into that next slide afterwards. So we'll say, okay, the nurse quickly finds out, okay, there is a patient who's having a stridor, difficulty in breathing. So red light, it's a red flag. Quickly get this child to, so we'll say it's a child with difficulty in breathing, right? Audible V's, right? Blue. So quickly get to another red beds in the ETU, right? How do you position? So after your triaging, it's the position, right? You get the appropriate area, prop up the patient so that, the patient finds it easy to breathe. And then your initial stabilization. Airway, how is the airway? Are there any obstructions? No. Then, okay, he's breathing fast. He's tachypnic, dyspneic, has almost a silent chest. Quickly start your oxygen, right? And then, right? And then maybe start nebulizing, right? And then your circulation is fine, we'll say. And then you quickly assess the disability. He's alert, right? So you are not too worried about the CNS. Then when you expose, you find there are multiple urticarial rashes. Okay, could it be an anaphylaxis? That's your next question. Then directed history. Quickly ask the mother, has there been any history of anaphylaxis? Is she allergic to any food or drug? Then the mother says, yes, my child is allergic to cow's milk and he has gone to a party just now. So we don't know, and he has eaten some ice cream. So probably that's the reason. So quickly, right, you quickly assess, right, it's most likely anaphylaxis. Commence your specific therapy. That's your next step. So give IM adrenaline straight away. You had done your basic airway breathing circulation. Now the specific therapy is IM adrenaline. And now you give adrenaline and then the child becomes all right. Then I go, okay, wow, he's fine now. I don't need to worry. Let me go have a cup of tea. No, you need to observe him. So you might need to repeat adrenaline every 5 minutes. You might need to start him on an IV adrenaline infusion. So you're going to continuously monitor him. So that's your basic structured approach. So out of danger, is he responsive? If he's unresponsive, shout for help, quickly triage, right? See which area you should put the child to, then position him in the proper way. Then your initial stabilization with airway, breathing, circulation, disability, exposure, then a quick directed history and examination, right? And then you commence your specific therapy, right? And then your ongoing care for monitoring. Then afterwards, next thing would be disposal, actually, whether you are going to get this child to the ICU or to HDU in a ward, or if it's a very minor problem, are you going to send him home, right? Those are the issues. Right. So this is what I discussed. Out of danger, right? Is he responsive? Send for help. So just a word about PP. Now, of course, the trend is slowly going away because hopefully we are coming out of COVID, right? But then you will need to remember all this, right? At least covering your mask, wearing a face mask, right? And cleaning your hands, right? And then this is triage. So this is called a traffic light system. So we all know red means it's a bad patient, right? Orange means, okay, it's potentially life-threatening, right? But not so bad as the first one, the red one. Green is less urgent, right? So you categorize patients according to the urgency of their illness and get them to appropriate area in an appropriate time. So for an example, asthmatic. So who will belong to red area? Okay, a child who can't speak in sentences, right? Who has a silent chest, saturation is 85. Have severe, significant difficulty breathing. That is a red patient. Quickly get him to a red bed and give appropriate treatment urgently, immediately, no time to waste. Then, what is an orange patient? Okay, same asthmatic will say, but he's dyspneic, right? He's dyspneic, but not so badly dyspneic. His SATs are like 95% in room air, right? Doesn't need oxygen at the moment. But he's tachypnic, he's dyspneic, but not very badly dyspneic, right? So you can have some bronchi. So it's a moderate exacerbation of bronchial asthma. You can't leave him. You can't tell him, okay, come in about 2 hours, right? Come in about 2 hours. I will come in about 2 hours. I will see this patient. You can't see that. So he needs treatment, but not as immediate as the first one. So probably you will put him to orange bed, then, okay, give about 2 back-to-back nips. We'll slowly assess him and continue monitoring. Then there is a patient who comes with okay, doctor, this patient had some cough and, he's not dysnic, he's well, speaks in sentences, eats and drink. But when you auscultate, maybe there are a few bronchi, right? This patient can wait, right? No hurry. So you can treat like an outpatient, give some treatment. So this is very important because at the same time, if all these three patients come, right, you're going to give priority to the red patient. Otherwise, the patient is going to die. Green patient is going to be all right, right? Orange one, if you don't address within a certain frame of time, will go into red, right? So that is a bit more urgent than the green one. So that's why it's important, right? Okay. So just a few red flags. So I just give you an overlook, right? But so red ones means they are immediately life-threatening, like urgently you need to address. Orange, you can wait a bit. Green, they are quite non-urgent, like you see them leisurely, right? So these are some of the red flags that you need to worry. If a child is lethargic, drowsy, right, having decreased activity, right, that's a very bad sign, right? So some of the nurses who had been in our units, like pediatric units for a long time, from a distance, they would say, okay, this patient is not very good. I don't like the look of it, because they don't have in-depth medical knowledge, but the experience tells, right, okay, this is not a very good patient. So whenever you go as a house officer, right, always respect their experience, right? Nurses, even though they have not done a medical degree, they have loads and loads of experience than you. So always respect their word, right? So if an experienced nurse says, I'm a bit worried about this patient, don't say, look, I'll go have some tea and come and see this patient. Always pay attention, see whether, there is something that you're missing, right? So if they are lethargic, ill-looking, decreased activity, difficulty in arousing, that's a very bit of a bad patient, right? And then, of course, if the respiratory effort is, very high or very low or grunting, right? Pale and mortal patient in shock, right? And decreased oral intake, output is reduced, right? Fever with flushed face, right? Those are all very bad patients. Right. So these are the positions that I talked about. So you now did your triage, identify this patient. Now you know it's a patient with status asthmaticus. So how would you keep this patient? Propped up. Severe pneumonia, propped up. Severe stridor, propped up, but you don't try to handle the patient, right? So sometimes if it's epiglottitis or something, you try to hold the fellow and keep him upright. If he goes like he gets agitated, he can go into a spasm, right? So a laryngeal spasm, and then that's the end of the story, right? We will get observed. So stridor patients, don't try to manhandle them, right? Let them manage their own airway, not to mess with them too much. But of course, pneumonia patients, asthmatics, you keep them upright so that all your abdominal viscera will be pulled down by the gravity, so the diaphragm has enough space to move up and down. So eases the difficulty in breathing. And then, of course, if it's a shock patient, you elevate the legs so that, because blood pressure is low. So all your blood, if you stand up due to gravity, the blood will go to your feet. But what you need to do is preserve circulation to the brain. So when you keep them, with their legs elevated, your brain perfusion is, not affected. So you any sort of shock, you keep the leg elevated, right? And then if it's a patient who is having fits or a drowsy patient, keep them left lateral so that they won't choke on their own secretion. So all the secretions will be by gravity will be going out rather than going into the airway, right? And then of course if it's a patient with raised ICP, right, you keep their head elevated. That is because when you keep head elevated and in midline, right? Now, because cerebral edema means you need to help venous drainage. If you don't help venous drainage, if veins are obstructed here, so more edema. So blood will be pooled there and will cause cell edema. So if you keep them upright at 25 to 30 degrees, your venous drainage is very nice, so that your head will the cerebral edema will be less. And if the head is kinked to one side again, these large veins are kinked. So again, venous drainage is affected. So head in midline, propped up, right? Okay. So then you position them, then it's your parallel processes. Parallel means if you can, if there are a few people, someone assessing the airway, someone assessing breathing, and someone assessing circulation and getting a cannula in. So that's what happens in most of the ETUs. So a bad patient comes, the most experienced person with the airway will go to the airway, right? We'll keep the airway open, suck out secretions, maybe need to put oral airway, bag him. Then at the same time, one of the nurses or the doctors will look after the circulation, right? So start putting a cannula, otherwise, because there is a team, right? So that's what you need to do, right? So A, B, C, D, E. This is your assessment triangle, actually, right? So what you do is, right, pediatric assessment triangle, A, B, C, D approach. So as I said, airway, breathing, right? Airway and breathing in this arm, circulation in this arm, and your CNS or your disability on this arm, right? So again, if you look at, so we'll go to the next slide then, where we will elaborate what is to be done in each arm, right? So first is airway, right? So the whole idea is you do this and try to see what is the primary system at fault, right? So with that, you see whether is it a potentially is it a airway issue, right? Is it a respiratory failure? Is it a circulatory failure, or a CNS failure, right? So then whatever is at fault, you try to fix it as early as possible. So if it's in shock, you treat the shock vigorously, right? That's what you do. Okay, so airway assessment. So you will look for normal passage of air. So if it's a talking or a crying child, that means his airway is fine. You're not too worried, right? But then there may be abnormal sounds, right? So a sound like this. Any idea what that is? Can someone put up in a chat box? What sort of a sound is that? Huh? Anyone? Any idea? And the second sound is this. Any idea what is that sound is? If someone is breathing like that, you can put up in the chat box so that I would know, at least you are listening to what I'm saying. Well, if you hear a sound like this, yes, someone's answering. Let me see. Okay. Okay. So the first one was a strido. Yes, right. Like that. So we saw, so you could hear sometimes, right? But then that was a strido. So you would be worried if you have a child with strido. Second one is grunting. Very good. Yes, right. So so one take-home message. So if you have a child with grunting or strido, don't leave them in the ward, right? Without getting your seniors involved, because grunting means what happens in grunting. So he's closing the glottis to maintain a peep, right? So his alveoli are collapsing. He's closing the glottis while expiring to keep a peep, to keep the airway. So if you don't, that's an ominous sign. If you don't support his respiration, he will end up with respiratory arrest. So this patient will at least need a CPAP or a high flow, right? Later, maybe even in ventilation, right? So you need to keep this child, in a very safe area and alert your seniors, right? That's it. So I had seen sometimes, your doctor just writing, okay, granting patient and just keeps in the ward, right? Later on in the night, you find that the patient is arrested, right? So be very careful, please, right? With grunting, strido, and even audible wheeze could be heard sometimes. Then you look at secretions, right? If there's drooling, what are you worried about? Just put up in the chat box if there's drooling from the side. In a child, high fever, there's a very soft strido, and he's like leading to the front, right? Leaning forwards, and then there's a bit of a drooling, right? What are you worried about? Yes, let me see. Yes, very good. Epiglottitis, right? So you don't try to mess with that patient. Be careful. Call your seniors. He needs an expert to handle his airway, right? So then an unconscious child, again, the airway is not protected, because if the GC is below 8, you need to be worried about the airway. So then there are various opening airway maneuvers, right? So for bigger children above 1 year, you try to keep in a sniffing position using the jaw thrust and the head tilt, and then in an infant, of course, you maintain the neutral positions, clear the airway, maybe oral airway would help, but always be worried about a cervical spine injury in a patient with trauma, right? Right. So since we are running out of time, I'll quickly go through these slides, right? So workup breathing. So in breathing, so that was airway. So in breathing, you look at workup breathing or effect of breathing and efficacy of breathing. So effort of breathing means how hard is he breathing? What is the sort of effort? So there are recessions, a tracheal tug, subcostal, intercostal recessions, right? And in a small baby, there may be head bobbing because of sternomastoid use, right? And there may be flaring of alienacy, right? And so those are all important signs of effect of breathing. And then efficacy of breathing is you look at the saturation, right? See whether the saturation is fine, and then look for air entry. How is it very good? This air entry, the air entry is not good. This efficacy of breathing is not good, right? Look for chest expansion. Is he drowsy? Again, if he's drowsy due to respiratory problem, his efficacy of breathing is not good because he's not getting enough oxygen to the brain. So that's the reason why he's becoming drowsy. So he will need some sort of respiratory support, and you need to be very worried, right? So that is your breathing, effort and efficacy. Then one more important thing, cyanosis is a preterminal sign. So if ever there is a patient with a saturation of below 85% in air, immediately call your seniors and get this patient assessed. Of course, there are exceptions like child with a congenital cyanotic heart disease, right? Like a tetrajophil or someone, right? So then you don't need to be worried. It's a chronic problem. But of course, in a respiratory patient or a child who is shocked, the saturation is below 85, please, it's very dangerous. So you need to get your seniors involved and start your resuscitation, right? And so these are some of the signs of impending respiratory arrest, right? That is respiratory rate low for the age. So that means initially he had a high rate for the age, but now he's getting exhausted and it's slowly coming down. And then there is an element of cyanosis. He's agitated, confused because of hypoxia, right? And then you can't hear anything in auscultation. It's because your breathing is very bad, silent chest, right? It's a preterminal sign. Then whatever you're doing, he's deteriorating. So that means he's going to get arrested, will need to be intubated and ventilated, right? Right. So in certain children who are exhausted, or children with neuromuscular disorders, or like CNS issues like raised ICP or poisoning, where raised ICP where the respiratory center is, compressed like due to coning, or if there is poisoning like OP poisoning, right? Then in those patients, even though there is a respiratory failure, it's not manifested as, respiratory distress. So you need to be worried for these patients, because without you noticing that there is a tachypnea, they will go into arrest. So these are some of the parameters. The take-home message is, in children with age, unlike in adults, heart rates, respiratory rates, right, and blood pressures change. So you have to have this sort of a chart in your ward to know whether they are in the normal limit or not, right? And these are some of the RV equipment that we use, right? So I said about the positioning, right? Then you might use simple face mask, then high flow oxygen through face mask and reservoir bag, which gives you almost 100% oxygen delivery, right? And then non-invasive ventilation like CPAP or BiPAP, bag and mask ventilation, and then intubation. So bag and mask ventilation is very important. Even if you can't intubate, it's important to put an oral airway, position them properly, maybe give a double-handed jaw thrust, get some help, and ask someone to ambu with a good seal. Then it's good as you have intubated the patient, right? So don't worry if you can't intubate initially. So make sure that you get a good chest expansion, keep bagging the patient until you have some senior help. So circulation, right? So what are we going to look at? Pulse volume and rate. So tachycardia is a very consistent sign of shock. And then look at capillary fill time, line of coldness, and blood pressure, right? So blood pressure, if it's compensated, like in dengue shock, it will be only the pulse pressure that is narrow, right? Not the systolic pressure might appear normal, right? And then also you can look for a postural drop, right? So this is how you look for capillary fill time. Count, like keep on pressing for 5 seconds. And if you are looking at the fingers or the toes, it should be at the level of the heart. Press for 5 seconds, 1 in 1,000, 2 in 1,000, like that. Then let go and see how many seconds it takes to refill. So these are the normal heart rates. Like, so initially it's very high, then slowly it comes down in children. So tachycardia is a consistent sign of shock, right? good indicator of severity of shock, right? Falling heart rate means maybe if there is no clinical improvement, that is a pre-terminal sign and maybe heading towards cardiac arrest. So blood pressure is very important. The last parameter to go down in a shock in a patient who is going to shock, right? So before that, there'll be tachycardia, capillary fill time will be reduced, and there'll be a cold line, cold extremities, right? So always look out for them, right? And so this is the formula to calculate the blood pressure, systolic blood pressure, 5th centile. So shock, hypertension means 5th percentile of systolic blood pressure. So that is measured by this formula, 70 plus age into 2. Sorry, 70 plus, right? Age into 2, yes, right? So if it's like a 3-year-old, 3 into 2 is 6. The lowest systolic pressure you could have is 76. So if this grew up to 10 years of age, then after 10 years of age, it's generally 90 by 60, right? And till adulthood, right? And then, shock means there is hypertension with poor organ perfusion, like maybe drowsiness, low urine output, tachypnea, that sort of thing, right? So hypertension is a pre-terminal sign. Always act very quickly to save that life, right? Okay. So how to stabilize a shock child? You need access, IV or IO, right? You need to give boluses. So as soon as you get in access, get all these investigations. I'm sure you that told during your circulation lecture. And so boluses are always 0.9% saline, 20 ml per kg, right? And never forget your glucose as well when you're RBS, right? So never forget your glucose when you're pricking. And then after your bolus, you reassess, right? So after every intervention, your ABCD approach, you always do an intervention, reassess, do an intervention, reassess, right? So these are some of the, so there are some types of shock I told her yesterday that you give 10 ml per kg, right? One is cardiogenic shock. So if these features are there, be careful. Don't give too much fluid because that will deteriorate the child, right? So if there's a gallop rhythm or a murmur, enlarged liver, which is one of the most consistent signs in children. You might not hear the bibasal crepitations, right? So it might be the enlarged liver that is giving you a clue. It's a heart failure, right? And then look for marked tachycardia, right? Cyanosis despite good oxygen therapy in cyanotic heart diseases. Then absent femoral passes in newborns, right? So these are some of the pointers towards a cardiogenic shock. And then, of course, your disability, right? Are they drowsy, right? So you can use your AVPU score or your GCS. And then to see whether they are irritable or if they are hypoxic, they could be irritable and agitated as well, or even might have a syncopal attack. So if they are a bit drowsy, always never forget your glucose. Don't ever forget your glucose. So we are looking at these 3 parameters: conscious level, posture, and pupillary signs. So conscious state, I said AVPU. So below PME, if they are only responding to pain, that means GCS is below 8. So be really worried. You might need to protect this patient's airway, right? So if you do a formal GCS below 8, can't protect the airway, you need to intubate them, and you need to probably do a CT, look for cerebral edema, and treat accordingly, right? And these like the modified GCS scoring, right? These are posturing, right? Whether it's decorticate or decerebrate. So decorticate means like this, you have caught the ball, right? It's like you have caught something, right? So these are again features of raised ICP. Then of course pupils, they are sluggishly reactive, maybe equal, unequal. So you will know more details in your CNS, the disability, the CNS assessment lecture, right? And so we had completed disability, and then is your exposure, right? So in children, be a bit careful. Don't keep them exposed for a long time. They'll become hypothermic, right? Look for rashes, fang marks, right? All those things, right? So this is a meningococcemia in your left-hand side. On your right-hand side on top, it's an anaphylaxis, right? With angioedema and arterial rashes, right? So if you work in the periphery in Anuradhapura, Polonnaruwa, Kilinochchi, Jaffna areas, always look out for fang marks, crate bites. There might not be a history. Look for fang marks, right? And so during primary survey, you identify the primary system at fault and you correct that. That's what you do, right? And then again reassess. So again, you do an intervention, reassess, right? That's your most important thing, and then continue to monitor, right? So this is how you take a quick directed history. Ample is the mnemonic, allergies, medications, past medical history, last meal and events, and your pain assessment. And then specific therapy, I told you if it's anaphylaxis, maybe adrenaline. If there are fang mark snake bite, might need to give antivenom, right? With acute stridor, you might need to intubate or give steroids like that, right? So ongoing care, you need to reassess. So there's a patient whom you have stabilized, you can't go away, be with that patient and continue monitoring that patient, right? And then if necessary, you send him to the ICU or to a general ward, right? So transferring is important, handing over is also important. So medical patients, you hand over according to the IS bar system, introduce yourself. Okay, good morning, I am the house officer in medical ward. Situation is I have a patient with anaphylactic shock following ingestion of cow's milk. A background is he's a known child with cow's milk allergy and gone to a party, taken some milk, and afterwards presented with the blood pressure of this much. These were the parameters. So we had given two doses of IM adrenaline. That's your right. That's what you had done, and then given a fluid bolus as well. So your recommendations would be to monitor these patients every 5 minutes if necessary. Maybe start on an infusion of adrenaline if there are any more episodes. So probably you would take recommendations from the other side as well, from the ICU, from the intensivists, because they are more knowledgeable about bad patients than a generalist, right? So you can always get some feedback and then do accordingly, right? So surgical patients, the trauma patients, this is how you hand over. So the basic identification stuff initially, and then mechanism of injuries that were to be observed, and then what are the vital signs and what sort of treatment you gave, right? So in summary, right, don't make diagnosis, blueprint, remember the structured approach, right? Primary survey and resuscitation, ABC, right? So neurological is disability and disability, right? Then afterwards, so you correct these primary system failures at the halfway through with your directed history and examination, you probably would come to tentative diagnosis, your secondary survey and stabilization, and then hand over to a disposal to a proper place, right? So I had to rush through the last few slides. I hope it's clear to you. Any questions that you need to ask? Okay, so thank you very much. I think Dr. Sandhya Dulawire will be doing the next lecture. So, Nadishan.
Yes, sir.
Ask Dr. Sandhya.
Yes, sir.
Logged in?
Yes, sir. She's logged.
All right. Okay. Thank you very much.
Thank you very much, sir. Next lecture will be delivered by Dr. Sandhya Dolavira, consultant pediatrician.
Can you all hear me?
Yes, madam.
Right, okay. I hope I have shared the screen.
Yes.
Right, okay. So good afternoon, everybody. Next lecture will be on vascular access in children. So even though the topic sounds very simple, it is an important topic because you know almost all the patients admitted to the hospital need some kind of a vascular access. So in children, it's often challenging for obvious reasons. You know, they are the vessels are very tiny and they are not as formed as the adults, and also you will have to sort of perform it in front of the stressed parents. So it's quite challenging. Therefore, you need to master the art of it and develop hands-on skills on vascular access. So what are the indications of vascular access? You may have to give IV fluid to correct dehydration or to maintain hydration, especially for those who are unable to tolerate sufficient volumes orally. Then to administer drugs or medication, transfuse blood or blood products, and also to draw blood for investigations. So there are certain important principles that you have to follow when obtaining a vascular access. It has to be done in aseptic conditions. Safety is very important for both the patient as well as the performer, and throughout the procedure, both parties have to be comfortable. Vascular access is of three types: intravenous, intraarterial, and intraosseous. So whether it is in children or adults, the basic approach is the same. So first we will talk about the intravenous access. There are a couple of basic principles you need to know. Firstly, always use the patient's non-dominant hand to minimize the effects of hand function. Then, you need to have a good knowledge of the venous plexuses of the hands and feet. If you can remember your anatomy, you can see a venous plexus in a good venous plexus in the dorsum of the hand, then the ventral aspect of the forearm, and also dorsal aspect of the legs. So it is always better to use these places when you are trying to trying to get the venous access. Then you have to ensure the peripheral perfusion is satisfactory. If not, think of moving to an alternative method. Otherwise, you will waste all the peripheral veins for future use. The other important thing is we have to first try the distal veins and then move proximally, because if you first start centrally and if you are not able to get into the access in the first place, then you will not be able to use the rest of the vein, the distal part of the vein, as it is already punctured proximally. There are certain areas where you should try and avoid cannulation. For example, veins over the joint flexions. Then junction of two veins. As in this picture, veins close to picture, always you have to avoid the, which is marked actually, you have to always avoid the junction of two veins, right? And then veins close to the arteries and deep line vessels. For example, the veins in the median cubital fossa and the elbow, which is close to the cubital artery, always better to avoid. Then the small visible but impalpable veins. You have to always find a palpable vein as much as possible. And the next thing to avoid is a bigger veins initially. For example, things like great saphenous veins and cubital fossa veins, because these veins should be preserved for venous access for in case for PICC lines or central lines, or you will have to reserve for difficult blood sampling. There are a few contraindications for peripheral use. So what are those? Sodium bicarbonate, inotropes like dopamine and dobutamine, calcium gluconate, high concentration dextrose, thiopentone, antibiotics like clarithromycin or flucloxacillin, better to avoid, because all these medications having a higher osmolality than plasma can cause irritation, causing venous necrosis and sloughing of the skin. So this is actually not an this kind of complications are not an uncommon event in the past, and there have been instances where the amputation of the limb has occurred, and also there have been leading to legal implications as well. So if you happen to give these drugs through a peripheral line, you have to give it very slowly with adequate dilution. So what are the equipment needed for vascular access? So prior preparation is important before any procedure. So what are the equipment needed for vascular access? You need to have peripheral IV cannula of various sizes, then anesthetic agents, then syringes of, again, various sizes, 2 cc, 5 cc, and 10 cc for flushing purposes, and as well as for to collect the samples. Then you need to have syringes to withdraw blood for investigation purposes, hypoallergenic plasters, tegaderm, bandages, scissors, and bottles to collect blood. So keep everything at your hand before starting the procedure. Then IV cannula should be in good quality. What do you mean by good quality? Good quality cannulas can be inserted very easily, and it will permit optimal flow rates, then minimum discomfort to the patient, and there should be injection port, and the lifetime has to be long, and it has minimal complications. So with practice, you will be able to come to this judgment to tell that it's a good quality cannula or not. So there are various gauges in cannula. As you can see, when the size of the cannula increases, the gauge number decreases. There is a color code to make the matters easy. For example, the purple and yellow cannula are for newborns, blue for pediatric patients, pink, green, white for adults, and gray and brown for adults who need rapid blood transfusions. It's easy to remember with the color code. So let's move on to the procedure itself, right? So as I told you, local anesthesia is very important. There are pharmacological strategies as well as non-pharmacological strategies to minimize pain. When it comes to the pharmacological strategies, there are 2 drugs available. We have EMLA and Amitop. We have EMLA frequently being used in our country. And there are clear differences between the two. For example, the onset of action is rapid with Amitop, and also Amitop causes less vasoconstriction. And before using them, it is always better to mark the vein on the skin with a marker pen, because with the vasoconstriction, the veins can get lost or faded after the application. How long will it take to get the action? It will take about 20 to 30 minutes. So it is important to apply them well in advance and in more than one area as well, because in case if you fail in the first instance, otherwise you will have to wait for another 20 to 30 minutes, go to another way. When it comes to the pharmacological strategies, the things that we can do is, you can do kind of a distraction. You can get the distraction, the child distraction away from the procedure, right? The things that you can do is that you can ask the mom to speak to the child. You can show something like soap bubbles, toys, moving animated clips. The smartphone will be the best one available these days, right? Things like play therapy. Actually, in the Western countries, there are designated people to do this job, to get the distraction. They would sort of dress like a kind of a like a cartoon character and using play therapy, so that they will be distracted, the child move from the procedure. The next important thing is getting the vein prominent. I'm sure you would have tried some of all these steps during your the undergraduate period, right? So what are the things that you can do? You can ask the patient to clench the hand and try to pump some blood. Then you can keep the you can sort of allow the arm to hang over the bedside, keeping at a level below the heart. Then warm the extremities by wrapping with a warm towel or dipping in warm wet water can be done, and this is especially useful in newborn. Then you can sort of tap on the vein very lightly so that the vein will get permanent. And lastly, the application of tourniquet, right? So you have to create an adequate venous pressure by applying a tourniquet or with your hand grip to obstruct the venous flow. But we have to make sure that it's not too tight to obstruct the arterial flow. So once the vein is prominent, first you have to clean the area with betadine and alcohol. Then select the straight section of the vein, not the tortuous part. When you are puncturing the skin, you have to do it about 2 to 3 millimeters away from the vein. Then go through the subcutaneous tissue to prick the vein. So while the needle is under the skin only, you will be pricking the veins, because if you do this way, the skin layer will act as a barrier and it will prevent leakages. And also, if you sort of try to puncture the vein on top of the vein can sort of slip away, right? So you puncture the vein 2 to 3 millimeters away from the skin, then go through the subcutaneous tissue to prick the vein from while it is under the skin. Remember, when you are selecting the cannula, it has to be a thing that will not completely occlude the vein. So how do you know that you have entered into the vein? You will see the presence of blood in the flashback chamber. So at the moment you see the blood in the flashback chamber, you need to insert the cannula a little further and then remove the stiller. And you have to make sure there is a free flow of blood from the cannula. Let's move on to some common problems you may face during the cannulation. Think about a situation with the insertion of the cannula, you will see the blood in the flashback change, right? Now, as I told you, you will be advancing the cannula and remove the stiller, but you will realize the flow has completely stopped. So this happens when you are taking the stiller out, you have realized the flow has stopped. So what would have happened? If you look at this picture, you will notice the tip of the stiller is pointing a few millimeters beyond the cannula proper. So what would have happened in this case was, once the stiller has punctured the vein, blood would have come to the cannula, but unfortunately the cannula proper is still outside the vein. You can see in this picture, right? So that's why when you pull out the stiller, the blood flow stops. So how to overcome it? You have to reinsert the stiller and advance the cannula further before removing the stiller. Another situation is with the insertion of the cannula, again you will see blood in the flashback chamber, and upon advancing you will realize the blood flow has stopped. So what would have happened here? When you are advancing, you have realized the blood flow has stopped. So if you look at the picture here, you can see the cannula has gone through and through. So no blood flow with the cannula, no blood flow because the cannula has again punctured the opposite side of the wall as well. So in this situation, if you withdraw the cannula a bit, then you will see a free flow of blood, right? So how to overcome this kind of a situation? So with the free flow of blood from the cannula, you have to attach a 5 millimeter syringe filled with saline and advance the cannula while flushing the vein. Because if you advance just as it is, there's a possibility that it can go to the same false passage. So without the stiller, you have to insert it again. You withdraw it until you get the good flow, and then attach a 5 ml syringe filled with saline and advance the cannula while flushing the vein. So this will open up the vein, allowing the cannula to stay in the vein. So those are the few problems that you may encounter when you are inserting a cannula. Then proper anchoring is very important, not like in the first device here. Otherwise, the whole effort you took so far may be in vain, right? So when plastering, you have to make sure the cannula tip is clearly visible to identify early signs of infection or leaking. You can see it in the second picture. So first put a plaster across the cannula, then on either side over the two wings. Then you can apply a tegaderm over it. And in children, it is always advisable to use the hypoallergenic plasters, not the sticky plasters. And splinting is generally discouraged because it can deprive them with the hand functioning and they will be really irritated, right? So as much as possible, avoid splinting. After the insertion of the cannula, you have to always check the patency of the cannula by giving a flush. And it is always advisable to attach a LS connector in children so that there won't be any additional weight on the cannula. So all the syringes can be connected to this using a three-way valve, so less chance of pulling it out. And the other important thing is once you have inserted the cannula, you have to always record the time and date of insertion. And how long you can keep a single cannula, the maximum would be 72 hours. Otherwise, it can cause a venous thrombosis as well as can lead to infection. So even the cannula is functioning properly, it is advisable to resite the cannula after every 72 hours. What are the complications that you can get with cannulation? Most of the complications are actually iatrogenic, things like hematoma formation, then infiltration of the subcutaneous tissue with IV solution, causing vasospasm, ischemia, gangrene of the distal extremity. Then during the forced flushing, you can cause embolization of the vein with blood clots, right? Air embolism can happen. Then accidental injection of infusion into an artery. And the commonest will be sepsis, phlebitis. So if you are using how do you identify the block cannula, right? That can be done clinically, or if you are using a syringe pump, there are 3 indicator pressure valves to show the level of resistance to flow, right? So clinically means when you are giving a flush, you will feel a kind of a resistance, right? And with the syringe pump, there are 3 indicators, and so that will be lit depending on the degree of the resistance. So if you suspect any kind of a block, you have to flush the line with heparinized saline to liquidify any clot. So if the line is still not working, you will have to resite the cannula. This slide shows how to get into an external jugular venous access, and this is a very good vein to access in collapsed patient, but you need the experience to do it. So the procedure is you have to place the child about 15 to 30 degree head down position, keeping a pad under the shoulders, and you have to turn the head away from the side of the puncture, clean the skin of the neck as usual. Then you can identify the external jugular vein when it passes over the sternocleidomastoid muscle at the junction of the middle and the lower third, right? So when you see the vessel, you can ask the assistant to place his or her finger at the lower end of the visible as in this picture, and so that the vein will be, you can stabilize the vein as well as the compression will cause the vein to be remain distended, right? Then entering the vein and anchoring is as same as for the other peripheral veins, but you have to ensure there are no air bubbles in the tubing before attaching the giving set. Otherwise, you can cause air embolism directly to the heart. In rare the difficult cases, rarely we will have to use the sites like scalp or you can you will have to do a venous cut down. So these actually, the scalp vein cannulation and venous cut down, actually not really in use now, because there are safer methods using ultrasound guided cannulation is possible in difficult cases. But in case if you happen to go to a periphery where the ultrasound is not really accessible, you can try the scalp cannula or venous cut down, right? So when you are inserting the scalp cannula, as you can see in this picture, you have to shave the area, can select the arteries like the veins like frontal or superficial temporal veins, and you can use a butterfly set filled with saline to cannulate do a scalp cannula. So for the venous cut down, the commonly used site are the great saphenous vein at the ankle. Then we'll talk about umbilical venous access. This is very commonly used in newborn, especially in preterms, and it is a kind of a central venous access, right? So in an emergency situation, if you get a child, a newborn who is collapsed, needing resuscitation, UVC, all the peripheral veins will be collapsed. So in this situation, UVC will be very useful, and also in preterms to deliver drugs, parenteral nutrition, right? And also to do the exchange transfusion. So this will prevent multiple cannulation in preterms, causing preventing them getting infected. So if you remember the anatomy, what is the position of the umbilical vein? There are three vessels in the umbilical cord, as you can remember. The two arteries are placed more caudally, and vein is a kind of the arteries are like cords, and vein is a kind of a slit which is placed more carefully in more cephalic position, right? So we have to identify the umbilical vein, and the length to be inserted can be in an emergency situation. You can sort of directly measure the length from the cord base to the sternum and add the cord stump length, right? So that much you have to insert. But if you are doing a sort of long, you have to planning for a long-term UVC insertion to give parenteral nutrition and the other things, then there's a formula shown in this picture to calculate the length of the catheter, right? So the size of the catheters, generally we use either 3 or 5 femtograde. And once, unless in an emergency situation, you have to always confirm the catheter tip by taking an X-ray. The level has to be in the T8 to T9 level. You can see the blue line here, which is a UVC. T8 to T9 level is the preferable position. Femoral vein or internal jugular venous access is done through ultrasound guidance. So this is a very safe and effective way of getting the central venous access. But you have to remember, it is not without danger in an unexperienced hands. Then we'll talk a bit about PICC lines, peripherally inserted central lines, right? So catheter is inserted through the peripheral lane in the arm or in the femoral vein. And there are special catheters for this. And you can get an idea about the tip of the catheter by taking an X-ray again. It should lie just outside the right atrium. Then the other thing that you need to know about is about the butterfly needles, right? So what are the indication for butterfly needles? To obtain blood cultures. If you happen to take or obtain blood, get a blood culture without IV cannulation, you can use a scalp vein scalp cannula, right? And then just outpatient basis or for the scalp vein cannulations, as I told you earlier. So let's move on to intraosseous access, right? So this is indicated especially in the collapsed patients, especially in cardiac arrest. If you don't have peripheral access, then intraosseous access is very useful. And also it can be used as if you fail to attempt to IV access by experienced person, again you can move on to intraosseous access, right? So IV needle can be placed either manually or with an easy IO drill. This drill is a powered device that enables rapid insertion of the intraosseous needle. So this procedure with the drill is less painful due to its rapidity, so that you can use it even in a conscious victim, right? So manually you can use up to the age of 8 years, and gun can be used at any age. So as you can see, there are the 3 lengths with a color code, but they all are in the 15 gauge. The length of needle will be depending on the size or the patient, the size of the patient and insertion site. You can select the correct needle for the patient. So if you take the location, it's the same for the manual insertion as well as the drill. The commonly used sites in Chile are proximal tibia and distal femur, right? It's anterior, if you the tibia is 3 centimeters below the tibial tuberosity. Femoral is the anterolateral surface 3 centimeters above the lateral condyle, right? So you have to stabilize the insertion site with your non-dominant finger and firmly hold the drill or the manual needle with your dominant hand. So position the needle tip at a point of insertion, and you have to go perpendicular to the long axis of the bone, right? So if you are using the manual needle, you have to advance the needle with a moderate pressure with a kind of a to and fro rotary movement, right? And once you do that, you will feel a sudden loss of resistance. So that means that you have in the marrow. If you are using the drill, all what you have to do is squeeze the trigger while applying a steady downward pressure, and you will feel again the sudden loss of resistance. So it is important to point when you are putting it perpendicularly, but you should never insert it towards the growth plate, right? It has to be away from the, always away from the growth plate, right? Then when you're anchoring, as in the other cannula, you don't have the wings. So when you're anchoring, you have to use a kind of something like shown in the picture. You can put an artery forceps and anchor the forceps into the patient. There is a background noise. Someone is keeping the mic on. Okay. So you can give any drug or fluid which are giving peripherally, can be given through the intraosseous needle, and you can do any investigations as well. But only thing is, when you are writing the request, you have to always write that it is a marrow sample, otherwise the interpretation will be wrong. So a little bit on bleeding for sampling. In children, it is difficult to draw blood directly into the syringe as you do in adults. So either you can do it by collecting the drops straight from the needle to the butterfly the tube, or you can use a butterfly catheter, right? So we were juniors, we used to break the needle, separating the plastic hub from the needle, because it will prevent clotting at the hub, right? So, but it is not recommended now, because there have been instances the needle has been lost in the veins, right? So in special needles, which is in the bottom of the slide, which is very safe, but we don't have it in the government sector. We have it in the private sector, but not in the government sector. But you can sort of make something similar to that by cutting the plastic part of the scalp cannula, right? So at the junction between the needle and the plastic part, if you cut it there, you can make a similar type of the needle, which can be used to draw blood for sampling. For capillary sampling, the sites that are used are the heel, fingers, and the earlobe. So when you are using the finger prick, take the midpoint between the edge and the midpoint of the finger, right? You should not never put it straight at the midpoint, because that will directly go to the bone underneath. Then with regard to the heel prick, especially useful in newborn, the area to puncture are shown in the diagram. You can see there are two lines, vertical lines drawn downward from the center of the big toe and center of the fourth toe, right? So you have to select the area that are lateral to the lines, which is marked red in this picture, because in the middle part is very sensitive and it is close to the underlying bone, right? So avoid the middle part, you have to go laterally. So the other two pictures show how to hold the foot for capillary sampling and how to collect blood to a capillary tube. So moving on to arterial cannulation. So what are the indications for arterial cannulation? Maybe to monitor arterial blood pressure, then obtain blood sample for blood gases, or calculate the cerebral perfusion pressure. So it has to be performed in sites where there is a good collateral circulation, right? So in children, the preferred sites are the radial, posterior tibial, dorsalis medius, or ulnar or femoral arteries, right? So this picture shows how to perform the Allen test to demonstrate collateral. What you have to do is you have to squeeze all the blood from the palm towards the forearm until the palm is very slow, very pale. Then you have to obliterate both the radial and ulnar artery at once. And if you want to cannulate the radial artery, you just block it and release the finger on the ulnar artery. So if the hand become pink, that means your ulnar collaterals are working, so that you can easily, safely use the radial artery for arterial cannulation. Then probably you have seen the vein weavers, right? So they are used in difficult cases, but they are very expensive actually. So what the mechanism of the vein weaver is, they will emit the infrared light, which is absorbed by the hemoglobin in the blood. So the vessels are clearly visible, but they have a limited use because they are not helpful when circulation is collapsed, because I told you it detect the hemoglobin. So if the blood flow is not there, no hemoglobin, you won't see any kind of a the vessel. So in collapsed patient, it's not useful, and also it gives only a two-dimensional view. Therefore, difficult to judge the depth of the vein, right? However, it's useful in certain situations. For example, if all the superficial veins are exhausted or damaged, and if you need to get an idea where the deep veins are there, then to get an idea where they are, you can use a vein weaver. On the other hand, the picture on the right bottom shows a cold light. So that actually gives some idea about the depth as well. So especially useful in, again, newborn, when you want to, especially when you want to do a long line insertion. So vein weavers and the cold light are the appliances that we can use to get our job easy, right? Okay, so these are the few things that I want to tell you. Any questions? You can use the chat box if you want to ask any question. So the take-home point that I want to tell you is, as I told you, it is important that you are maintaining the hands-on skills, right? Because you may be called for a difficult venous cannulation. Generally, peripheral venous cannulation in our setup is done by the nurses, but you will be called for the difficult cases. So to handle a difficult case, you need to have the hands-on experience, right? So always when you go to when you start your clinical practice, whenever you get the opportunity, try and practice the cannulation and sampling, right? Okay, thank you.
Thank you very much, madam.
The lunch, right? Sir, the next is the lunch break, sir?
Yes, madam. The next one is the lunch break.
Right, okay.
Lunch break until 1:15. Next lecture will be start soon.
Okay, right. We are a bit behind time. So I'm Dr. Sridhar Disilla. We'll be talking to you on transport and stabilization critically ill children. Now, there are a few basic principles. One is you may transfer patient within the hospital or maybe from hospital to hospital. Mode of transport, very often ambulance, not by other means in our setup. Then we need to stabilize and prepare for transport. And we need to identify problems during the transport. And then how do we handle it? So there are key differences between transporting children as opposed to adults. One is children can get hypothermic, and that can adversely affect. And equipments are different. The sizes are different. And equipment failure is common. Dislodgement is higher. For example, ET tube can get dislodged very easily in pediatric patients. Then like probes, like saturation probes, is different and sometimes hard to find. Then very often we need requirement for sedation and paralysis because they struggle and then try to dislodge all the tubes. And we have to accompany a parent or guardian because children are not transported alone. So we need to get the parents or guardians in the ambulance. Now, type of transfers, the scene run is when we pick up patients from the scene, that is pre-hospital care. So inter-hospital, as I said, within the hospital. Inter-hospital is within a bit from one hospital to another hospital, and that can be international as well. So the pediatric transfers for any transfers in the healthcare is referral hospital driven in our setup, not retrieval. Retrieval is you go and get the patient from a small hospital to bigger hospital. Backup transfers is when a patient get better, you send us again to the small hospital. So what we need to ensure is, we are transferring the right patient, right time, and by the right people, and to the right place, and by the right form of transport, and making the right environment, and receiving the right care throughout. So these are the basic principles in transporting. What are the principles during transportation? Shared care. It's not only the referring hospital that we say we have a patient that we need to transfer from Avisaville Hospital to the NHSL hospital. So both Avisaville Hospital and the NHSL unit should have a shared care on this patient. The transport team is clinically isolated. If something happens, you have to get advice either from the receiving hospital or from referring hospital. Resource limitations. We don't have all the equipments in the ambulance or during transport. So there may be limitations in the resources, like we only have a doctor and a nurse. Very often you will find that most junior doctor and the most junior nurse is assigned for this job when you start working. So you have no experience, but in spite of that, you need to transfer. So this will happen during your internship. Then unfamiliar equipments. The equipments that is in the ambulance are not familiar, never used by you earlier. So therefore, you have to familiarize how to operate this equipment. When the patient gets into trouble, if you start operating, it might not be very successful. Then movement and safety. So when you move the patient from the patient's bed to the ambulance bed, there are issues because we need to find out, you have to decide which tubes or which connection should be disconnected at last and then connected at first in the on the transport stretcher. And how do you load the patient and how do you make sure the patient is safe in the ambulance? We have good straps in the ambulance to make sure, and connect the patient again to the oxygen supply in the ambulance, and the sucker is working. So all these things matters. So therefore, movement and safety issues are there. Then physical and physiological changes. So when the ambulance is moving fast like this, the patient's hemodynamic can change. When the ambulance driver actually apply brake, all of a sudden, there can be hemodynamic changes. When the ambulance takes acute bends, then there can be hemodynamic changes in the patient and as well as the staff. Sometimes the staff start vomiting. So if you are going in the ambulance, in the back of the ambulance for the first time, and sometimes you get sick and you will start vomiting. So therefore, there are changes that can happen during the transport. So this is the guide that we go for the transport lecture: assessment, control, communication, evaluation, prepare and package, and transport. So we call it acronym ACEPT. So these are acronym that we use: assessment, control, evaluation, prepare, and transport. Now, it's better to have a form like this before you, when you want to transfer a patient. What does it say? The name of the referring hospital and the name of the receiving hospital here. Then who is referring? Referring hospital's doctor, MO, and the contact number. The receiving hospital, MO, and the contact number. Then whether the transport doctor is fully trained to undertake the transport, and so much, and so is the nurse. And sometimes whether if you are tend to vomit, then whether you have received antiemetic before starting the journey. Patient's biodata, name and illness. What are comorbid issues this patient is having? And what is the category of this patient? So newborn or medical problem, surgical, trauma, and possibly diagnosis. What are the reasons for request? Whether respiratory arrest, impending breathing difficulties, cardiac arrest, shock, compensated or uncompensated, and other security issues. Okay, then convulsions, deteriorating level of conscience, raised ICP, other neurological problems, gastrointestinal problems, renal, surgical. And so this form of transport, this form of form, we have developed by College of Pediatricians. You can use it for transferring patients. Then the assessment, initial assessment is important by the referring team. Like a patient is transferred from Avisavira to National Hospital, Avisavira team should do the initial assessment. And they have to decide their transferring actually make it's needed. And you have to stabilize before transfer. And also you have to find out degree of urgency. And you find sometimes in your medical schools, you learn extradural hemorrhage after fall, extradural hemorrhage, subdural hemorrhage. Sometimes you don't have to, you have to transfer immediately because these conditions need immediate interventions. Otherwise, the patient is going to die. And if you have a ruptured some splenic rupture coming into, you had to transfer immediately because you had to, if you can no facilities in your hospital, you had to save the patient, in transfer immediately. So then, so the assessment, some of the parameters that we do before we transfer in saturation monitoring, is the respiratory functions is good or not, carbon dioxide monitoring, if it's intubated, then pulse rate and rhythm, NIBP, urine output, core temperature, and arterial blood gas. These are the things that we mean to do. So the transport team, you need to identify who the leader in the transport team, like a doctor is a team leader basically in the ambulance, and identify the tasks that need to be carried out before transferring. Anticipate the problems that this patient might going to have, and do you have adequate equipment to use in the case of emergency? And allocation of clearly defined roles to the members is important. So it's a good communication. There should be good communication between referring hospital and receiving hospital. So the referring hospital doctor, the hospital doctor should contact the receiving hospital doctor, and then you have to agree on what is the problem, the reason for the request. And you need to listen to the receiving hospital should listen to the referring hospital doctor, what they have done, and what is the condition of the patient now. And you have to summarize the agreed plan. So therefore, when you decide on the transfer, it's important what is the indication and where is this patient going and how long it's going to take and what is the environment like, the ambulance environment is like, and what are the skills you are competent with, and what is the patient's condition. So whether you are transferring for a specialist treatment or specialist investigation, which is not available at the referring hospital, and special facilities not available at the referring. So these are the reasons that you transfer. But you need to, during the transfer, you have to be ready to face this type of challenges in the transfer. So even you evaluate a patient who's awaiting transfer, you need to decide whether it's an urgent transfer or time-critical transfer. The stabilize and how best this patient is stabilized, and which staff and what equipments, and mode of transport. So the communication should take place on the IS-bar format. You know IS-bar format. IS-bar format is who am I and who are you, the situation, background, assessment, and recommendation, and documents that is needed for the to hand over to the patient. So prepare and package. You need to stabilize the patient and prepare for the transport team. So during transport, you have to make sure that the patient is secured, patient is safe, and the equipment is functioning, and staff is competent in handling. And transport teams sometimes need to be insured. So again, before we transfer, you have to make sure the patient's A, B, C, D, F is good. Therefore, don't forget glucose. Then adequate airway and respiratory support. Venous access, at least it's 2 wide bore cannula or intraosseous needle. Adequate fluid resuscitation to optimize treatment. Then spinal injuries, immobilize. And time-critical injuries in the brain and other organs, need to call the specialist before you leave. I said EDH. If you are transferring an EDH patient from your hospitals to a bigger hospital, you have to make sure that the surgeon, general surgeon, or the neurosurgeon is available by the time you take the patient to the hospital. Otherwise, there will be a lot of time wasted in removing that, and patient's life will be in danger. So therefore, this is important to identify time-critical transfers. Now, there are a lot of equipments like this that you need to carry in the ambulance. airway equipments, the breathing equipments. So you basically can't remember all these equipments, isn't it? And it's important to carry the oxygen, number of oxygen cylinders that you need to carry. So if you have, it depends on the distance. So the formula is the duration of the journey. So the journey is from Avisabil to Colombo South, Colombo National Hospital. It takes about 1 hour, sometimes maybe 1.5 hours, so 90 minutes. And then the flow, how many flow of meters that you, how many flow each patient is getting? The patient getting 10 liters per minute of oxygen or 15 liters per minute oxygen. Then times 2 and divided by the cylinder capacity. So you have bigger cylinders and small cylinders. So you should know the capacity of the small cylinder and a bigger cylinder. So basically, like I mean, as far as I can remember, the cylinder is about 10 liters or 15 liter cylinders. So you need to capacity liters divided by. So then you get the number of cylinders that you need to carry, because otherwise there has been instances where the oxygen has run out during the transfer, and then patient gets hypoxic and patient dies. Therefore, it's important that you calculate this, make the calculations on this formula and decide the number of cylinders that you need to carry. If you have any difficulty, you can actually always contact the intensivist or the anesthetist in the hospital and ask them how patient is on 10 liters per minute of oxygen, so might need 15 liters per minute, and how many cylinders should I carry? Should I take in the ambulance until I reach the receiving hospital? So this is something that you need to think about it before you transfer. Again, the circulation, there are a lot of equipment that you need to carry. ECG monitors, blood pressure, NIBP, pulse oximeter, then cannulas, intravenous infusions, and three-way trap, and all these things. Drugs, fluid and drugs, there are a lot of things. What drugs need to be taken in the ambulance, and what the drugs need to be diluted and prepared. Like sometimes adrenaline, we have 1 in 1,000 adrenaline, so we have to prepare 1 in 10,000 adrenaline because there's no time to dilute in the ambulance. And we need to carry diluted or made inotropes in case patient needs. So these things, so drugs required during transport, infusion prepared, medication for emergency situations, and what drugs should be drawn up into the syringes and be made it ready during the use. And how do you, once you get the patient, how do you transport, how do you shift the patient from patient's bed to the ambulance bed with all these lines in the patients, maybe ET tube, maybe sometimes IC tube, and how do you secure this trolley in the ambulance without going up and down? Of course, we put the patient and use the straps of the patient. And this chest drains, when should be disconnected or clamped? And the blankets, you need to carry blankets because patient can get hypothermia. So you have a lot of checklists, as I said before. There are checklist to checklist. If you have a checklist, it's easy, a lot easy. Checklist some of the points in the checklist is ET position. Then the suctioning, suctioning, stable vitals, adequate IV access. And we had done a chest X-ray and arterial blood gas before moving the patient, because that will show the child is metabolically stable, ABC. Chest X-ray will show you, will tell you ET tube beat properly. So again, they use this checklist in the transport form before you transferring. What is the patient's breathing, respiratory pain, amount of the oxygen patient is getting, with the oral intubations, nasal intubation, ET tubes, blast, blood gas, pulse rate, CRFT, blood pressure, perfusion, with the peripheral IV or IO, fluid boluses, ionotropes infusion, catheters, and then ABPU scale, Glasgow scale, level of consciousness, posture, pupil signs, RBS, temperature, and whether the patient has there is neuroprotective measures is something to do. So therefore, it's like this: patient's current situation, airway, breathing, circulation, disability, organ support, physiological resource, therapeutic resource. And finally, again, ABG and the chest X is important just before leaving. So moving the patient, as I said before, it's important to should be done by the team leader. Give clear instructions how to shift this patient from patient's bed to the ambulance bed like this. And then how do you connect the disconnected equipments here and make the patient safe? Mode of transport is by road. In our setup is by road, and very rarely we undertake air transfers. But in overseas, other countries, they might take either rotatory wings or fixed wing transport. So what are factors affecting transport? Nature of the illness. As I said, patients with EDH or splenic rupture needs urgent transfer. So mobilization time is important, how long generally it takes, but it depends on the geographical factors. So there's heavy rain, landslide, floods, and road is not carpet road. Then the weather, heavy rains, then the traffic conditions. When you get to the city, where are you entering during the peak traffic hours? And assess and identify and treat any changes in the clinical signs. Keep the patient warm. And how long the communication? How will you get help during the transport? So you need to carry on your mobile, and then you need to contact either receiving hospital or referring hospital to get the advice, and then when the patient is sedated or paralyzed. So what do you monitor during the transport like this? The oxygen saturation level patients, ECG and heart rate, continuous non-invasive blood pressure monitoring. You can adjust blood pressure monitoring to happen every 5 minutes, end-tidal carbon dioxide, and then temperature in the ambulance, so that it's not too warm and not too cold. When you come to the receiving hospital, you should know where you are going. So if you are going to the NHS, National Hospital in Colombo for the first time, there are about 8 gates. And sometimes your unit may be right opposite to you entered. So therefore, you should know how to enter, which gate to take. And then from there onwards, if you don't know how to go, is there somebody to take you through? Whether you need to go through the MOPD, admitting doctor, whether you need to go straight to the intensive care unit. So these things you need to sort out before you land, before you come to the receiving hospital, so that your time is not wasted. So therefore, it's a good idea to tell the receiving doctor what is your departure time and what is the expected time, arrival time in that particular hospital, so that your time is not lost. How do you hand over? Hand over to the both doctor and the nurse at the same time. So don't hand over separately, doctors to doctors, nurses to nurses. No, you need to hand over as a team to the receiving unit doctors and the nurse. So clear documentation you need to hand over, and you need to hand over the investigation. And you have to tell them what procedures you have done. And with them, you have to check the patient's stability before they come, and make sure the patient is stable before you leave this. So what are the things that you need to, again, on a checklist, on the ventilator, what are the settings this patient is on, and during the transport, what happened? Equipment check, as I said, battery backup, oxygen cylinders, automated external defibrillator, ventilator, suction machine. Samples you have taken at the referring hospital, and what are the samples with you right now? Medications that you have prepared, and check on documents, X-ray, CT scan, ultrasound, so imaging, government transfer form, and letter to the consultant. Always take a letter to the consultant. From the referring hospital consultant has to issue a letter to the receiving hospital consultant. And consent from relatives, important before you leaving. Observation charts and medication list. So inform the receiving hospital what's the departure time, expected arrival time, and inform the receiving consultant. So during the transfer, if the patient is subjected to one of these, you need to tick and then give a clear handing of what happened. Take the patient through the MO admission or ETU or direct to the intensive care unit. So hand it over to intern medical officer or SHO or registrar consultant. And then the saturation at the and then the date, arrival time. So hand over documents is important, transfer documents, X-rays, and the consent. Okay, so this is a bit of lengthy thing which I don't want to go. So we have come to the end of this lecture. In summary, you need to decide on risk of, consider the risk and benefit of the patient transport, and careful planning and preparation is important, and choose an appropriate mode of transport. Be clear on the communication between the referral hospital and receiving hospital and team members, and anticipate the problems during the transport and use a check, and there's a lot to remember. So if you have any checks, if you have any questions, you can put in the chat box. Otherwise, we can close the session. Okay. Are there any questions? Okay, right. So we will close the session. Somebody's making some noises. Nadishin, can you mute them? Okay, so we'll move on to the next lecture, which is on communication. Right, okay, thank you.
Thank you very much, sir. Next lecture will be delivered by Punyani Bandhulika madam. It's over to you, madam.
Can all of you all see my screen?
Yes, madam.
Okay, good afternoon. This is your communication skills and interpersonal skills lecture for the pre-interns. So, do you think as budding doctors, or if you all are going to become doctors very soon, intern house officers, so do you think in your career communication skills and interpersonal skills will be important to you? Any guesses? Right, so no response. So how can I proceed? Right. Actually, interpersonal skills and communication skills are a critical success factor for life, for everybody, for you and for me and for everybody. It's a critical success factor for your life. So, the majority of your perceived ability comes from how you communicate. Actually, as I have depicted, what you know matters only 30%. But how you put it in words matters a lot. So, communication is sharing of your feelings and sharing of one's understanding. So, effective communication means to express oneself in such a way that one is readily understand the content and also the feelings behind the content, and also to respond appropriately, verbally and non-verbally. What are interpersonal skills? Interpersonal skills are the capacity for recognizing our own feelings and those of the others, for motivating ourselves, for managing emotions effectively in ourselves and others, which we call as emotional intelligence. So, communication in healthcare. Actually, as a doctor or as a nurse, communication in healthcare is very important. Sometimes we have to divulge very intimate information, but they have to be very accurate. Sometimes the information is very painful, like concerns about development of a baby. Say the growth and development is delayed, maybe a baby with Down syndrome, maybe a child with child abuse, or a fatal illness like cancer. Even those things we have to divulge with the child and with the parents. But we can't lie to them. There should be accurate information. So communication becomes very, very important in our practice. So what are the benefits of good communication? Actually, if you communicate well, you will get lot of information from your patient. So it will help you to correctly diagnose the illness, and also the compliance with treatment will also become good if you communicate well. If you explain how the drug should be used and how long it should be used, not to discontinue as they wish, so they will know some idea. So if you communicate well, they will comply well with our treatment. And also the patient compliance will be very high. Lot of them will adhere to our treatment. Their anxiety, distress, hidden problems can be detected really easily if we communicate with them. The patient will be very satisfied, and it will reduce the cost of the health care, because they will not go doctor shopping from here and there, and there will be fewer malpractice suits. But dissatisfaction can trigger patients' doubts about the competence of their physician, so which will seriously reduce their compliance with their treatment regime. If they are dissatisfied, they might not take the treatment, and it will negatively affect how long it takes to recover, which will increase the frequency of patient malpractice suits as well. So we have to make sure all the time to communicate well with our patients and their parents or the bystanders, and give them the maximum. So, doctor-patient relationship. Being doctors, we have a particular responsibility to develop effective interpersonal communication skills. That is our responsibility. So, guess, what percentage of communication do you think you are responsible for? Well, it is 100%. You are 100% responsible for your communication. When you are going to communicate, your good first impression matters a lot. Your physical appearance, your confidence, how alert and how gentle you are matters a lot. So, anyway, when you are going to communicate, you have to always show some respect. Introduce yourself by name. Greet the patient and the parents appropriately. Maintain some privacy between the two of you all. Be pleasant. Maintain a correct balance between formality and friendliness. We can't be too friendly with them, and maintain some balance between formality and friendliness. Give them courtesy. Pay some attention to them. Warmth. And also, it is very important that you can't use medical jargon. You have to use appropriate, simple language where they will understand what's wrong with the patient. Right. What percentage of communication is just given by the words? It's actually 7%. Very small percentage for the words. But how you put it into words matter a lot. What are they? Wording. Your wording, although it matters very little, you have to properly plan and structure your words. And you must have an objective when you are going to communicate with your patient. So, what percentage of communication is just given by the tone? Your tone is also very, very important. It is 38%. Words matter only 7%, but how you put it into words matter a lot. What percentage of communication is just given by the physiology? Your body physiology. What is body physiology? Your body language. Your posture, your gestures, your facial expressions, even blinking, breathing, all those things matter a lot when you are going to communicate. So, body physiology matters about 55% of your communication. So, it is an immense amount, isn't it? So, your words matter a lot, little, but how you put it in words matter a lot. Right. Sometimes we are going to deliver a message, but the message is not really delivered to the patient or the parent. Why? The message is distorted. So, what do you think about this? He is telling, I have something really important to tell you. And he thinks, maybe I should get a haircut. So, he's assuming something. Right. So, the main cause for distortion is not active listening. If you don't listen well, if you are not prepared to listen well, maybe we can't communicate well. The message the other person is giving to us can be distorted. So, listening is equally important in communication. It is a process of receiving constructive meaning from and responding appropriately spoken and non-verbal messages. So, listening is a master skill which is rarely taught to us, isn't it? In the medical school, we were not taught to listen. So, for listening, competency is achieved through practice. A good listener is not just a silent receptacle. He has to respond appropriately, verbally. Ah, yes, okay. How is that? So, likewise. And non-verbally. So, verbally and non-verbally, you have to respond appropriately even if you are listening, to indicate that you are actively listening. Right. So, when we are doing communication, when we are communicating with somebody, effective physical attending behaviors are also very important to communicate well. What are they? Right. Maintain face-to-face with your communicator. Having good eye contact is very, very important. Leaning a little bit forward so that they feel like you are really concerned. Open posture and mind. You can't be with some preoccupied ideas. You have to have a very open mind, open posture, relax, not be rigid. So those things, we call it, if you read it down, FELOR, fellow. The effective physical attending behaviors are very important when you are going to communicate. Right. So listening helps to build relationships. It solves problems. Lot of problems are solved by listening. Ensure understanding between the two of you all. Resolve conflicts and improve the accuracy. So at work, effective listening means fewer errors. You will do less errors and less wasted time. So what are the barriers for active listening? Maybe you're busy, noisy environment, or you may be preoccupied with something. Then you may not pay attention to what the other person is telling, or speaking rather than listening. All the time you are speaking, not paying your attention to listening, or judging. Or sometimes you may not notice the non-verbal cues, the feelings, underlying feelings behind the content. So if you ignore the non-verbal responses, you may not get the whole idea, whether this person is happy, whether this person is sad or anxious or lost or whatever it is. So non-verbal cues play an equally important role in your communication. Levels of listening. So when you are going to listen, you can totally ignore what the other person is telling, or you can just surface listen. He's telling and telling and telling. You will get a basic idea, or you can get the content out of what you have listened, or you can become an empathic listener. What is that? Just listen. You have to understand, put yourself in other person's shoes and see. When you want to understand more facts, think whether if this happens to me, how will I react? What will my feelings be? Then you will know how difficult it is for the other person. So empathic listening is very important in our medical career. That is what we want you all to be trained for, empathic listening. Right. So empathy is putting yourself to patient's position and see. Think, if this happened to me, how will I react? Right. So empathic listening is to recognize the content as well as the feelings. Therefore, you have to watch for non-verbal cues as well. Right. So, 3 examples. One says, if I keep my child in the hospital too long, I wonder what will happen to my job. So the mother is feeling anxious. Second example. Doctor said I can go home. The child is feeling well. So the mother is happy. Oh, I was really hoping that I would get my transfer to Kandy. The nurse is not getting the transfer. So she is getting disappointed. So if you listen the content as well as the tone and the non-verbal cues, you will recognize the feelings of the person, underlying feelings. So then when you listen empathically, actually we want you all to form an empathic response, which should include content as well as the feeling. So, how to formulate an empathic response? A mother says, today she slept well and didn't cough in the night. So, the mother is feeling happy. The child is not coughing, the wheezing is settling. So, mother is happy. So, how are you going to formulate an empathic response? Oh, you seems to be pleased that the baby slept through the night. It means the baby is recovering from wheeze and you are happy. So that is how you can form an empathic response. So likewise, listening, questioning skills are also very important in our communication. So you can question, especially when you are taking a history or when you are checking the knowledge of a certain illness or something. So questioning skills will give you more information. Like if you ask for an open question, well, tell me all about your illness, or what would you do if I, likewise. So if I ask the mother to tell everything about your illness, she will come out with lot of things. How the whole fit happened, and how they get into the bus, how they came to the hospital, what are the things they have given at home, how did they bathe the child while fitting, and all these sort of things. So those are called open questions. But you will gather a lot of information, then you can help them. So you can get information, come to a correct diagnosis, educate them not to do certain things during the next fit, likewise. So open questions help you a lot, but it will cost lot of time. So what are the other types of questions? Specific questions. Seek to answer to a particular point. Amma, බබාට වමන ගියා නේද? වමන ගිය හැටි ගැන අපිට කියන්න. So to a particular point. Or you can ask confirming close questions. බබාට වමන ගියාද? Yes or no. And then building questions. In what way do you think we should help her? In what way do you think she will do this better, do this physiotherapy well? Likewise. So building up questions. So they will come out with their opinion, which will help us to make them more adhere to their treatment. Or you can give clarifications. What I hear you say is, at the end of your history taking, you can say, now you have told these things to me, is there anything else you want to let me know? So if you clarify, they will come out with more facts, right? So questioning skills are also very important when you are going to communicate. Touch. When we are communicating, actually we have to use appropriate touch, which can mold the behavior of the other person. What is rapport? So when we are communicating with other people, we have to develop a good rapport with the person we are going to communicate. So in that sense, a relation of harmony, accord, and affinity or alignment will help. How can we do that? Right? How can you achieve rapport? By matching and mirroring. So if you match the other person on the other side whom we are communicating and mirror them, maybe with the content, maybe with your tone, the voice tone. Hello, how are you? The other person says, I'm fine, thank you. So it won't the tone won't match. So likewise, if you match the tone, so how can we mirror when we are on the phone? You can mirror the tone. You can match the tone. You can match the volume. You can match the speed and the language, the same language. So likewise, if you match and mirror certain things when you are going to communicate, the other person on the other side will feel, oh, she is also like me. So they feel comfortable with you, and they will build a good rapport with you, which will help more to get more information about the patient and the illness, and also to make them compliant to the treatment. So matching and mirroring and the alignment will help in your communication. If we have a good level of rapport, it can be possible to alter their physical posture actions, which in turn can change their situation. So, at the end of our communication, if we summarize, oh, දැන් අම්මා ඔයා කිව්වේ මේ බබාට වතුර වගේ බඩේලිය යනවා. දවසට 3-4 පාරක් වගේ වතුර වගේ කහ පාටට බඩේලිය යනවා. ලේසෙම සීදන් නැහැ, වමනේ යන්නේ නැහැ, උණ නැහැ. අම්මට තව මොනවා හරි කියන්න තියනවද? So summarizing at the end of your session, then they will come out with whatever which has been forgotten to say. So, and also it will indicate that you were listening actively. It is all about your problem or the management plan. So summarizing at the end of your communication will also very helpful. Right. Confrontation. So when we are communicating as doctors, we sometimes have to confront with other people. So what are the situations? When we are in the ward, we'll have to confront with the consultant, with the registrars, senior registrars and senior MOs, or confront with the co-HO, or maybe with the sister, nurse, cleaning staff, minor staff. There are so many people, or maybe the security guard in the car park. So likewise, we have to confront with so many people at work. So sometimes if you confront alone, it may elicit a defensive reaction, or the colleague may feel threatened. How to confront someone about an action or behavior that you would like to change? If you want to change somebody, how are you going to change their behavior? How are you going to let them know this is something wrong? You must change this. But if we tell it like that, they won't be happy. So when we are confronting with somebody, we have to confront empathically. So if you confront and express empathy, that helps a lot. So likewise, when you can use these things. I feel this is not appropriate. So I prefer you can come to work a little bit early, because the consultant will expect you to come early. So is there anything in particular that makes you late every day? So likewise. So because I would prefer if you can come to ward early, because. So likewise, if you use these words, it expresses empathy. Although you want to confront your colleague and you are expecting a change of his behavior, use empathic confrontation. Use these words. So it will be very nice. They will readily understand their problem, and they would think of change in their behavior. So, for example, someone is a hemophilia patient who had a convalescing bleed into the knee, convalescing after a bleed into his knee joint. Now we have arranged physiotherapy for someone, but he says he can't do the physiotherapy himself. So he says, I'm not going to bother with this dumb exercise. The physiotherapist will do them for me. But that is not enough. He has to daily do them at home. So how are we going to confront someone? Right. I have 4 options. Which one is the best? Know someone. You have to do your exercise. Will he be happy? Oh, that's really poor attitude. What's the problem? Will he be happy to change himself? Someone, you made a commitment to the physiotherapist that you will do the exercise on your own. Will he change his behavior? Right. What about this? Well, I know it's quite boring to do the exercise, but it is important that you do them. Is there any particular reason about exercise that you don't like? How about that one? Then they will come out with their problems, their difficulties, hardships. So then we can counsel them better and make them understand doing physiotherapy daily is very important if he want to have a normal joint. Right. When we are going to communicate, we have to always maintain confidentiality, assure confidentiality. So keep patient's information secretly. Right. So what are the important aspects of doctor-patient communication? Respect and warmth, appropriate words, although they matter little, we have to use appropriate words. The tone and the body language matters a lot. Active listening is very important. Always be an empathic listener. Empathic confrontation. Questioning and clarifying skills are equally important for a better communication. Use appropriate touch. Build a good rapport. How to build a good rapport? Alignment. Right? So, good rapport. Summarizing helps. Use appropriate confrontation, empathic confrontation only when needed. Maintain confidentiality. Sometimes, when you are in the ward, you will have to confront with an angry, demanding patient. You are the only house officer available in the ward. This is a very challenging and difficult situation. So, always what you can do is listen. Listen actively during the outburst. Avoid becoming defensive and aggressive yourself. Don't become aggressive. Keep your tone to a minimal level. Formulate an empathic response. Yes, I can feel that you are really upset about this. So, likewise, you can formulate an empathic response after listening, active listening, and restate what has been said and offer clarification. So, how are you going to communicate with your co-workers? Use your interpersonal skills. So, show some respect, warm up to others, convey your points very clearly, listen actively, value their opinions. It is very important to get other people's opinion if you want to become a successful person, right? So, empathize with them, support and encourage the other people, give and receive constructive criticism, and try to build an effective team, which is very important when you are at work. If you build an effective team, your efficiency is much more. You can give a better service. So, constructive criticism or suggestions to your co-worker. He is not doing something which you think is not good. So, you want to tell something, criticize your colleague and ask her to change her behavior. How can you do that? Should not be in front of any patients. Do it privately. Be constructive and concentrate on the facts only. Get to the point. Avoid blaming. Right? Sometimes you will have to pinpoint the mismanagement or a fault of a co-worker. If you do that in front of a patient, what will happen? It breaches an important aspect of your professional behavior. So not always in front of your patient. You can't do it in front of the patient. Do it privately. Use the confidence of the patient towards you will be breached if you do it in front of the patient. And they feel anxious about our management. So, how could we improve communication skills? It is by self-awareness. It is an honest active process of learning about ourselves and personal reflection. So acknowledge your strengths. First think, can I communicate with well? Can I face this situation? How am I going to do that? So practice. Through practice only you can become an effective communicator. Also, you can facilitate by keeping a personal diary. Right. In summary, communication is a skill actually. It can be achieved by practice. Every one of us can become effective communications which can be achieved by practice. It is a critical success factor for your life throughout. So, at the end of your good communication, both parties will be satisfied and you will have less problems, no problems actually. So, the desire has to come within you. Thank you.
Thank you very much, madam, for your valuable lecture. Next lecture will be delivered by Dr. Harendra Kure, emergency physician at LRH. So it is over to you.
Okay. Thank you, Nadisha. Okay, so good afternoon, everybody. It's an absolute pleasure and very exciting to meet, or not really meet, but actually to speak to 294, or a few less, obviously, of the next generation of clinicians in Sri Lanka. My name is Harendra Kure, as Nadishan introduced me to you. I am the emergency physician currently working at the Accident and Emergency Department of the Lady Ridgeway Hospital for Children. So we are going to discuss about, so I've started from the wrong end of my talk. How interesting is that? Okay, just a moment. Okay. Yeah, an approach to a seriously injured child. I think a couple of days ago, you probably interacted with my junior colleagues. We had a whole day of emergency medicine for you. And I'm sure all of you are very confident now and eager to manage emergencies. My talk over the next 20 minutes or so is going to be something focusing on pediatric trauma. Some of you will get the opportunity to probably work in pediatric units. Some of you will obviously have an opportunity to work with surgeons. Some of you even might be working with pediatric surgeons. But there may be some of you who might be just stuck doing medicine. Not very interesting, sorry, but anyhow, that's how life goes. And also some of you might be, looking after mothers and newborn children. But it's imperative that you understand the approach. Each one of you should understand an approach. And that is exactly what we are going to do. So it's going to be a structured approach to a seriously injured child. And something that we all should be able to do, identifying life-threatening injuries. And because this talk is on pediatrics, life-threatening injuries in children, obviously. And something that you all would have probably gone over with my colleagues, the initial stabilization and how you resuscitate a child in this context in the emergency department following trauma. Like all good things, it's time to discuss a case. Now, it would have been wonderful if about 2 or 3 of you could come online with me
unmute your mics and have a interactive session. Is that possible, Nadisha? Can 2 people be unmuted just for my discussion? Not possible? Nadishan, are you there? No. Okay, right. So Palitha is a 13-year-old boy. Like all 13-year-olds do, he wanted to climb a tree in his own front yard. And obviously he did this when his mother was away, go on shopping. And unfortunately, like children of 13 who climb trees, they generally tend to fall down back to the ground. And this is exactly what happened to Palitha. But on the way down, he knocked a part of his body on a low garden wall and then bang onto the ground, a footpath, possibly concrete. Right? Now, this is the kind of standard story that you will gather from a trauma presentation to emergency departments all over the world and obviously even in Sri Lanka. Okay. This story has absolutely important information for us as clinicians. And even if this story comes in various different languages, it is imperative that you understand very, very well what we call as the mechanism of injury. Because based on the mechanism of injury, you can anticipate dangerous life-threatening insults and injuries, which may not look very obvious at the onset. So keep in mind, lesson number 1, as intern medical officers, because very often you are the ones who listen to the story. You need to decipher the important facts and be very thorough with the fact gathering. And I'm glad I'm following a lecture on communication skills, because this is where it all matters. These are things that are very important for you to learn as junior clinicians, because it'll be so useful for you when, like me, after 27 years of clinical practice, they still stick in your mind and they still become habit forming. So the good habits need to be learned during internship. Because ultimately, there's no difference between what you want and what I want. It is safe management of patients and to prevent death and to minimize morbidity, right? So you learn it from day 1. Okay, so the mechanism of injury in this context is dangerous because the child has fallen from a tree, which is obviously more than 2 meters in height. And on the way down, he had a hard impact on his soft body and then bang onto the ground. So these are important things for you to gather. Now, these are the goals of objective assessment and what kind of treatment that we might want to initiate as we assess. So I'm sure you recall from the lectures that you heard given by my colleagues that our approach is assessment, which is as objective as we can be, picking the problems, fixing the problems, reassessing, and moving down the line. And there's some there's a structure in which we approach this. Now, to sum it up very simply, we need to pick the conditions that kill you first. So in trauma, it is always associated with bleeding. Now, bleeding can be of many forms. When you say catastrophic external hemorrhage, what you mean by the English adjective catastrophic is that it can lead to death. Okay. So what kind of bleeding will lead to death? Bleeding that is fast and furious, as one of the titles of a famous movie that I'm sure many of you have watched repeatedly, because there's a whole series of them. So it is fast and furious bleeding. It is irrespective of the area of involvement. Even a small puncture wound over one of the main blood vessels is going to bleed fast and furious. It doesn't have to be a huge, humongous wound. Even a small puncture wound can bleed fast and furious. Simple lacerations of the scalp is going to bleed fast and furious. And if they go unnoticed and unattended to, it can cause a catastrophe. And what is meant by catastrophe here is the extreme, that is death. So remember, you have a sole responsibility, one, to anticipate catastrophic hemorrhage based on the mechanism of injury, and to identify it if it is very obvious. Now remember, the whole problem with managing trauma, and especially pediatric trauma, is that we don't anticipate the worst possible scenario or the worst possible case. And very often you might miss catastrophic hemorrhage because it is not obvious, it is concealed. So keep these things in mind. Next in line is to assess the airway. And remember, when there is a fall from a height of a significant height, such as this, fall from over 2 meters, or in smaller children, say less than 2 years, even a fall of more than 1 meter, it is a dangerous mechanism of injury. And directly in line for injury is the cervical spine. So you have to be very cautious that you may be dealing with an unstable cervical spine injury. Therefore, it is paramount that you understand the concept of trying to minimize the mobility of the cervical spine. May I repeat that notion? Minimize the mobility. It is not total immobilization anymore. It is minimizing the mobility of the cervical spine. So you have to be conversant with inline cervical spine stabilization, how you need to employ it and how you give it. You need to know that, and that is a skill that you will learn when you visit emergency departments and start working with us. You can use adjuncts such as soft collars, sandbags to keep the head from moving from side to side to minimize the mobility. Now you need to obviously assess the airway with a structured way, with an objective intention of knowing, is this airway open? If the airway is open, then can this patient protect the airway? These are the two simple questions that you should have very clear-cut answers. Now, if it is obstructed, you get, when you look, listen, and feel for the movement of air, which is a silent process in normal circumstances. You don't hear air moving in and out of a person, right? But if it is creating unusual sounds, such as gurgling, such as stridor, such as snoring, then you know something is wrong. If the patient is able to talk to you clearly and cognitively, then it ticks off three boxes in your brain. That is, the patient is able to vocalize, so the airway is open and sound and is not obstructed. And because the patient is giving you reasonable answers to your questions, there is a good level of consciousness, which means the patient's ability to protect the airway is intact. So simple objective ways of assessing with a meaningful way. So I hate it when people, teachers especially, say, what is your approach? It is the ABC approach. And first I look at the airway. Looking at the airway does not give you anything. You must understand, what am I looking for in the airway? What is it that I'm objectively assessing in the airway? And it is nothing other than patency, ability to protect. And if this is trauma, be concerned about a potentially dangerous cervical spine injury. Right. Next in line in our objective assessment is the breathing component. And we know that breathing is essential because life on Earth is sustainable because we get oxygen into our lungs and from that into blood and therefore into the cell, and therefore life continues. Any breakdown in this process, which is oversimplified by me, would lead to death. So it is obvious that you need to be concerned that the breathing takes place correctly, so that the oxygen goes in and the carbon dioxide comes out. But this is a very complex phenomena, breathing. There's the interaction of many important organ systems in play. There's the central nervous system, the peripheral nervous system, the cardiovascular system, the respiratory system, the musculoskeletal system, all of these interplay. And obviously, I don't need to remind these things to you because you guys have the freshest knowledge of anatomy, physiology, and so on and so forth. So you examine for external injuries. You look for the chest expansion. You listen to air entry on both sides. You percuss to find any unusual changes. And you look for the position of the trachea. But remember, all of these things seem to be very subjective. It is all dependent on how you interpret these findings. But when you count the respiratory rate with the correct way, and when you measure the pulse oximetry reading with a pulse oximeter probe, these are objective assessments. These are the assessments that we should go by. Because what respiratory rate cannot vary from you to another one to another one to another one. Similarly, SpO2 recording cannot change from the person who is interpreting it, because it is the very objective assessment of giving us a very crude sort of feedback as to the ability, how much of oxygen is actually bound to the hemoglobin that is being detected at the tip of the finger where the probe is. I mean, that is basically what it says. It is not an absolute thing that you're going to interpret, but it is something, a relative a number that is giving you an inclination about what's going on. Is what is going on bad? Is it very ugly? Is it life-threatening? Or is everything fine? Circulation, obviously, is the next most important objective assessment in trauma that you have to do. Because these are objective parameters that have to be measured, have to be documented by you, junior medical officers, intern officers. Take these things seriously, because if you make errors in this, the more clinical decisions that are done by your seniors can go wrong. And at the end of the day, the patient will suffer. So take to heart the importance of your role as first contact, as the first assessor, and be truthful and be concerned and be as objective as you can. Please do not fill in the blanks. Do not treat bed head tickets. If you did not measure the blood pressure, it cannot be 120/80 that you put on that bed head ticket. No, please, if you didn't measure it, do not write it. In other words, be truthful. Be truthful to yourself. Do not beat around the bush, because you are playing around with human lives. Okay. Next, we move on to the objective assessment of the level of consciousness. Now, objectiveness is the name of the game, right? As intern officers, as junior clinicians, please get this straight. The more objective you are in assessing a patient, the better the outcome is going to be. The more focused is your management and treatment going to be. Because remember, you are treating a human being in front of you. You're not now teaching Ganong, you're not teaching Guyton, you're not treating any of those textbooks. I know you read it, I know you got through it, I know it is all in your brain, but now is the fun part of your medical career. You're actually going to deal with human beings. So you need to adapt to that. And the easiest way to do that is just be truthful to yourself and do not, I repeat, beat around the bush. Right. What kind of treatment do you anticipate that this child, Palita, might need? Well, if he had any obvious catastrophic hemorrhage, especially from a limb trauma or say a scalp laceration, then the most simple techniques of controlling bleeding should be employed at the onset. And applying direct pressure over a bleeding wound is so simple and straightforward, provided that you are safe with gloves. You should employ that. If it is a limb, there is a possibility of applying a tourniquet. If you can identify a clear-cut bleeding vessel, you should be able to suture it, identify it and suture it. So these are absolutely simple skills that you will learn, you will practice, and it will be in your armamentarium as you become a more senior clinician. So learn these things as junior clinicians. Airway maneuvers, there are few simple things that you can do, which as juniors you should know how to do, such as the head tilt, the chin lift, and the jaw thrust. Now, remember, if you're concerned about an unstable cervical spine injury, you cannot make any undue movements of the neck. Therefore, out of the three simple maneuvers, it is only the jaw thrust that you can employ. Be familiar with airway adjuncts such as the Godel airway, the oral airways, the nasopharyngeal airways. Know how to size it So this all applies to adults, it all applies to pediatrics. So you just need to have a different set of adjuncts available depending on which area of the hospital you are practicing. Ensure that there's a functional suction machine, because when you got debris, blood clots, vomiters, or kottu roti and all this stuff inside, stuck inside a patient's mouth whose conscious level is so low they can cough it out, it is the suction apparatus that is going to pull it out. So ensure that you have it at hand. Remember, all critically ill, injured trauma patients will benefit from any amount of oxygen other than 21%. So be conversant, be familiar with the devices that can provide enriched oxygen to your patient, and know the simple things first, so that you do the simple things first. There's no point contemplating things like endotracheal intubation if you don't know and if you don't use a face mask oxygen. Learn how to do that first. Intubation you can learn later. And then if the breathing is compromised, you need to be able to assist the breathing of the patient. So there are various modes. The bag valve mask resuscitator is something that you should know inside and out, and the functions of it, the different parts of it, and how you use it on a patient to assist breathing. Intubation is a very, very skilled and high-risk procedure which you will be taught later on in your clinical career by people who do it day in and day out, notably anesthesiologists. Then we come to the circulation. What can we do when we find objectively that circulation is compromised? Be absolutely proficient in gaining intravenous access, peripheral access. You, from day one, please learn the proper methods of gaining IV access. In children, it is a very challenging task, but you need to be patient. You need to understand the psychology of this whole procedure in children, the psychology of the parents who are by the side of the children when you're doing this. So you need to understand this. And as you heard the previous speaker, communication comes into play here, because you need to explain yourself to the parents. You need to explain to the child, if possible, if they are able to understand, and become more and more proficient in gaining intravenous peripheral IV access. It is an absolute must-know skill. In pediatrics, it is just a bit challenging, but the more you do it, the better you become. There's a mention of a drug called tranexamic acid, which I'm sure you are so very, very conversant, because pharmacology knowledge is so fresh inside your brain cells. This is an antifibrinolytic. There's a place for tranexamic acid within the first 3 hours of trauma, and you need to know the dose, and you need to know how you give it, and you need to remember to give it in a patient following trauma within the first 3 hours. Be conversant about communicating with the blood bank. As the previous speaker said, aggression is not the way to get things done. Be empathetic, be understanding, be clear, but communicate. Please learn to communicate. You need to pick up that phone and dial the number and speak to the blood bank personnel if you want their services. If you want their services, they need to be informed beforehand and they will comply, but you need to communicate. O negative blood can be given to you within a flash if it is available in the blood bank, but anything more is going to take some time, and they will require a blood sample for grouping and cross-matching. Immediate fluid resuscitation, if you feel the intravascular compartment has been drained due to hemorrhage, needs to be replaced with crystalloid boluses. But you are not going to flood the intravascular compartment, which is losing blood from some source, with crystalloids, because any common sense and any idiot will understand that if it is blood that is being lost at a very fast rate, it is blood and blood products that needs replacement. There's no point filling that intravascular compartment with crystalloids. It is not going to carry oxygen. It is not going to create any clotting. It is not going to do anything. It's going to confound the problem more and more. You're going to add a load of hydrogen ions, a load of chloride into the system. You're going to freeze the system, right? And you're going to dilute the bit of coagulation factors, and you're going to propagate the vicious cycle of coagulopathy and trauma. So please refrain from flooding the intravascular compartment with crystalloids if the patient is losing blood from some source following trauma, you need to initiate blood and blood product transfusion as early as possible. Right. All trauma has some element of pain, and pain is unpleasant, and pain has to be treated. And in emergency department practice, the pain that we get, we need to titrate the best known drug for pain, that is opioid analgesic in the form of morphine. It is a titratable dose, that is, you have a safe dose, which is 0.1 milligram per kilogram body weight. That is the max for that patient. You keep giving slow incremental doses within that ceiling until the pain is taken care of. We do not like to keep patients in pain in emergency departments. We are conversant about the drug morphine. We know its side effects. We know what it can do. So if you know it, you can manage it. But you are not going to deprive a patient of the gold standard of analgesics just because somebody else does not know anything about morphine, which they should, because they all studied pharmacology. Right, now this becomes a bit of a silly kind of thing because I need interaction here, but since all of you decided not to unmute yourselves, I'm just going to run through these images. So this is like a rapid fire that is really fun if you guys and girls were bold enough to interact with me, but since you chickened out, it's fine. This is an image of a child with an obvious lesion over the anterior part of the neck. You can see that he's getting supplementary oxygen. If I tell you that this child was involved with a collision where the car caught fire, what would be the immediate life threat in this child? Okay, think it over in your brain. Yep, you got the answer. It would be inhalational injury causing a critically dynamic airway. And critically dynamic airway is an airway that you lose in front of you if you don't do what you need to do to prevent a life being lost. And that is early elective intubation. So that's what this child would need to save his life. This is a classic image which you shouldn't be looking at because this is a clinical diagnosis. But if you look carefully, you find that the entire hemithorax on the left side is totally become white with the cardiac shadow because there's no lung tissue over there. And if you look carefully on the right side, right hemithorax, you will find that there are no vascular markings. So this is the classic appearance of a pneumothorax. And if you recorded this child's blood pressure and heart rate, you will find that he's tachycardic with absolutely low blood pressure because his cardiac output is compromised. So this is what you term as a tension pneumothorax. And the tension is not yours. The tension is not the lung. The tension is the right side of the heart. The right side of the heart is tensed because it's getting pushed against by abnormal collection of air in the pleural cavity, which technically should be free of anything. So what is the life-saving procedures that you do? You need to decompress the pneumothorax with a chest drain insertion, and you need to prop up the cardiac output by giving a little bit more fluid. And that is going to save this child's life. Here's another similar looking chest x-ray, but obviously it's not the same pathology because here, if you look carefully, there is no deviation of the trachea because trachea is slightly deviated to the right, which is the normal appearance in any trachea. But you find that there's a complete or near complete whiteout on the left hemithorax. And if I give you a clinical bit of information that this was a child who was involved in a blunt trauma to the chest, you should anticipate and know that this could be either a collapse, which is unlikely, but this is something occupying the pleural space with something radiopaque, and that's something, if it is in relation trauma, is hemorrhage or blood until proven otherwise. So this is a massive hemothorax. So this child is going to have a compromise of his breathing, a compromise of his circulation. So how do you prevent him from dying? How you prevent him from dying is you insert an IC tube to ensure that you know how much of blood is there, how much of blood and how fast the blood is draining. That's why you need to get an IC tube and you need to drain out the blood that is collecting. And you obviously need to replace the blood with blood. And that will save this child's life. This is a classic wound on the chest wall, which is termed as an open chest wound. The problem here is that there's a direct communication from the wound to the pleural cavity. And as you know, everybody in this country loves to creep in through the least resistant pathway. Well, air is no exception. So air which should be traveling down the trachea decides to track in through the open wound, and you convert a simple pneumothorax into a tension pneumothorax. So how do you prevent the child going into a cardiac arrest because of a tension pneumothorax here? What you do is you employ this three-sided technique of plastering so that you create a flap-like mechanism where it does not allow air to go in, but it allows the expired air to come out through the least resistant pathway, therefore negating the ability or the possibility of it converting into a tension pneumothorax. So this obviously should be followed up with a formal intercostal drain, which has to be, mind you, inserted from another new stab injury. So that is open pneumothorax. Here is another image which looks innocuous but has potential to become life-threatening. These are aberration or imprint aberrations over the right hemithorax. Then you need to anticipate and understand that a lot of terrible things may be lying below it, such as if you go from top to bottom, and since you guys and girls are so fresh with your anatomy knowledge, the ribs obviously can become fractured. It can be fractured multiple ribs. It can be fractured at both sides. And if there are 3 consecutive such fractures on both sides, it becomes a flail segment. There can be collection of air, collection of blood in the potentially empty pleural space, leading to pneumothorax, hemothorax, or pneumohemothorax. And below that, you get the lung tissue, which is a very delicate structure, and it can be contused and it can be bleeding, and that can lead to both oxygen and carbon dioxide exchange impairment and can lead to hemorrhagic shock. So horrendous kind of injuries can be underlying, which are all life-threatening. So you need to be aware of this. You need to act fast. And if there are multiple rib fractures, this patient will be in a whole lot of pain. So you need to take care of that. So how are you going to manage this patient is with analgesics, obviously high flow oxygen to supplement the breathing compromise so that you give more oxygen. And you might have to support breathing with non-invasive ventilation, or more skilled hands may be required, and he might actually need intubation and positive pressure ventilation in intensive care for this patient. And finally, this is an image of an ultrasound picture. Remember, when we are managing trauma, most patients cannot be carted around from department to department. They need immediate attention, objective assessment, and ultrasound becomes our eyes to places that the human eye cannot see. So if you are looking for potential places where there can be catastrophic bleeding, which is not obvious, such as the cavities in the body, which includes the pleural cavity, the pericardial cavity, and the peritoneal cavity, ultrasound is our go-to, because we bring the ultrasound machine to the patient, and never does it work vice versa. We don't cart around our patients into radiology departments to do fast scans in trauma. No, we should be competent and able to do it ourselves at the bedside, because remember, our responsibility is to the patient, not anybody else. So this is a classic appearance of pericardial effusion, and if you will learn ultrasound during your clinical practice days. My vision is within the next 5 years to introduce it into undergraduate curriculum, because I think ultrasonography and the skills for bedside ultrasonography is something that has to be learned by every single doctor. Just like how you listen to air entry and S1, S2 and heart sounds, now is the time for you to be competent and comprehensive about point of care ultrasonography. Every doctor who comes out of med school should be competent in point of care ultrasonography. So here you will see that the right ventricle is collapsed in diastole, and that is the hallmark of a cardiac tamponade. And this needs to be drained immediately with ultrasound guided pericardiocentesis if you want to save this person's life. Okay, so getting back to Palitha. So Palitha, the 13-year-old boy who fell from the tree onto a garden wall and then bang onto the floor, has now arrived in your emergency department. He's 40 kilos in weight and he's crying in pain. He's a respiratory rate of 40 even for a 13-year-old, which is way too high, but he's saturating 98%. That's because of the oxygen that you're giving. He's perfusing well to his peripheries at the moment, slightly low, 3 seconds, but he's tachycardic, and has got an unusual blood pressure reading of 140/75 for a 13-year-old. There's no obvious external hemorrhage that you can identify, but he's got a bruise over the left head. Now, if you think of the catastrophic hemorrhage component, there is nothing external, but still we have to be sure that there is nothing going on inside Palita, which may be tantamount to catastrophic hemorrhage. But what is a giveaway that he may be actually having a cardiovascular compromise is his tachycardia and kind of a systolic blood pressure, which is high, and so is the diastolic blood pressure. Both of those going up. So it could be the pain, it could be early compensated shock, narrowing of pulse pressure, because there is no narrowing technically, but diastolic pressure going up could indicate early peripheral vasoconstriction setting in. The bruise over the left forehead is very, very worrying because he may be harboring a clinically significant traumatic brain injury. Because remember, this was a fall from a height. He's saturating well, but that at the expense of a tachypnea. So Paul is not well at all. Paul is pretty seriously ill. And I hope you are able to gather that by looking at these numbers, which are all objective. Sorry. Yeah, so as expected, over a short period of time within the emergency department, things become very different. And this is actually what happens in trauma. Trauma patients deteriorate pretty fast. They deteriorate in front of you. That is why when you're managing emergency department patients, you have to be at the bedside. There's no point you being in the tea room. There's no point in you being in the restroom. There's no point in you being in the house officer's quarters. You have to be by the bedside of the patient. Remember that as well. Your objective assessment has to be done by you. Your eyes have to work, your hands have to work, your all 4, 5 senses, whatever you have, need to be on that patient. And especially if it is a pediatric trauma, it is essential and paramount. And you need to communicate clearly with whoever who is going to make important decisions on behalf of Palita. It could be a senior house officer, it could be a registrar, it could be even your consultant who may be not around at that moment. But if you contact that person, they will all be able to come near the patient and start managing this patient with you. But this again emphasizes the integral part of your role as junior clinicians, as house officers, because more often than not, you are the ones who come into contact with the patient first. So in a scale of importance, I pay the highest importance to you. Now, this is not to overwhelm you with responsibility, but for you to understand that your role is absolutely important for the well-being of the patient in front of you. So take this to heart, become responsible individuals, and start enjoying clinical practice. So Palita has become pale. He's got worsening of pain. He is now confused. His peripherals are cold and clammy. His saturation is now dropping in spite of supplementary oxygen. His respiratory rate remains 40, but his pulse has become thready. He's become more tachycardic. His blood pressure falls to a systolic of 100, and you cannot even record diastolic blood pressure. And dramatically, his peripheries have now gone into shutdown because it is now taking 6 seconds for it to refill the capillaries in the peripheries. So this all in all tells you that you're on the slippery slide of the slope. This is, and in children, may I remind you, they are the greatest of compensators ever. They will compensate in front of you, and you think that everything is fine, and then they crash also in front of you. Because unlike in adults, the period of compensated shock is very long in pediatrics. And we don't want them switching over from compensated shock to decompensated shock, and which then dramatically goes into irreversible shock. And when they go into irreversible shock, there's nothing that you can do. They are going to die. Okay, take it from me. They are going to die. Irreversible shock is irreversible shock. That is why you use the term irreversible. You might just crowd the intensive care units thinking that organ system support is going to pull them through. They won't. But if you pick the child in compensated shock and you were able to resuscitate this child and you were able to send this child to intensive care and they give organ system support, that child might walk out, not might, will walk out of that intensive care unit. Now again, emphasizing the importance of you at the bedside of this child following trauma, you who picked up these changes and conveyed it to the more responsible clinicians. It is you and nobody else who is going to make a difference in these children's lives. Right. So if we do a reassessment, what are the possible diagnoses that we have to consider? What about the airway? Yes, so Paul's conscious level is dropping, which means his ability to protect his airway is going to get compromised. So that means it might lead to an airway obstruction. What about his breathing? He is tachypneic. He's desaturating now. So he may be harboring a pneumothorax, a hemothorax, or even lung contusion. So there are issues even in his chest or breathing apparatus. It could be a flail chest, it could be underlying lung contusion, it can be anything of these. What about the circulation? We know circulation is very, very seriously affected because he is now tachycardic, you are recording only a systolic blood pressure, and his peripheries have completely shut down because they are rerouting his peripheral circulation in the hope that central circulation and the vital organ perfusions can be maintained. These are all done by the creator, mind you, not any of us. Right? This is normal physiological changes taking place due to trauma. This is normal physiology working at its best. So he may be losing blood even though we can't see it with our eyes. He may be harboring a cardiac tamponade. His solid organs may have got ruptured, or maybe he's bleeding into the retroperitoneal space. You don't know. You have to find out. That's your role. What about the disability examination? Well, he could be harboring a clinically significant traumatic brain injury. He might be having a very unstable cervical spine. So you need answers to these questions. But the important thing as junior clinicians is that you anticipate these changes. You ask these questions. You ask these questions from yourself, and you ask this question from your SHO, your registrar, and your consultant. Please ask questions. This is your learning curve. If you don't ask questions, you won't hear answers. If you don't hear answers, you wouldn't know what to do, even if you knew what was going on. So please, I beg of you, ask questions. Be the one who irritates your SHO. Be the one who irritates your registrars. And definitely start irritating your consultants from day one. And get blackguarded, get scolded. That's what's going to make you a good clinician. Take it from me. I've learned it the hard way and I have no regrets. What about everything else? Yes, never forget things like hypothermia, because remember, hypothermia is one component of the lethal triad of coagulopathy, and you have to be absolutely sure that you are going to avoid and prevent and treat hypothermia in trauma. So you can do simple things to prevent it, but you need to know it. So please get used to measuring temperatures. Don't put the palm of your hand and say, I got asthma. No, it has to be an objective assessment. There is a thing called a thermometer, and you need to record the body temperature, preferably core body temperature. Hypoglycemia is another killer, and you look very stupid if you have not checked random blood sugar and you find that your consultant comes around and says, what is the blood sugar? And you haven't done it, and you find that it is absolutely low, and all you need to do is correct it with some dextrose and the patient comes to life. And you called down your consultant at 2 o'clock in the morning because you thought the patient is brain dead, right? So that really can irritate your consultant, but you might learn never to miss random blood sugar check once you get blackguarded once or twice by your consultants. Okay, so when we reassess Palita, we find that there was no obvious external hemorrhage. There was nothing to be worried about the airway. The chest was clear, the air entry was fine, but there was tenderness over the lower chest. But of course, circulation parameters were pretty bad. He's tachycardic, there's a significant drop in blood pressure, and his peripheries are shutting down. And in the disability, there were some sinister changes. He's becoming confused, which only reconfirms that his cerebral circulation is getting compromised, or he may be harboring a clinically significant traumatic brain injury. But you need to assess his conscious level with an assessive parameter such as AVPU score or the Glasgow Coma score, because you need to chart it, you need to document it. And please document truthfully. Document everything that you find objectively. Document it, write it down in the BHT, but do not cook up stuff. Please do not do it, but please do get into the habit of documenting. It is essential because remember, it is a continuum of care, and we sometimes have to refer back to patient notes to get some absolutely important information, and it compromises patient care when you find that documentation is poor. It is a direct reflection of being a very, very poor clinician. So don't get into that habit of being a poor clinician. Start doing these things right from the onset. He's got abdominal tenderness on the left side, and a large contusion over the left flank, but you can't find any fractures in his long bones. So these are all ominous things for you to think of pretty bad injuries in Paul. So Paul was managed accordingly, depending on what we found. His airway patency was maintained. We maintained inline stabilization with sandbags. We gave him supplementary oxygen just via a face mask. We got in IV access. We gave him tranexamic acid. We've asked for O-negative blood and group-specific blood because we know there is some kind of hemorrhage that is going uncontrolled. We initiated some crystalloid fluid resuscitation, and we were considering whether we should add on the maintenance fluid requirement or not. So if the hypertension is not corrected, we need to actively look for life-threatening hemorrhage. We have to be concerned about the bruises of the abdomen. We have to look for, very specifically, now be objective, we have to look for solid organ damage, such as liver rupture, spleen rupture, pelvic fractures, and upper thigh bleeding to look if we missed a femur fracture or not. So we need to do things when we don't know things by the naked eye. If you can't see, use the machine that will show you. Do a fast scan, do an extended fast scan, use the ultrasound machine. And then you need to follow and see what else you need to do. You can easily catheterize the bladder, or you can apply a pelvic binder. You need to do all of these things for Paul. Right. So if all those things were done, then we arrive at a definitive diagnosis, and that will determine specific therapy. So all in all, the approach has been to anticipate the worst, get objective assessments done, and then try to work out what's happening while resuscitating. That is what we've been doing all this while. But the approach has been systematic. We've tried to address what can kill Palita first. And therefore, we are now in a situation where we are still having a child who's alive, but who needs specific treatment based on the definitive diagnosis. So what could be the diagnosis? Well, the diagnosis following more thorough imaging is that he's got a ruptured spleen and he's got multiple lacerated left side kidney, because when he fell down and hit the lower garden wall on the left side, he's ruptured his solid organs, kidney and spleen on the left side. This is causing obvious uncontrolled catastrophic hemorrhage, which is conceived. So what are the specific therapy options? It all depends on what is at hand in your institution and how stable is Paul following your initial management and resuscitation. If there is nothing that you can do for Paul in your institution, then you need to resuscitate and transfer him to a place where that can be offered. If it is a place where you have everything, like LRH, for example, then there's even a place for intensive care, conservative management, watchful, conservative, careful, intense monitoring and management, because at the drop of the hat, all you need to do is take the Paul into the lift, down to the theater, and the surgeons will attend to him. But that is only in a place of excellence like Lady Ridgeway Hospital for Children, where everything is at hand 24/7. If you can't meet either one, then you need to go to your general surgeon or trauma surgeon in your institution, and they need to attend to Paul operatively. If again, you're in the confines and the luxury of everything is available, such as Lady Ridgeway Hospital for Children, there's even a possibility of us asking our colleagues in radiology, especially those who are competent in interventional radiology, to identify the bleeders and then embolize if they can, if it is safe. So all these therapeutic options are available for you depending on what kind of facilities you have at hand. Now, if there's nothing that you remember from my talk, at least try to get this downloaded into your brain. Communication, as you heard, is such an integral part. You need to learn it. You need to learn it properly. In trauma, when you're communicating with colleagues, try to conform to this simple acronym at MR. A is age of your child or your patient. Time is, T is the time of injury. M is the mechanism of injury. So time of injury, mechanism of injury, details which are absolutely essential for ongoing care, and maybe details which might save a life, reduce morbidity. It is all elicited by you the first contact, the junior doctor. So please make it a habit to get these things right in the first go. Injuries that you have found so far in your examination and clinical assessment. The signs of initial presentation or the objective parameters such as the vital signs, the heart rate, the blood pressure, the respiratory rate, the SpO2 and the temperature. All this must be documented and checked. Estimated time if you are going to transfer this child from your center to another center. And if you need to ask for assistance from other people, you need to tell the person you're communicating what you have asked. And please, again, coming back to the importance of communication, coming back to the notion of being empathetic, coming back to the notion of being truthful. In pediatric practice, remember when you're managing a child, you also automatically need to be managing at least 2, 3, 4 other people, such as the terrified, anxious mother, the father, and sometimes extended families in Sri Lankan context, the grandparents, the aunts, the uncles. Keep them informed, be truthful, be empathetic, let them know what's going on. It is so important for you to understand this, because the day it happens to you, you'll realize the importance of it. So like everything else, we are concerned about picking up life-threatening injuries. We have to pick catastrophic hemorrhage because that is accentuating external hemorrhage, which we can see with the eyes. We need to fix it. We must be absolutely concerned about critically dynamic airways, which come about with inhalational injury and also any direct trauma over the neck, because it can cause expanding hematomas and compromise the airway patency in front of your eyes. So you need to electively intubate these children. Tension open pneumothoraces have to be decompressed. Hemothorax has to be estimated and blood products have to be replaced, and flail chest needs aggressive supportive care and management in the form of non-invasive or invasive ventilation with good attention to pain relief. Circulatory parameters, you have to be able to be one of those people who are absolutely paranoid about knowing what is the heart rate, what is the blood pressure, what is the heart rate, what is the blood pressure. What was it 2 minutes ago? What is it now? Be that person now, because it is imperative, especially in life-threatening injuries, that you know, that you document, and then you respond to these changes, which will save lives. May I repeat, save lives. Please ensure that you formally learn and practice on all patients that you see objective assessment of level of consciousness. Start practicing it even on people who are fully aware and conscious. Keep practicing it, GCS, AVPU, some way, and document. And learn a cursory focused neurological exam to pick certain changes you might see at the onset. Right, so hypothermia is a forgotten entity in sunny tropical paradise Sri Lanka, but let me reiterate that trauma patients in our country, which is a warm country, can become hypothermic, can propagate the lethal triad of coagulopathy, and can lead to death. So objectively assess, check core body temperature, and if it is low, please rewarm your patient actively. Volume resuscitation with blood and blood products is an important concept. Remember, tranexamic acid, 15 milligrams per kg, even in pediatric practice within the first 3 hours. Be cautious with the amount of crystalloids that you're going to use. Pre-warm it because that will negate creating hypothermia. 10 ml per kg is like the max, right? If you need more, you must think blood. So get on O-negative blood, and always volume is 10 ml per kilogram of blood. There is always this important thing called trauma-associated coagulopathy. We don't like it because it makes matters worse, but sometimes we contribute to it. So we should be very careful when we are managing patients, and especially when we are replacing blood and blood products. They must be warm to body temperature. They must be in this ratio of 1:1, that is 1 red cell unit for this child who is 40 kilos, which is 400 ml. to 1 unit of FFP, which is 15 ml per kg, which then means 600 ml. So when you are transfusing blood and blood product, it has to conform to this ratio system, 1:1:1. That's how you do it. You can go for point of care testing like blood gases. There is a big role of maintaining normal level of calcium level, because calcium is an important entity in coagulation. You have to treat hyperkalemia actively, because blood products sometimes profuse transfusion can push up the potassium level. You need to keep a tab on the hemoglobin level, and you need to keep those platelets above 100,000. So these are all very important concepts in clinical practice when you're managing trauma and replacing blood and blood products. There is a thing called a massive transfusion protocol, which you need to trigger with the blood bank, and they do all the hard work by sorting out all the blood and blood products into packages, and they keep sending it to you, and it is our duty to give it to the patient. And as an intern, as a junior clinical member of a trauma resuscitation team, this becomes a huge responsible job to liaise between the trauma team and the blood bank. And sometimes it may be you who takes on this responsible job. So understand the theory and the knowledge behind what we are doing. It is important. And in conclusion, remember, managing pediatric trauma is a team approach. And you, as junior intern medical officers, are an integral part in this whole management team. If you don't perform, whatever we do may not work for the patient in front of you. So remember, it is a question of putting all these things together, and cannot re-emphasize the importance of communication. So happy that I followed it up with an excellent talk on communication by the previous speaker. And may I reiterate, it's important, because when you're managing pediatrics, you are effectively managing more than 2 other people who need to be in the loop, who need to know what's going on. So don't ever forget it. Anybody wants to unmute and ask questions, you're more than welcome. Otherwise, that is the end of this talk. Anyone has questions? Can you ask? I don't know if you're permitted to ask questions, but I just love people who ask questions. So you're given a brief moment to unmute and ask any questions if you have burning questions. Okay, seems like no one has questions. That's fine with me. It's you who lose out, not me. And just to recap, so pediatric trauma is an entity. Children are subject to trauma, whatever age group it is. For us, it is a structured approach. We look for catastrophic external hemorrhage, which is obvious. We are concerned about cervical spine injuries, depending on the mechanism of injury. And we have to anticipate it, and we need to be cautious and take precautions and minimize mobility at the cervical spine. We need to, at the onset, support ventilation to ensure adequate oxygenation and removal of carbon dioxide. Trauma is always associated with bleeding, and bleeding needs to be controlled. And if there is bleeding, you need to objectively assess it, and you need to replace blood and blood products as early as possible. Disability is a term that reflects the level of consciousness and the functioning of the central and the autonomic and the peripheral nervous system. So you need to be aware of the problem to prevent further insult, because whatever that trauma caused to those systems as injury, you cannot undo, but you cannot afford to propagate the insult to the brain or the spinal cord. So you need to prevent secondary insult. And hypothermia and hypoglycemia, 2 things that seem very, very innocuous, but make a huge bearing in managing a trauma patient. You need to be absolutely concerned about this. Thank you very much. My lectures take a little more than time. My apologies for that. Very disappointed that nobody interacted with me, but you are more than welcome to visit emergency departments where emergency physicians are lead clinicians. We are happy to help, teach, and work on the floor with you.
Thank you very much, sir. Next lecture will be delivered by Dr. Sheila De Silva.
Oxygen matter.
Pulse volume?
Pulse volume is very low.
BP?
Blood pressure is about 70/40.
Heart rate?
Heart rate is there.
Miss, large book annual
The noises are becoming a bit bad. Oral air.
Saturation?
88.
With oxygen?
With oxygen 10 liters.
RBS
Shall we come a bit more quiet? So you see a lot of urticarial rash all over the body. That now that you have exposed the child.
This is anti-like so we should get.
Okay, so
saturation
noise is coming from the patient. Your time is now.
Miss, normal cell and bolus to classical.
Noises are becoming a little bit better after oil. Normal cell and bolus are hurry. 20 kg
bolus are classical. Bolus is
taking up.
Saturation 89. 92. Okay, continue number back.
3 now. 3. Capital 3. Pulse volume is better. It's moderate. Heart rate is there.
BP?
BP is blood pressure is coming there. No, that is all the coffee. Yeah, okay, this is the blood pressure. The noises are becoming less frequent.
Saturation is picking up 92.
Still noises are
Moving a little. Trying to push off.
It's something else from us.
Capital yes is
saturation බලන්න.
Left, front is high monitor.
Circulation.
High flow. 3, 6, okay.
Pulse volume.
Still moderate.
අපි දැන් විනාඩි 3ක් විතර ගිහලා අපි second IM adrenaline release කරා. කොයින්ද්‍රි IM adrenaline course කරනවා. අපි ආපහු reassess කරමු. Saturation.
He's here and he's already is a bit boiler. He's trying to push off the nasal bronch.
Look at the circulation balloon. Pulse volume.
It's better compared to previous.
Pulse BP.
Like 80%.
Okay, so that is improving now. अभी drip pack डालती हूँ full maintenance and no missile and drip pack डालती हूँ. इसके ने कैसे एक कोटा खोल दिया. Set खोल दिया. अभी आप हो रही है. Saturation.
Okay, I'm the ICU doctor. If you'd like to give me a summary.
Okay, so patient came with the cobra bite and areas already here and locality and then we was the anaphylaxis of low BP, perfusion was poor and we have given IMS in 2 doses and 1 normal cell as well and now maybe it's improving. Now saturation is with oxygen about 92 and BP also normal and perfusion wise capillary time also.
So the antivenom is removed or is still going in?
It's on the way.
We can restart
You want to restart. So have you given any specific treatment here? Any specific treatment given for the anaphylaxis?
I am actually.
That is all right. You didn't give a steroid. Okay, we will give the steroid and we will take over the patient to ICU.
Okay, thank you.
So now we will watch the video, very short video on cardiac arrest management.
Check the site frequently for signs of swelling and needle displacement or compartment syndrome. Intraosseous need in a critically ill child, allowing rapid administration of life-saving fluids and medications.
Got a 7-year-old male complaining of breathing problems while playing soccer. We started oxygen and an IV.
Get him onto the bed.
Vital signs were stable, but he started getting anxious and agitated as we pulled in, so I'm a little worried about him.
Tony, you're gonna be all right. Mommy's right here, honey.
Heart rate was about 110. His respiratory is about 30. Tony.
Okay, we need to move him fast. Let's move him on 3. 1, 2, 3. What's happening? Marcus, call the code and get the pediatric cart. He's not breathing.
Switch
I'll
the
give him
monitor.
breaths.
And leads attached.
What's happening? He's gonna be all right, isn't he? Dana, would you stay with Mrs. Porter, please?
Miss Porter, please step over here. Miss Porter, we can stay here. We just need to give the team room to work, okay? Now, it looks like Tony has stopped breathing, but the nurses are helping giving him breaths, okay?
I need to call my husband.
That's no problem. We have a feeling.
Okay, what have we got, Colleen?
A 7-year-old with breathing difficulty and became unresponsive and just stopped breathing. Just gave him 2 breaths and now I'm checking his pulse.
Okay, I'll take the lead. Can you help with crowd control, please?
You got it. Everyone but the code team, clear back.
During the resuscitation of an infant or child in cardiac arrest or respiratory failure, there are many tasks that must be performed by the resuscitation team in a short amount of time. A team leader or member can easily become overwhelmed. This is when good leadership and teamwork is most important. During the next few minutes, we're going to show you the elements of effective resuscitation team dynamics and explain how they can improve the quality of the resuscitation attempt. You should understand not only your role, but also the roles of the other members of your team. You'll see why correct performance of team roles and team behaviors is critical for optimal outcomes. To begin, open your provider manual to the section labeled Part 5. Locate the Effective Team Dynamics observation sheet, as well as the Summary of Team Roles page. Now we're going to follow the first few minutes of a simulated code. Using these pages for reference, we want you to pay close attention to the action, taking note of the way the team members interact and assume various roles. In a few minutes, your instructor will pause the video so you can discuss what you've observed.
I don't have a pulse.
Looks like VFib. Okay, Marcus, go ahead and attach the defibrillator pads, please. Sarah, start recording, please.
I'll begin recording now.
Attaching pads. Starting compression.
I'll ventilate.
2.
Roberta, could you use the resuscitation tape to determine this boy's approximate weight and then check the IV for me, please?
I'll get the tape and estimate his weight and then check the IV. The weight is 30 kilograms. I'll check the IV.
Okay, everybody, the weight is 30 kilograms. Colleen, on the compressions after we check the rhythm.
I'll be ready to take over compressions.
Okay, stop compressions and let's check the rhythm. Okay, we have VF. Prepare an unsynchronized shock of 2 joules per kilogram.
Okay, charging to 60 joules. Okay, I'm clear. You're clear. Everybody clear. Shock delivered.
Resuming CPR. 1, 2, 3.
Okay, Roberta, prepare epinephrine. I want 0.01 milligrams per kilogram. That's 0.3 milligrams IV in case we have a shockable ray or a systole on the next rhythm check. Double check the dose on the tape for me, please.
IV flushes well. I'll prepare epinephrine 0.3 milligrams.
Are you able to ventilate easily down there?
Yes, I'm getting good chest rise.
Okay, good job. We'll continue ventilating with the bag mask and we'll hold off on the intubation.
It's been 1 minute, 30 seconds since the shock.
Okay, everyone, we're going to check the rhythm in just a few seconds. If VF is still present, we're going to give 4 joules per kilogram. That's a 120 joules unsynchronized shock, and then we're going to switch compressors. Roberta, then you're going to go ahead and give the 3 milligrams epinephrine IV if the VF is still present. Is there any questions?
Wouldn't it be 0.3 milligrams epinephrine?
Oh, thank you. That's right. It's 0.3 milligrams IV epinephrine.
We're ready to switch.
I'll be ready to charge another 120 joules if another shock is needed.
0.3 milligrams IV of epinephrine ready.
Okay, stop CPR.
It's now been 2 minutes.
Okay, we have persistent VF. Marcus, give the 120 joules shock.
Joules. I'm clear, you're clear. Okay, everybody's clear. Shock delivered. Resuming compressions.
Okay, Roberta, go ahead and administer the 0.3 milligrams epinephrine IV.
Epinephrine 0.3.
Okay, right. So we have watched 2 videos. One basically a mock scenario, and other one which is a standard scenario that was happening in other countries. So what we have observed in these 2 scenario clips is the teamwork and how we work in a crisis situation. So there are a few slides here which we saw, and we find that the failure to resuscitate is basically due to knowledge and the skills of the healthcare workers. It is due to the human errors, what we call human errors. What do you mean by human errors? It's due to soft skills. So this is based on soft skills. We identified a new specialty or new specialty or then called crisis resource management. So what do you mean by crisis resource management? This was earlier highlighted by a person called Dr. Gaba, who is the anesthesiologist in US. And he actually, in his first paper, he pointed out, he highlighted 15 points of soft skills or human errors that can happen in a crisis situation. So out of these human errors, we will go through only few, which is very important in day-to-day practice. The first one is, I think, as interns, when you start working interns, you need to recognize whoever comes to the door, you have to recognize that now this is a very mild condition. But if you don't recognize that it's serious, probably the outcome will be poor. Then when you need to work, you need to select a leader. So probably the leader would be the most experienced person on the floor, maybe the SHO, maybe the middle grade, maybe the registrar, or maybe the consultant. Consultant, the team leader will have to stand at the foot end of the bed, the airway person and the airway doctor and the nurse here. And this is the assessment doctor, and this is monitoring, and this person is getting vascular access, and this is running up and down, and this is right. So this is how you had a position in a crisis situation. Then you need to think actively, you need to anticipate the issues, depending on the patient, what are the drugs needed, fluids, airway, and also the other resources that you need to mobilize. So you have to write down on the board what are the airway things and the circulation and the drugs that is needed for this particular patient. So the equipment plays a very important role in your crash cart. Rather than have this type of equipment, you have to make sure your equipment are well stored so that you can pull out at any moment during the crisis. Allocation of roles should be done depending on the team members present. And then depending on their competencies, you can allocate. So if you have somebody who's doing good in airway, then you can allocate airway. Somebody good in vascular access, vascular access, and so forth. So if somebody, one person is not happy with the role allotted, then he can always speak up and say, I'm not very comfortable of the role that is happening. Other thing is you need to call for help, because you don't wait until the late call for help, and then you might be in problem. So you need to call for help the moment you realize that you need the help. So calling for help early is not, don't underestimate, it's not incompetent. It shows, in fact, it shows you are a very competent and mature leader. So communication during crisis, we saw quite the number of communications that happen in both clips. So we have to advise in a situation like this crisis situation, closed loop communication. So you can go and read what is meant by closed loop communication. Then decision making is also a challenge during crisis situation. So always when you make decisions, you have to make decisions according to the findings, like, so you have to see airway, breathing, circulatory, and disability assessment. What have we done and what should be done, so that you can make rational decisions. Otherwise, it's become. So when you want to make hard decisions, you need to identify what the problem is, what are the options available, and what are we going. Who does what, which is very important, because sometimes we just yell, we just tell a lot of things into the air, but nobody does. So it's important that who does what, and then what happened, and what are we going to do about it at the end. And in a situation like this, there are things called fixation errors that can happen, and which adversely affect the patient's outcome. So what are these three fixation errors? The rush for decisions, because shortage of time, which may not work for that patient. And failure to ask for help or guidance is another fixation error. And failure to review is a fixation error. So these are the fixation errors that can happen in a crisis situation. So in the last slide, what is important is when you have a crisis situation, we have to appoint a leader. Team leadership is important. And situational monitoring, where this patient will be managed in the emergency unit, or in the casualty ward, or in the general ward, or the theater. And then mutual support, backup not doing anything, you can always fit in to the job that is being most demanded at that particular point. And you have to be adaptable. So you may have the work of a minor employee, sometimes work of another person. Communication is important, and team orientation towards the patient safety is important. So leadership, communication, situation management, mutual support, and on the outside circle is the performance, knowledge, skills, and attitude. So these are strategies for tools and enhance patient safety. Okay, so this comes to the end of the session today. End of the session. So what we'll be doing on the 4th, you'll be having a neonatal session, and after that we'll send in MCQ, online MCQ for you, and also feedback, and the Ministry of Health will issue a certificate after that. So thank you very much for joining for the last 2 days on pediatric module. So it's over to Roshan. Roshan, it's over to you.
Thank you very much, sir. As Sheila sir said, College of Pediatricians will register all the participants on the website of the College of Pediatricians. Am I right, sir?
Yes, yes, yes.
Right. There will be different evaluation questionnaire and plus the certificate issued by the College of Pediatricians, disregard of the Ministry of Health certificate. So everybody please log into the website and answer those MCQs and obtain the certificate which is issued by the College of Pediatricians. So that is one thing. So we are, as Sheila said, we are going to have an NLS program on 4th October. So thank you, Sheila sir, for organizing the program for today and yesterday. We conclude today's program. Monday we are having internal medicine. So do join by 8 a.m. or rather 7:45 for the sessions. We will share on your groups the timetables. Thank you, Sheila sir, once again. Anything, sir, you want to mention?
No, I think it's important to follow all these lectures so that you get an idea how we should function, how you work once you start internship.
Yeah, other thing I want to mention is we are going to have a common practical skill book, which will incorporate College of Anesthesia and Pediatricians together. We will share that common practical book, but once we share on your emails, you can go to the nearest hospital, liaise with, meet the consultant in charge, anesthetist or the pediatrician, get those skills acquired, and I mean, practice those skills and get the signature on the book. So that is one thing on the practical sessions. You can go to the nearest base hospital or type A or type B hospitals, which is closer to you, where a consultant is available. So that's one thing I want to mention. So that we'll be sharing those practical books, skill books at the end of the sessions. Yeah, right. That's all. Yeah. Right. Thank you, everyone. Okay. Thank you, sir.
Okay. Thank you very much. So I think we'll meet on Monday morning. Next session. Yeah.
Thank you, sir. Thank you, Dr. Dishan from SLCP.
You're welcome.